Hello, hello, hello. IT, can you hear me? Hello, IT, can you hear me? Okay. Um, IT, if you could check whether the other panelists are online. Um, there is two panelists attending online. There is Xiomara Chavez attending online, as well as Mr. Francis Nkoka. If you can check if they're online and then you can promote them to panelists. Hi, Xiomara.
Hello, good morning.
Morning. Um, I don't see the guy from the World Bank, Mr. Francis. But
From?
the guy from the World Bank, Mr. Francis, he's not in the attendees list. Let me check again.
France or France?
Francis Nkoka.
Ah,
No, he is not online. But in any case, Frank is in the room, so he will present on his behalf.
okay.
Yeah, I'm not sure. I don't. I'm not sure if they can hear us, but at least IT can.
Okay, great.
Okay, so we wait.
la fièvre Lassa. Nous avons aujourd'hui l'honneur d'avoir des panélistes qui vont nous partager différentes expériences. Alors, pour commencer la session de présentation, nous avons Dr. Lilian Wambua de l'OMSA, l'Organisation mondiale de la santé animale, qui va débuter par sa présentation. Docteur Wambua, vous avez 10 minutes pour votre présentation. Je vous remercie.
Lillian, your microphone is off, by the way.
Good morning, everyone.
Morning, on vous entend.
Thank you. I'm going to present to you. I'm not sure why I'm echoing. Sorry, I will just check. I'm not sure.
Is it OK? Vous n'arrivez pas à partager? OK, it's OK. Nous
No, I
voyons.
am trying to stop the echo on my side. Good day, everyone. Yes, now the echo is gone.
OK.
If you can still hear me,
Yes.
I will share the presentation from my side now. Okay, colleagues, I will take you through my presentation. Will take less than 10 minutes, I hope. And the presentation is on breaking the cycle of Lassa fever and why we need the One Health approach. My name is Dr. Lilian Wambua, and I work for WOA as a Regional One Health Program Officer. It's a pleasure to join you from the World Organization for Animal Health. We call it WOA for short, OMSA in French and Spanish. WOA was founded in 1924, and it was initially called the OIE. And so many people know it as the OIE, although in 2022, we rebranded the organization and now it is abbreviated as WOHA. And it is an intergovernmental organization that basically enables us to promote the transparency on the animal health situation globally, and to help us also to improve the safety and safe trade of animals and animal products across the world. So in terms of our vision, WOA envisions providing leadership in global animal health governance and promoting animal health and welfare And we support several global goals. One of them is what I mentioned already, the safe and fair trade. And secondly is public health. The work of WOA supports public health in terms of uh, dealing with zoonosis and other public health threats that emerge from the animal source. We also promote global food security and food safety, as well as sustainable socioeconomic development. And how we do this, basically we are recognized as a standard setting body, and we also coordinate various global frameworks, including the One Health approach, to enable us to promote safe trade as well as public health and safe food. We also are engaged in building capacity, especially the capacity of the veterinary services, so that they can be able to offer quality veterinary services. And we're also engaged in facilitating collaboration. One of the key collaborations we facilitate is with what we call the quadripartite, which is a partnership between the World Health Organization, that is the WHO, the Food and Agriculture Organization of the United Nations, that is the FAO, as well as the United Nations Environment Program and WOHA. And together, these four organizations are called the quadripartite. And our partnership basically facilitates the global adoption of the One Health approach. In terms of Lassa fever, we see that its transmission cycle is actually a mixture of ecological, environment, and social-cultural factors. So the main reservoir, as we know, is the rodent. And the rodents basically spread this disease to human beings in various ways. One of the ways is via contaminated foods. So the rodents, when they contaminate the food and the same food is ingested by human beings, the human beings get the Lassa fever virus. Also, one of the other ways is that the rats also vertically transmit the viruses between themselves across species, various susceptible species of the rodents. And also the infected human beings are able to transmit the disease or the virus to other uninfected individuals through aerosols and other factors. And what's important to note is that this transmission cycle actually gets even more complicated because of the fact that the cycle can be perpetrated locally, but also can become an epidemic due to nosocomial infections. So when the infected individuals get sick and they go to hospital, various transmission factors can also come into play, which may promote the transmission within the hospital setup. Also, the infections may end up back into the environment through inappropriate disposal of infected hospital waste. For example, the inappropriate disposal of the syringes, infected syringes, and other hospital waste. And the same infection may also end up, in non-endemic areas due to international travel. So we see that a lot of factors are coming into play here. And this is why we say, because of the interplay between the rodents in the environment, as well as the human beings and various other factors in the hospital setting and also in the community setting, that we require really a One Health approach to prevent the spread of Lassa fever. Now, over to the One Health perspective, we know that Lassa fever is the transmission of Lassa fever is dependent on various risk factors. One of those is land degradation and land use changes. The reason this is important is because the more that land is degraded and the more that land use changes occur, it changes the habitat of the rodents, so that where perhaps the rodents used to be forest dwelling, now due to land degradation as well as changes in land use, they are forced to move towards human dwellings. The climate change is another big factor because it has a potential impact on the rodent densities. So we know that climate change can have an impact on global temperatures and also precipitation. And the more the high temperatures go and the higher the precipitation or the rainfall, it creates an appropriate environment or microenvironment for the rodent to breed and to increase in density, as well as also to spread to new areas where they never used to be found. Uncontrolled expansion of rural and urban settlements is a factor also that emanates from increased population, which we see all across our continent in various countries. So this uncontrolled, especially the uncontrolled expansion of the settlements, comes with a poor sanitary management as well as poor waste management. And because of the lack of this critical infrastructure for waste management and for drainages and various infrastructure, then we have the rodents breeding in increased densities close to the human dwellings. And lastly, we also have several sociocultural factors such as the hunting and consumption of rodents that increase not only Lassa fever spillover, but also other rodent-borne infections, for example, Bartonella infection, plague, and others. So the more we adopt a One Health perspective in the prevention of Lassa fever, it has the added advantage also of helping us to control other rodent-borne infections that may either have an impact on public health. And in promoting the One Health approach, it is an integrated approach that enables us to deal with diseases that occur at the animal, human, and environment interface. A healthy environment promotes the health of both animals and humans. And this is why we say things that degrade the land or degrade the environment or bring about changes in the ecosystem itself will end up affecting also our animal health and our human health by promoting the spillover of pathogens across the interface. And so the One Health approach promotes collaboration, communication,
1 minute.
as well as coordination between disciplines. And moreover, it also enables us to adopt a whole of government and whole of society approach, whereby we also involve the rural communities, the urban communities, in and the civil society in controlling various diseases. This figure here shows us the importance of undertaking a One Health perspective. When we look at the various thematic areas of One Health, we see that it involves enhancing One Health capacities to strengthen health systems. We also want to reduce the risks from zoonotic or neglected tropical diseases such as Lassa fever. there is also a thematic area on food safety, for which it is relevant to Lassa fever, as well as curbing the silent pandemic of antimicrobial resistance and integrating environment into One Health. So looking at all these thematic areas, we are able to appreciate that Lassa fever really will need a One Health perspective in terms of capacity building, in terms of looking at the environment health and controlling the disease through the vectors, in this case, the rodents. I wish to stop here and hope that this lays basis for the subsequent presentations that will show us why we require a One Health approach in Lassa fever prevention. Thank you very much, and over to you, Chair.
Merci, Dr. Lians. Merci beaucoup pour cette présentation fort intéressante. Alors, nous allons sans plus tarder passer la parole, je ne sais pas si c'est prêt là-bas, au niveau de la présentation de la Côte d'Ivoire. Dr. Ouattara Duyeri de la Direction des services vétérinaires de Côte d'Ivoire. OK, la présentation de Dr. Ouattara. Sinon, on passe à Dr. Daniel, si ce n'est pas prêt. Oui. Il est là, il est Dr. Ouattara, il est là, le panéliste. On a donné à Ousmane. C'est pas encore prêt? C'est bon? Vous avez celle de Daniel? Docteur Ouattara, il a donné sa présentation. À défaut, si ce n'est pas prêt, on peut commencer avec la présentation du Nigeria. OK. On perd du temps. OK. Docteur Ouattara, de la Direction des services vétérinaires de Côte d'Ivoire, vous avez la parole. Attends.
Ok, merci. Je suis docteur Ouattara Douyeri Thierry. Je suis chef du service de la surveillance et de la riposte au niveau de la direction des services vétérinaires. où il y a eu des cas, comme par exemple où les études ont montré qu'il y a eu la circulation du virus. Diapo. En plus de cela, nous avions plus ou moins, pour continuer avec la sensibilisation, nous avions mis en place encore une équipe pour élaborer des messages à travers des documents que Ebo Sushi avait produits en son temps. Donc, Ebo Sushi a mis en place euh, des documents, des fiches techniques, des messages, des choses que nous avons plus ou moins adaptées en Côte d'Ivoire pour contextualiser. Et pour ce faire, nous avions impliqué, par exemple, les traducteurs nationaux en Côte d'Ivoire, ceux qui font le journal télévisé en langue nationale, qui ont été impliqués. Donc, ils ont été impliqués à l'élaboration des messages. Dans un premier temps, pour qu'ils comprennent bien l'enjeu, nous avons fait une présentation du virus, des signes cliniques chez l'homme et autres, l'épidémiologie du virus, pour qu'ils comprennent bien. Après cela, nous avions mis en place des petits groupes, ce qui nous a permis d'élaborer des messages avec ces personnes-là qui sont dans la communauté. Donc, à travers voilà, leurs expériences et autres, ça nous a plus ou moins permis d'adapter ces messages-là aux communautés pour que voilà, ces communautés acceptent bien ces messages. Donc, à la fin, nous nous sommes retrouvés à faire 3 messages en langue. Nous avons fait d'abord un message générique que nous avons traduit en 3 langues nationales, par exemple, 3 langues locales, le sénoufo, le baoulé et puis le malinké. Donc, généralement, cette langue-là, le choix s'est fait en fonction de la zone à risque. De plus, nous avions ajouté le français. En plus de cela, nous avons élaboré aussi des affiches. Voilà, vous voyez par exemple un exemple sur la fièvre de Lassa. Et cette affiche a été faite aussi selon une approche, une seule santé. Voilà, nous avions impliqué le groupe de travail technique, communication et changement de comportement. Nous avions impliqué encore les traducteurs en langue locale et autres pour dire que ici, nous avons pris en compte l'approche holistique et interdisciplinaire pour pouvoir élaborer ces messages. Pour continuer, nous avions eu diapo. Par la suite, dans le cadre de la mise en œuvre de ce protocole, nous avons eu des acquisitions aussi par le biais du projet Ebo Sushi. Donc là, nous avons acquis des pièges pour la capture des rongeurs. Parce que dans le protocole, nous voulons faire 2 types de surveillance. Une surveillance active au niveau des rongeurs. À partir du moment où on a des cas de circulation du virus, nous allons aller maintenant vers les populations pour faire une surveillance, pour voir s'il n'y a pas de lien ou bien il n'y a pas d'interaction entre la circulation du virus au niveau des rongeurs et chez les hommes. Bon, ce qui va nous permettre plus ou moins de mettre en place des mesures appropriées dans ces communautés-là. Donc ici, on vous a plus ou moins listé le matériel que nous avons déjà acquis. Donc actuellement, au Diapo, nous sommes plus ou moins dans la mise en œuvre de ce protocole-là. Donc ce que nous pouvons retenir ici, c'est que l'implication des leaders communautaires, c'est-à-dire les traducteurs en langue locale, par exemple de la télévision nationale, qui sont bien connus de tous, nous a permis plus ou moins de mieux adapter les messages, améliorer leur compréhension pour que la population accepte, voilà, ou bien adhère à notre stratégie de lutte ou bien de surveillance. De plus, la collaboration interdisciplinaire multisectorielle avec tous les secteurs nous a permis plus ou moins d'avoir une approche holistique dans l'élaboration du protocole. Donc, ça a pris en compte tous les aspects faune sauvage, aspects santé animale, santé humaine. Voilà. Et pour terminer, l'analyse sérologique combinée à tout ce que nous voulons faire comme recherche active nous permettra plus ou moins de disposer d'informations pour améliorer la prise de décision. Donc, comme on le dit, on n'a pas eu d'épidémie, on a eu des traces du virus par-ci, par-là, mais il faut vraiment qu'on ait une situation voilà, une situation qui pourra nous permettre plus ou moins de mettre en place une stratégie qui sera appropriée à la situation. Donc, comme je l'ai dit, contre perspective diapo, euh, nous sommes dans la mobilisation des ressources pour mettre en œuvre ce protocole d'accord. Dans un premier temps, nous avons élaboré une communication en Conseil des ministres, d'abord une note technique pour informer le gouvernement sur l'existence de ce protocole, ce qui nous a permis de mettre en place aussi une communication au Conseil des ministres avec le budget qu'il faut pour que l'État nous décaisse cet argent pour déjà commencer le travail. Dans un second temps, nous voulons plus ou moins renforcer les capacités des acteurs en termes de capture de rongeurs, voilà, et puis aussi de prélèvement et autres. Et puis pour terminer, c'est de mettre en œuvre ces mesures de surveillance active qui pourront plus ou moins nous donner une situation de référence sur quoi nous allons nous baser pour pouvoir mettre en œuvre ou bien mettre en place des mesures appropriées pour lutter contre la fièvre de Lassa. Donc, en conclusion, on peut dire que voilà, la Côte d'Ivoire a commencé à se préparer pour faire face à une quelconque épidémie de Lassa. Et pour ça, ce qu'on peut dire, une approche interdisciplinaire, multisectorielle est indispensable pour pouvoir mettre en place cela. Si ça se faisait seulement que dans ce secteur, ça allait être sectoriel et puis bon, peut-être que toutes les approches ne seraient pas plus ou moins prises en compte. Donc, ça, quand même, ça nous a permis de pouvoir mettre en place ce protocole multisectoriel que nous allons plus ou moins mettre en œuvre d'ici peu. Avant de terminer, je tiens à remercier Ebo Sushi, qui nous a vraiment appuyé pour la mise en œuvre de ce protocole. Et puis, tous ceux qui ont contribué à l'élaboration de ce protocole, pour citer les acteurs communautaires, les directions de santé, l'Office ivoirien des parcs et réserves, et puis le ministre aussi qui a porté le protocole au niveau du gouvernement. Merci pour votre attention.
Ok, merci à Dr. Ouattara qui est revenu sur l'expérience de la Côte d'Ivoire qui, sans avoir eu d'épidémie, travaille à la prévention en termes de renforcement des capacités de surveillance, dont la préparation du plan de surveillance intégré a fait l'objet d'une approche une seule santé et même une approche transdisciplinaire dans le cadre du partage d'informations, dans le cadre de la sensibilisation et qui a fait l'objet d'une communication en Conseil des ministres qui a eu l'accord du gouvernement pour pouvoir financer cette surveillance intégrée de l'ASA, bien qu'on n'ait pas de cas, mais on a des traces de circulation virale, des preuves de circulation virale, donc il faut renforcer la surveillance. Alors, sans plus tarder, je vais appeler à ce micro docteur Daniel du Nigeria pour nous partager l'expérience de son pays. Et la régie, si vous êtes prête, docteur Daniel, vous avez la parole.
Good morning, everybody. It's my pleasure to represent Nigeria here for this discussion. I am Dr. Daniel Okoma. I'm Assistant Director for One Health and Zoonosis with expertise in Lassa fever and Mpox. I work for the Veterinary Public Health Division of the Federal Ministry of Livestock Development, Nigeria. For starts, before now, we used to have the Federal Ministry of Agriculture, where you have livestock embedded in it. However, we didn't really used to have the kind of push and interest for animal disease control. So sometime in July of last year, July 9th, 2024, the president created the new ministry for Federal Ministry of Livestock Development. So without much ado, let's move into it. Can I continue?
Is it okay? La traduction, c'est bon? Ah, il y a un souci d'électricité. OK. Issue of electricity.
Okay.
Power.
Let's start over again when this time.
On va continuer en anglais. Bien parti. Your presentation is not too long.
No, even
It's okay for 10 minutes.
Yes, sir. I'll work with them. Let them start.
Okay.
I try to make it short.
Yes.
I summarize it.
Yes. Okay.
The history, questions.
Try to smile. You
Can explain that. Yes. Okay. Very sure. Yeah.
La régie, c'est bon? Is it okay? Okay, you can go.
Good morning again. Yes. Like I had said before, the name is Dr. Daniel Okoma from Nigeria, and I stand director with Zoonosis and One Health, with expertise in Lassa fever and Mpox. I work for the Veterinary Public Health Department of the Federal Ministry of Livestock Development. I'm here today to present on the topic Lassa fever, the experience of Nigeria. As a brief history, until last year, July 9th, the Federal Ministry of Livestock Development was part of the larger Ministry of Agriculture. And because of the interest in animal production and its GDP growth, we realized that the animal health component had to be really magnified. So there was that creation of the ministry. And here we are today with real focus and hoping that there will be major change in the control of Lassa fever in the country. So can we have the previous slide 4? Okay, then. Slide 2, okay. So as an outline for this discussion, we'll be looking at a brief overview, the background, and then the reservoir and transmission dynamics. We'll also be looking at the challenges in reservoir control. We'll look at what Nigeria has done regards the risk factors that amplify this spread. We'll also look at the current gaps in diagnostics and surveillance system, control strategies, One Health, and then we're looking at the way forward, and we'll conclude from there. Next, please. Next slide, please. As an overview, of course, Lassa fever is a viral hemorrhagic fever ailment, and it is very endemic in West Africa. It's zoonotic in nature, It's of course, it has that human component, which always gives us the reason to go back to the animal health component to start seeing how this thing came about. The presentation explores Nigeria's experience from an animal health and One Health perspective. As background, Nigeria as a country has a population of over 280 million people. And over 70% of this population are actively involved in farming. Now, as farmers, this 70% provide more than 90% of Nigeria's food. And then again, looking at that, we have serious issues in the agro-processing sector. We're looking at problems with infrastructure. We're looking at issues with funding. So most of the processing of these foods and storage is actually at local level. So this now would also exacerbate the spread of the disease. Next, please. Next slide. So for reservoir and transmission, the mastomys rodent sheds the virus in urines and droppings. Contamination of food and household items drives this transmission. So during a processing of the food, locally in Nigeria, most of these foods are being dried outside in the open. These rodents might infect it through urine and feces. Also in Nigeria, we have the issue of hunting. Major hunting challenges. Hunting is mostly a cultural thing. Most festivals we have hunting festivals that happen around there. And this also exposes the humans to these rodents. Agricultural practices influence the rodents-human interaction, where you're looking at bush burning and preparation of land for agricultural activities. In that process, most of these animals, their habitats are being altered, and then they now move into the human environment. So the sylvatic cycle is actually altered too. Let's move on to the challenges. The first major challenge would be the reservoir challenge, the challenge with reservoir control. So we're looking at poor rodent control in the rural areas. Don't forget that most of the rural communities have that challenge of hygiene. And so you have most of the rodents in that area. And that's where most of the food, the farming takes place, the subsistence farming. And we're also looking at issues where this exposure happens in that sylvatic cycle before it moves into the cities. We're looking at limited awareness on safe food storage. And that's where most of the issue is. Most of our farmers need orientation, they need sensitization and knowledge. Without knowledge, you cannot control this menace. It has persisted because most of them don't know what to do and how to go about it. So we're looking at traditional food processing methods that attract rodents. We could change that, and that narrative will change as well. Insufficient integration of the animal health surveillance in outbreak responses whenever we have these responses. So now let's look at also the risk factors that amplify this spread. Wildlife hunting and bushmeat consumption is a major risk factor. Food hygiene and processing practices, poor risk communication, especially to farmers and traders, poor sanitation in high burden areas, and gaps in surveillance at the animal-human interface. So with this, we now as a country had decided to step up our surveillance in the animal sector. So then we now said, we need to start trapping. You need to trap these animals and then do some assays to establish this virus in the rodents. So next, please, next. Next slide. Next slide, please. Okay. So for the animal trapping, for the animal trapping, the government has decided to go into active surveillance. This active surveillance will help in situations where we move in, going by the C-traps that are being put out there by the Nigeria Center for Disease Control. It indicates where we have these issues, and then there's an active animal surveillance. We move in there, we do trapping, and then we also check. We do the laboratory assays to establish this virus in the animals. We are also hoping that this situation can be included in our routine surveillance, where the animal surveillance is part of our routine, where we would now be picking up these cases from the rural areas. Let's move on to other situations, other challenges. Next slide. Okay, like there you have the laboratory analysis, like I had mentioned. Next slide, please. Okay, so what are the current gaps in diagnostics and the surveillance system? So here we have identified that we have weak laboratory capacity for early detection in animals. We look at limited field studies on rodent population dynamics, which calls for and begs for more research. Poor diagnostic support in rural health centers, and inadequate linkage between veterinary wildlife and human health laboratories. We can also note that mostly in our rural areas, the laboratory diagnosis in those areas are very, very poor. And then you now start realizing that in situations like that, where most of these cases actually start from the rural areas and then they now move to the urban areas. However, where they come up, surveillance is very poor and laboratory is also very poor in those areas. So it's hard to actually pick up these cases from the rural areas, and they only get to present themselves at urban areas and health facilities in the urban areas. So what are the control strategies? Next slide, please. Looking at from the animal health view, we are looking at community-based rodent control. We look at regulation of bushmeat hunting and trade. We want to strengthen food storage and processing hygiene. We're looking at serosurveillance scale-up and its integration into routine disease surveillance. We're also thinking of how to build capacity of veterinary field officers and also the para-veterinarians. This will actually help in improving capacity for surveillance and picking up of these diseases at the rural community level. Next slide. One Health coordination has also been very, very important in disease control. Looking at the multi-sectoral incident management system, which is being controlled at the NCDC, at that level, you actually have the animal health components alongside the human health and environment. Whenever there is any disease outbreak, they come together to see how they can address the situation. It has actually helped a whole lot. Now, we're looking at also joint risk communication strategies targeted at farmers, hunters, and food processors. In this situation, whenever we have these outbreak responses and we're in the field, you find out that we have come together to actually develop risk communication materials that speak directly to these farmers and also to the hunters, looking at them as major risk, at-risk populations. This actually has gone a lot way to help us in addressing this issue. And then also looking at cross-sectional training on outbreak investigations. If we only keep improving the strength of the human health components, it would not really help because we are only as strong as your weakest link. So we're also looking at strengthening training for the human health counterparts alongside animal health counterparts and the environmental health counterparts as well. Looking at research collaborations in rodent ecology, virus evolution and transmission pathways, it has become very expedient that we should look at researches and how to improve on research. Research would help a whole way to bring out the importance of this situation. Let us start picking up what are the changes, what are we looking at, what are the changes in the dynamics of this disease. Probably that is where the answer to this major issue is. Now, strategic priorities and future directions. What's the way forward? As a country, we're looking at launching a 5-year Lassa fever strategic plan for 2024 to 2028, incorporating animal health components to be really embedded in it. Next slide, please. We're looking at sustained funding for veterinary and wildlife surveillance. This is very key because if you don't strengthen the animal health surveillance area, especially the wildlife, a whole lot of cases are being lost in that area. That is where most of this situation comes in from, where you start having the animals at the sylvatic cycle breaking into the environment and then start causing these issues in the rural areas, which we start picking up at the urban areas. So we need to strengthen animal health surveillance, especially at the wildlife area areas. Then we need to also intensify farmer and community engagement on rodent proofing. We're looking at food processing. We're also looking at food storage. How do we proof them of rodents to safeguard and the food? Development of rapid diagnostic tests for both humans and animals. This is very key, especially when we're looking at surveillance at the field level. Rapid diagnostic kits can help to actually detect these cases at the level of the field. You don't have to start picking up cases like we had seen. The samples were taken from the field and sent to the laboratories. We could have an RDT kit at the field, and then you are checking those things, and you now make informed decisions, policy-making decisions at that level to know what you could do at that point. And then strengthening enforcement of food safety and wildlife trade regulations. We have had situations where these hunters, even when you have made policies that in areas where we are having the wildlife parks, don't go there to hunt. A lot of them have gone there, killed crocodiles, killed other animals, game animals, just for food. And we need to now strengthen policies to control these situations. In conclusion, a One Health approach is the most sustained pathway for Nigeria and the region. Lassa fever control requires integrated action on the human, animal, and environment interface. Reservoir control and improved food hygiene is very essential, as we can all agree. And enhanced risk communication, surveillance, and laboratory capacity will reduce the impact of this disease. Thank you very much. Thanks.
Thank you, Dr. Daniel. Merci beaucoup, Dr. Daniel. Nous allons procéder rapidement à 10 minutes d'échange relativement aux 3 présentations. Alors, nous allons prendre les 3 premières personnes qui voudraient poser des questions. Levez la main pour celles qui sont intéressées par les questions ou des commentaires. Allez-y. Allez-y.
Thank you very much for the speakers so far. From Cote d'Ivoire, I'm sorry, English.
So in the
absence of observed outbreaks and epidemics in the northern region of the Ivory Coast at the moment, is it worth being a bit more proactive in trying proactively going to those locations, mapping rodents and testing them using PCR or serology in advance of any outbreaks to guide future surveillance efforts? And then I have a shorter question for Dr. Daniel from Nigeria, and I'm amazed about the plan for active surveillance in rodents. Fantastic. Look forward to talk more about that in this, where they were looking at sort of long-term rodent control and its effects on Lassa. There's potentially some concerns about creating sort of like vacuums, so like removing rodents from villages, and households may draw in rodents from areas where they may rodent control. So doing the initial research during the surveillance would be amazing.
This is your name and your
And
institution.
then maybe in the future thinking about sort of control methods.
This is your
Doctoral researcher at Pennsylvania State University.
Thank you.
Thank you.
Thank you.
Thank you very much. Thank you very much for the beautiful presentation. I just want to ask that for the fact that I still continue to have land degradation, forestation, and so on, we expect more of them to continue to live with us. I just want to ask, to control vector, what is the role of rodenticides in terms of controlling reservoir? What is the benefit and other side effects of use of rodenticides to control vector population? Thank you.
La dernière personne ici.
Thank you very much. Thank you very much. Dr. Bubakar Waziri from Nigeria. To the counterparts from Cote d'Ivoire and Nigeria, I congratulate you both. The Nigerian counterpart did take the word from my mouth. Development of rapid diagnostic test kits at the human-animal interface. That's very strategic. The story of
The story of avian influenza is very recent.
Pathogens
Pathogens are beginning to jump
from one
from one host that is known
to a host or
to a host or ranges of hosts that were
It's
unknown.
also pertinent for us to
It's
start
also
looking in that
pertinent for us
direction
to start
for Lassa
looking in that direction
virus.
for Lassa fever virus.
Rodents are
Rodents
always
are
incriminated.
always
How
incriminated.
about other
How about
non-conventional
other
potential
non-conventional
reservoirs
potential
for this
reservoirs for this pathogen?
In my country, a lot of people
In my
keep
country,
cats,
a lot of people keep
and most of these
cats,
rodents are fed
and
to
most of these
cats.
rodents are fed to
Or
cats.
These cats are
Or
used
these cats are
in
used
the control of some of these
in the
rodents.
control of some of these
What
rodents.
efforts
What
are we
efforts
using or
are
looking
we
or implementing
using or looking at or
surveillance of
implementing
Lassa virus
in the
non-conventional
surveillance of Lassa virus in
reservoirs?
non-conventional reservoirs? Also,
The counterpart from Nigeria
the
talked
counterpart
about
from Nigeria talked about
proving
food
against
proving
rodents.
against
The
rodents.
question I think we should be
The
asking,
question I
if
think
it
we
has
should be
not been
asking,
asked,
if it has
is
not been
what is
asked,
the
is what is the environmental
of this
persistence
virus?
of this
Beyond the
virus?
food,
Beyond the food,
people can pick this virus
people can
from
pick this
non-food
virus
sources.
from non-food sources.
How many efforts or how much
How many efforts
are
or
we
how much
putting into
efforts
place
are we
in
putting into
understanding
place
the
in
environmental
understanding the
persistence of Lassa
environmental
virus, not
persistence
only in
of
Nigeria,
Lassa virus,
but
not
across
only in Nigeria,
countries
but
that
across
may want to look at the
countries
situation of Cote
that
d'Ivoire,
may want
that
to
they are
look at the situation
currently
of
doing
Cote
active
d'Ivoire,
surveillance, but not
that they are
considering
currently doing active surveillance,
non-food
but not
environmental
considering
sources of this
non-food
virus. Thank you.
environmental sources
Ok, merci
of this
beaucoup.
virus.
Nous allons passer la parole maintenant
Ok,
aux
merci.
panélistes. Merci beaucoup. Nous allons passer la parole maintenant aux panélistes. Ah, ok, je vous donne cette chance-là. On est limité dans le temps. Ok, je vous donne cette chance-là. On est limité dans le temps. Allez-y.
C'est gentil, merci. Thank you very much for all the speaker about this important session. The speaker show very clearly that for human being, the exposure, it's of course hunting. It's today, I would say, explaining 10 to 15% of our cases, but more importantly is more the exposure to the food, as Daniel from Nigeria was explaining. And we know that the rodents, notably the bastomies, are a pest for our farmers. And of course, they have an impact on the economy of the farmer because they are eating the food in the crop, for example, in the land, coming to eat the food in the storage. And I think that there is also one else is also about that. Is also finding solution with the farmer themselves to decrease this population of rodent in the land and the one that are coming to the storage. So I would like to also have the feedback from colleagues from Cote d'Ivoire, Nigeria, about how we engage more with the Ministry of Agriculture in charge of following the impact of the rodent as a pest for the agriculture, to decrease the population of the rat and increase the safety of the storage
Merci
of the
beaucoup.
grain, for
Question
example.
intéressante.
Thank you
Alors,
very
nous allons
much.
maintenant passer
Merci
la parole
beaucoup. Question intéressante.
différents présentants.
Alors,
Docteur
nous allons
Daniel, vous pouvez
maintenant
commencer.
passer la parole
Docteur Daniel, you have the
aux
floor.
différents présentants. Docteur Daniel, vous pouvez commencer. Docteur Daniel, you have the
Yes,
floor.
it's okay.
Right. Thank you
Yes,
so
it's
much
okay.
for the questions. Right. Thank you so much for the questions. There are a plethora of questions, but we'll start with those we can remember now. From David Simons. Yes. You had mentioned rodent control and the fact that if we decide to virtually clear off all these rodents, ecologically, there would be a gap which shouldn't be. The intent and the
the intention for this is not to clear off everything. However, in areas where you don't expect to see rodents, like in your food storage areas, in areas where you don't expect to see rodents, like in your processing areas, if you could have a rodent-free area there, say, but we're not proposing or advocating that you should move into the wild and clear all of them. No, we've accepted wild is. However, most of our industrialization activities and everything actually have gone into the same system, altered their ecosystem, and now they have no trying to these days. I know in other countries it's happening. In Nigeria, I mean, we are expanding. We are building large estates and industries, and we're moving into these places. What do you expect? The fight back coming. Then again, we are only advocating that let's have a rodent-free area where you are saying, okay, you're processing feed. The processing area should be rodent-free because that's where the risk, that's where it abounds. We're looking at storage. You can have a rodent-free storage area silo. That's what we're propagating. Let's have a safer area. If that answers that. Let's look at the food proofing. I think I think it was Dr. Baka. He talked about food proofing, which would be you're trying, like I still said, you're trying to protect your feed or your food from these rodents. That actually does stand. But however, your concern was other sources of infection. What are we doing about these things? That's where the risk communication comes into play. It's very key. We are doing risk communication. We're sensitizing these people. Most of them, in fact, most of them are our studies and researches, you find out that education is actually one of the major issues for the spread of this disease. People who are very exposed, people at risk, like the farmers, the hunters, and the rest of them, are not informed about this. So if we do proper risk communication and proper sensitization, we also address most of the other nosocomial and other routes of infection apart from food, which we seem to always want to focus on. I think that addresses that if it does. You could nod. Okay. And then, like you had mentioned, sir, you talked about rodents. How are we engaging farmers on the rodent control? How we intend to sensitize them and teach them how to go about rodent farmers' side of point of view. Now, in most of the countries, rodents from risk communication materials. The farmers' side of the point of view. We have flyers. Now, in most of the and in fact, we have flyers. Farmers have been targeted as main audience. So we've made it interesting. We've made it tutorial. We've actually been able to address that need so that they understand clearly at the farmer's point of view. The farmer is actually doing his crop production and processing. He moves on to actually store, hoping to sell this produce. And if we do not control it at that point, you can imagine the magnitude of spread we're going to have of this disease. So the farmer is very key for knowledge, to understand how to go about these things. Like I said, the risk communication is very, very key. And we've done a whole lot, and a whole lot is still being done. And then, of course, the risk communication is one health, more like one perspective when you have the human health counterparts, the animal health counterparts, and the environmental health all coming together to see how we can have a very effective risk communication. And let me leave some questions for my co-presenter.
Docteur, rapidement.
Ok, merci.
Merci.
Merci pour ces questions.
Pour revenir un peu à la situation de la Côte d'Ivoire, comme je l'ai dit, c'est basé sur des études que nous avons effectuées au niveau du terrain. Voilà, dans un premier temps, le docteur Kwadjo qui est ici, il va vous partager son étude. Par exemple, à Korogo, c'était sur des rongeurs que nous avons capturés. Et là, ça a montré plus ou moins la présence de mastomys. Donc, étant là, il va vous faire l'économie de cette situation-là tout à l'heure dans sa présentation. Par exemple, à Bangolo, là-bas, c'était
partie du sérum que l'Institut Pasteur a collecté de 2015 à 2018. Donc, c'était une étude rétrospective. À partir de là, nous avons détecté qu'un patient qui était mort déjà, il y a pratiquement à Bangolo, on a trouvé les traces du virus. Donc, c'est là qu'ils ont parlé, ils ont parlé du cas mortel comment on appelle, de Lassa à chose. Donc, c'était à travers une étude aussi que nous avons menée. Pour terminer avec la gestion des rongeurs, hein, ici, d'abord, le rongeur, il est nuisible. C'est vrai qu'il est nuisible, en même temps, il est très, très important pour la biodiversité. Contribue à l'amélioration du sol, il fait beaucoup de choses. Donc, ici, notre approche, selon ce que nous avons mis en place comme message, le comportement des populations face aux rongeurs. Par exemple, dans les maisons, pour empêcher l'apparition des rongeurs, il faut assainir son environnement. Il ne faut pas que la nourriture traîne. Il faut que autour des maisons, il y ait les herbes, tout ça soit plus ou moins nettoyé. Il faut fermer tout ce qui est cliché de rongeurs. Concernant les stocks d'aliments, il faut plus ou moins prendre en compte des dispositions pour pouvoir empêcher ces rongeurs-là d'y accéder. Voilà, donc ici, c'est une approche basée sur la participation effective de la population. Il faut que la population, là, c'est quoi le Lassa? Là, ils vont prendre des dispositions pour pouvoir plus ou moins éviter les rongeurs. On ne peut pas empêcher, on ne peut pas tuer les rongeurs comme il se doit avec tout ce qui est bien-être animal et autres, mais on peut plus ou moins
Ok, merci beaucoup. On est pris par le temps. Je pense que c'est des discussions très intéressantes qui suscitent beaucoup de questionnements, mais on doit aller à la deuxième
sur la
phase
connaissance de la maladie
des panélistes.
et
Vous
sur les
pouvez
mesures
échanger
de
après
prévention qu'il faut
avec les différents
éviter.
pris par le suite de la deuxième phase des panélistes. Vous pouvez échanger après avec les différents présentateurs pour approfondir différentes questions qui me paraissent vraiment. Dr. Daniel, thank you very much, thank you very much. Et nous allons appeler deux autres panélistes ici rapidement. Léonce, docteur Quadio, vous restez à votre place. Nous allons appeler docteur Frank Nkoka de la Sierra Leone. Yes, we can. Et puis docteur Ziomara Chavez qui va nous suivre en ligne. Docteur Frank, est-ce qu'il est là, docteur Frank? On nous a dit qu'il devait être là en présentiel. Sinon, nous allons continuer. Léon, tu seras le seul en présentiel et celui de l'OMSA fera sa présentation. Il est là? Photo de groupe? OK, venez pour la photo de groupe. Après la session, la photo, pas de groupe de femmes. Alors, docteur Léonce va commencer sa présentation. La régie est prête pour la présentation de docteur Léonce. Est prêt pour la présentation de docteur Léonce. Est prêt pour la présentation de docteur Léonce. Merci. On nous dit que Francis est en ligne, donc il fera aussi, juste après docteur Quadio Léonce, il fera sa présentation. C'est bon? OK,
C'est bon?
maintenant, docteur
OK,
Claudio
maintenant,
Léonce, vous
docteur
avez la parole.
Claudio Léonce, vous avez la parole.
Merci, monsieur le directeur. Je suis Léonce Kouadio, enseignant-chercheur au département de biologie animale de l'université Peleforo Coulibaly de Korogo, ici même en Côte d'Ivoire. Je suis par ailleurs chercheur associé au Elmos Institute for One Health en Allemagne, dont je suis le point focal au niveau de la Côte d'Ivoire, et aussi chercheur associé au Centre suisse de recherche scientifique. Alors, mon intervention va porter sur les points saillants de la recherche en Côte d'Ivoire relativement à la fièvre de Lassa. Alors, nous allons partir d'un contexte diapo. Le contexte de ces recherches que nous avons menées sont partis du fait que nous savons tous que la fièvre de Lassa est endémique dans une partie de l'Afrique de l'Ouest. Le virus a été détecté chez les rongeurs dans certains pays qui sont voisins aux nôtres. Et ajouté à cela, il y a le constat qui a été fait, c'est qu'il y a des données génomiques qui sont très limitées dans plusieurs pays, y compris la Côte d'Ivoire, mais aussi un sous-rapportage de probables cas qui serait dû à une faiblesse de nos systèmes de surveillance et de diagnostic. Alors, on pense que cela pourrait conduire au fait que le virus circulerait dans certaines zones qui sont proches des zones endémiques connues, mais qui ne sont pas détectées. Alors, diapo, ce qui fait que nous avons mené des études dont l'objectif principal était de conduire une étude compréhensive sur le virus de Lassa en Côte d'Ivoire. De façon spécifique, il s'est agi d'investiguer sur la circulation même de ce virus-là au niveau des rongeurs, notamment chez l'espèce de rongeur Mastomys natalensis, mais aussi de faire une caractérisation de ces souches qui circuleraient ici même en Côte d'Ivoire. Diapo. Alors, comme méthode, nous avons capturé des petits rongeurs en milieu rural, que ce soit à l'intérieur des concessions comme à l'extérieur, en utilisant des pièges Chairman. Nous avons pu collecter le sang et les organes majeurs de ces rongeurs qui ont été analysés par la technique PCR. Nous avons procédé aussi à l'identification moléculaire de ces espèces de petits mammifères que nous avons capturés, puis procéder pour les cas positifs au séquençage et à des analyses phylogénétiques. Diapo. Alors, deux principales études ont été menées. La première étude s'est déroulée dans 3 zones de la Côte d'Ivoire qui présentent des écosystèmes différents. Nous avons travaillé à l'ouest, à la frontière avec le Libéria, au bord de la forêt de Taï, au centre de la Côte d'Ivoire à Boaké et au nord de la Côte d'Ivoire dans la zone de Korogo. Nous avons pu investiguer dans 15 villages, ce qui nous a permis de capturer au total 254 rongeurs et 27 insectivores. Diapo. Alors, le travail au laboratoire nous a permis de détecter le virus de Lassa. Diapo. Chez 4 rongeurs de l'espèce Mastomys natalensis sur 18 qui ont été capturés dans un village au nord de la Côte d'Ivoire. Alors, des analyses phylogénétiques, il découle que les séquences de la Côte d'Ivoire sont dans le même clade que celles qui proviennent du Mali, détectées chez la même espèce de rongeurs, ainsi que celle qui a été trouvée chez la souche AV. Et ces mêmes analyses ont démontré que l'ancêtre commun récent des séquences obtenues au Mali et en Côte d'Ivoire ici circulerait depuis environ 90 ans. Alors, fort de ce premier résultat qui nous a permis de détecter le virus en circulation dans la zone nord de la Côte d'Ivoire, nous avons décidé de mener une seconde étude. Diapo. Cette seconde étude s'est focalisée uniquement que dans la partie nord de la Côte d'Ivoire. Nous avons travaillé sur un transect en partant de Korogo, qu'on peut appeler la zone épicentre, jusqu'à la frontière avec le Mali, jusqu'à Tengrela. Et donc, c'est là-bas que nous avons focalisé nos efforts. Nous avons visité au total 11 villages sur ce transect, ce qui nous a permis de détecter la présence du virus chez 18 rongeurs sur les 322 qui ont été capturés lors de cette étude. Diapo. Lorsque nous combinons les deux études la première et la seconde étude, nous avons pu capturer au total 467 mastomys sur les 573 petits mammifères qui ont été capturés, ce qui démontre que le mastomys est l'espèce la plus répandue, la plus endémique en milieu rural, ici en Côte d'Ivoire. Et 22 ont été trouvés positifs. Alors, nous avons pu obtenir le génome complet de 13 individus, ce qui nous a permis de faire des analyses phylogénétiques. Alors, de ces analyses phylogénétiques, il découle des constats. C'est que les séquences de la Côte d'Ivoire qui sont en rouge sont regroupées en deux clades. Nous avons un premier clade, celui qui est en haut, qui est constitué uniquement que des séquences de notre étude. Je rappelle que ça, c'est un zoom de l'arbre phylogénétique que nous avons fait pour vous montrer la partie qui nous intéressait. Alors, nous avons en haut la partie qui comprend les séquences de la Côte d'Ivoire et la séquence de la souche AV, sur laquelle je reviendrai tout à l'heure. Et tout à fait en bas, nous avons des séquences de la Côte d'Ivoire qui forment un même clade avec les séquences qui ont été trouvées au sud du Mali. Alors, juste pour rappel, le sud du Mali et le nord de la Côte d'Ivoire présentent le même faciès géographique, les mêmes populations, les mêmes habitudes. Alors, donc, revenant à la souche AV, qui est un peu plus haut, avec le premier clade de la Côte d'Ivoire, il s'agit d'une souche qui a été détectée chez un touriste allemand qui a voyagé successivement au Ghana, en Côte d'Ivoire et au Burkina Faso, et qui par la suite a été contaminé, a été transféré en Allemagne, et les résultats, malheureusement, elle est décédée, les résultats ont prouvé que c'était dû au virus de Lassa. Mais la littérature n'arrivait pas à situer où est-ce que cette personne avait pu contacter le virus de Lassa. Alors, le positionnement de cette souche dans le même clade que ce que nous avons trouvé dans la zone de Korogo renforce la thèse selon laquelle le patient aurait été infecté lors de son passage à Abidjan, parce que pour quitter le Ghana, passer par Korogo, fallait passer par Korogo pour aller au Burkina. Donc, nous pensons que c'est probablement lors de son transit à Korogo qu'il a dû s'infecter. Ce qui nous donne une idée encore plus poussée de cette souche. Diapo. Alors, nous avons aussi mené des études sérologiques, toujours dans le nord de la Côte d'Ivoire, une étude en milieu rural et une étude en milieu urbain. En milieu rural, c'est le premier village, là où nous avons détecté pour la première fois le virus chez les mastomys. Alors, nous avons obtenu une séroprévalence de 95% dans ce village. Et à Korogo, qui est la grande ville de la zone, qui est la zone urbaine, nous avons obtenu une séroprévalence de 38,54%. Diapo. Alors, ça, c'est une étude qui a été réalisée par une équipe de l'Institut Pasteur, qui a mené une étude rétrospective, comme Dr Ouattara l'a dit tout à l'heure, sur un échantillon de 268 sérums. Et ils ont pu détecter un cas positif dans la zone de Bangolo, qui, elle, est située à l'ouest de la Côte d'Ivoire. C'est un peu le ramassis des travaux qui ont été menés jusqu'à présent au niveau du virus de Lassa. Avant de conclure, Diapo, je voulais informer l'assistance de ce que la majorité des travaux que nous avons menés à l'époque, bon, le terrain a été fait ici en Côte d'Ivoire, mais le côté laboratoire a été fait entre la Côte d'Ivoire et l'Allemagne. Mais depuis peu avec... ah oui, j'ai sauté la conclusion, j'y reviendrai. Depuis peu avec nos partenaires allemands qui sont le Robert Koch Institute de Berlin et le Helmholtz Institute for One Health aussi en Allemagne, nous avons un laboratoire de biologie moléculaire flambant neuf, qui est bien équipé, qui nous permet de travailler depuis l'extraction jusqu'au séquençage à haut débit. Alors, c'est l'opportunité pour nous de déclarer que nous sommes ouverts à toutes sortes de collaborations, mais encore aux organismes qui sont présents ici. Nous sommes un laboratoire qui est encore neuf, qui est encore bébé. Alors, nous sommes disposés à toute formation qui irait dans le sens du renforcement et de capacité des acteurs qui sont dans ce laboratoire afin d'améliorer les rendements des travaux qui sortiront de ce laboratoire, mais aussi de renforcer aussi le plateau technique de ce laboratoire. Merci, c'était juste la parenthèse. Alors, pour conclure, cette étude a révélé la première mise en évidence génomique du virus de Lassa au nord de la Côte d'Ivoire. Et de là, il découlerait qu'il y ait probablement une circulation de ce virus, mais qui passerait sans être détecté, probablement dû à nos faiblesses de capacité de diagnostic et de surveillance. Il est alors nécessaire de mener une surveillance génomique aussi transfrontalière afin de surveiller la circulation de ce virus-là. Et quand on combine les résultats que nous avons obtenus chez les rongeurs et chez les humains, la conclusion finale que nous pourrons tirer, c'est que la fièvre de Lassa est un potentiel problème de santé en Côte d'Ivoire. Voilà, c'est sur ces mots que je voulais terminer diapo en remerciant déjà toutes les institutions qui ont participé à l'élaboration de ce projet. Ah oui, c'est vrai. Les recommandations, il s'agirait d'étendre cette étude à d'autres régions de la Côte d'Ivoire, principalement aux régions frontalières avec les autres pays où le virus circulerait aussi, mais aussi améliorer la surveillance génomique et en faire renforcer la capacité des structures de surveillance de la Côte d'Ivoire. Donc, sur ce, je termine en disant merci à toutes les structures qui ont contribué à la réalisation de cette étude et merci à vous pour votre attention. Merci.
Merci, Dr. Léonce Quadio. Nous allons sans plus tarder passer à Dr. Francis, qui est en ligne. Francis Unkoka, qui est en ligne. La régie. Francis, vous pouvez partager votre écran.
All right. I hope you can hear me. My presentation is clear. Yeah? All right. Is my presentation visible?
Là-bas, on voit. Et puis, OK. We can see your presentation there, but not on the screen here.
Okay. I have shared the presentation with the
On va y aller. Okay, you can go, Francis.
Okay.
Okay,
All
it's
right.
okay. 10 minutes, please.
Thank you so much. I apologize, I can't be there in person. I'll share the urban prevention of other fever, the experience from region. I don't know what is happening, but I hear myself, so it's echoing too much. I don't know, but I'll proceed. Experience from Sierra Leone, the major issue we have is rapid and planned and urbanization that create ideal condition for Lassa fever, primary various carrier to thrive near human population. I think when you understand what is happening in Sierra Leone, you can see in the picture there, the Sierra Leone's own climate risk assessment flags high urban population densities, rapid and planned urban growth, and inadequate housing as the main drivers of the disease outbreak. When we look from the buildings, development, everything else, everything is pushing towards the thriving the condition for the rodents to grow, to spray, and be found everywhere. What we have seen is the overcrowding of shared wash services. We are talking about public toilets and all that. Poor solid waste management, poor fiscal and sludge management, recurrent flooding,
increase the risk of environment contamination that attracts rodents and complicate the hygiene behavior needed to reduce the spread of Lassa fever. When we look at the history in Sierra Leone, the three cities of Kenema, Bo, Kailahan are the ones where Lassa fever was previously recorded. And when you look at these cities, these are the cities where all these conditions I've highlighted above are prevalent. And this also, when you combine this with the incomplete infection prevention and control, now you allow that the spreading goes beyond uncontrollable. And that's what we're doing under the Resilient Urban Sierra Leone project, where we are combining solid waste management, neighborhood upgrading, and enhancing the emergency response capacity for Sierra Leone, that they can be able to manage this risk from the different perspective. Now, when we look at the emergency response capacities in Sierra Leone, there is a weak emergency coordination, poor operation, and preparedness, and this affects how the government and other agencies, how they respond to the different emergencies, be it natural disasters or health emergencies. Under the project I've highlighted, we are supporting government to enhance their capacity for emergency preparedness and response, so that they can be more prepared when a disaster or an emergency is to occur, but they can also have capacity to quickly respond when a disaster has happened. And this is where the public health agency and the disaster management agency work together. And through the another operation, we are supporting to strengthen that coordination of the disaster management agency and the public health agency, that they can work together. And we are supporting them to ensure that the standard operating procedures for emergency management in Sierra Leone are reconciled and work together, that they can be able to respond when a disaster has occurred. But one of the ways we think is critical, as it has been already presented by the previous speakers, is the improvement of solid waste management in Sierra Leone. This is one of the major problem in Sierra Leone. It could be also a problem in other Western West countries, Africa West countries. We see a lot of unconnected wastes and sanitary dumping of the waste, and this is happening quite a lot in the urban areas, and it provides a conducive environment for the spreading and the multiplication of the loadings, and through the LASUP, the Resilient Urban Sierra Leone project, we are developing a national solid waste management strategy to strengthen the institutions, to come up with better plans on how to manage the solid waste, but also to find ways on how the secondary cities and even Freetown can raise adequate resources for solid waste management. Our primary assessment of the of solid waste management needs in Sierra Leone, we discovered that there is low waste collection coverage. Only 30% of the waste is collected, leaving much of the waste unattended to and dumped anyhow. We are seeing that there is open dumping, There is unregulated scavenging, and that is informal pickers, which facilitate the spread of the problem.
Francis,
But we
please,
also,
you don't say next slide. You have 4 slides, but it's
yes.
only one slide. If you have finished one part, you can say next for the
Okay. Sorry.
technical. Okay.
Can you go to the third slide? Okay. Yeah. On this slide, my apologies. I thought I'm the one controlling the presentation. So what I was saying here is, we have done the needs assessment in Sierra Leone on the solid waste management, and our observation is there is low waste collection, there is open dumping, informal waste pickers that are engaging with all the location where the waste is being dumped, and there's a need for the strategy to close these gaps by defining saving standards, strengthening the municipal capacity, and mobilizing investment for modern and resilient solid waste management system. And that's what we are doing in Sierra Leone to help them manage the conducive environment for rodents that are carriers for Lassa fever. Can we go to the next slide, please? Thank you. So this is the last slide. So apart from improving the solid waste management, we also need to improve water and sanitation services in informal cities. In Sierra Leone, we're working in three secondary cities, or three neighborhoods. That is the Moiba, Coconut Farm, and Port, and mainly where we are supporting in water and the sanitation services. These neighborhoods are limited in so many areas, which is very common to all other cities and the neighborhood in Sierra Leone. So only 45% of the residents living in this neighborhood live within 500 meters of functional water kiosk. Most of the waste in these neighborhoods are either burnt or dumped, not in a proper location, but dumped anywhere. Over 80% rely on communal pit latrines, with open defecation still widespread. And this, if you look at this, these are conditions that facilitate multiplication of the rodents, because we are creating an environment that is good for them. And what we are doing under the project, we are expanding reliable water access and protecting sources from the contamination. So we are doing a lot of wash investment to help this neighborhood they can be free from contamination. We are building public toilets to curb defecation, because this is one of the biggest problems that they're experiencing. But we are also enhancing waste collection and preventing refuse from clogging the drains, because most of the waterways and drains are clogged by the waste that are not properly dumped. So we are enhancing the practice of waste collection, and these are the efforts that we are thinking, and we are working with the government of Sierra Leone, that by doing this, the conditions that are suitable rodent multiplication and the spread of Lassa fever could be reduced, and thereby reducing the spread of the disease. In a situation that the disease still is spreading, then we are also enhancing the capacity of the government that they can be able to manage emergencies in case of the health emergencies. We have resources under the DPO with Katido that in case of any health emergency, the government can activate the Katido to provide resources for emergency response. So these are the
Thank you,
experiences and
Francis.
perspectives for
Time
Sierra
is
Leone.
up.
Thank you.
Thank
Yeah,
you.
thank you.
Merci beaucoup. Nous allons passer à la présentation, à la dernière présentation. Docteur Xiomara Chavez de l'Organisation mondiale de la santé animale. Docteur Xiomara Chavez, si vous nous entendez, vous avez 10 minutes exactement. Nous sommes en retard et il y a une présentation plénière ici. Et donc, il faut qu'on respecte le time. On a débordé déjà de plus de 15 minutes. Docteur, vous avez la parole.
Thank you very much. Merci beaucoup. So now I'm going to share my screen to start with the presentation. Can everybody see my screen?
Yes.
Perfect. Thank you very much. Thank you for this invitation. And well, my name is Xiomara Chavez. I work at the World Organization for Animal Health at the Capacity Building Department as the Workforce Development Program Project Manager. And I will be presenting today pretty much the importance of the community-based One Health approach for Lassa fever prevention. So first, Lassa fever versus One Health. We all know what One Health is, right? The One Health approach recognizes that human, animal, and environmental health are interconnected. And Lassa fever is a perfect example. It's carried by rodents, it spreads in households and farms, and has devastating impact on human health. So prevention cannot rely on one actor alone. It needs an integrated action. And I wanted to present here just two examples, one from Liberia, one from Nigeria, that I found online. And the commonality here is that we see that the community is engaged, it's involved, right? So this is where we're aiming today. So why a community-based One Health approach is essential? You know, Lassa transmission is driven by rodent infestations, poor sanitation, and unsafe food storage. So these are issues that communities can directly act on. They can clean surroundings, they can rodent-proof homes, and report early symptoms, for example. So a One Health approach allows us to combine medical, veterinary, and environmental expertise in ways that are relevant and practical at a local level. So in this slide, for example, I wanted to share with you on the top of the slide an extract of a publication made by Abdullahi on Lassa fever and the importance of local community engagement. And in the bottom, you'll find also a case study from Benue State, which is among Nigeria's highest burden states. So in 2024, the state reported 1,051 suspected cases and 67 confirmed cases of Lassa fever. And as of August 10th, 2025, it was only 155 suspected cases and 14 confirmed cases reported. So how did this happen? Actually, what happened is that 91 community volunteers and health workers were trained in 45 high-risk areas. And what did they do? They delivered messages in markets, in worship places, and homes to promote rodent-proof storage, sanitation, and early treatment seeking. So, resources to support prevention of Lassa fever. What can we as WOAC can do from our front? I wanted to introduce you to the competency and curriculum guidelines for community animal health workers. This document has been published last year. And well, you can have a look at it online. It's open source. In this document, you'll find a Model 10. We have 11 models in total, but Model 10 is about engaging with the community. All in all, this curriculum for CHWs, it's divided into core competencies and additional competencies. So I believe that for Lassa prevention, engaging with the community, it's important, of course, and you will find specific competencies here to support either the new development or the adaptation to existing curricula in different countries. But not only the Model 10, we can also find different models addressing disease prevention, disease detection. So I really invite you to have a look at it. And also, WUA has worked with FAO and WHO to release a coffee framework. So this coffee framework is it aims to define essential competencies across human, animal, and environmental health sectors. So in this case, domain 12, which is communication and community engagement, it highlights the importance of high-risk communication, building trust, and involving communities in decision-making. I think that the commonality of both documents is that they highlight the importance of using clear and trusted communication channels, such as community leaders or animal health workers, in order to share prevention advice. And it also means listening to the communities by collecting feedback on, for example, local beliefs or barriers. So for Lassa, this can translate into effective rodent proofing campaigns, better food storage habits, and faster reporting of symptoms. So it's essentially, it's all about turning communities into partners and not just recipients of information. So how can these resources be used by countries that need them? First and foremost, these are guidelines. These are not standards. So countries are free to use them or not according to their legal and regulatory frameworks. But how can they use it? So first, I think it's for standardized training. Countries can adapt either their existing guidelines or develop new ones to ensure that community animal health workers are trained to a minimum globally recognized standard. Number two, fill workforce gaps. Rural and underserved areas often lack veterinarians or health staff, so CHWs trained under these guidelines can extend reach. Then integrate into One Health. So by using models on disease recognition, community engagement, or food safety, COS can directly support early detection and prevention of zoonotic threats like Lassa fever and promote consistency across regions. So
3 minutes, please.
Countries in West Africa, where Lassa is endemic, could align their training, enabling cross-border collaboration and mutual recognition of skills. So who should champion the use of these guidelines? For the guidelines to make a difference, it's very important to involve at a national level, ministries of health, agriculture, and environment that could formally adopt and finance them following the national legislation and regulation framework. Regional and international bodies can help harmonize training across border and provide technical support. But equally important are NGOs, civil society, and local leaders because they are the ones that can ensure communities trust and embrace the role of CHWs. So all in all, the takeaway message, I think that there are three clear roles that CHWs can do. Surveillance and early warning, meaning reporting unusual rodent activity or livestock illnesses. Community engagement and education, teaching households how to store food safely, maintain hygiene, and avoid rodent exposure. And coordination with human health teams, referring suspicious human cases for rapid diagnosis and care. How can they do it? Educating communities, working with other trusted local channels, implementing two-way communication, meaning from CHW to community and the other way around, and establishing real-time risk communication systems for early alerts on suspected cases. So why all this? The main objective, I think, is to gather the important resources or documentation for a proper trained workforce, either existing or new trained workforce, for an empowered community, and all in all to reduce transmission, in this case, Lassa fever or any other zoonotic disease. This is the end of my presentation. Thank you very much. And if you have any comments or questions, please feel free to contact me. Thank you.
Merci beaucoup. Thank you very much. Merci pour cette présentation. Nous sommes pris dans le temps, donc nous n'allons pas procéder aux échanges parce que la plénière doit commencer. Et je voudrais, sur ces propos, vraiment remercier tous ceux qui ont fait des présentations très importantes, qui ont mis en lumière l'importance de l'approche One Health dans la gestion, dans le contrôle et dans la prévention de la fièvre Lassa. Vous voyez, chaque présentation a sorti un pan essentiel, notamment la connaissance du virus, les réservoirs, l'importance de l'urbanisation galopante et l'implication l'engagement des communautés, mais aussi surtout le secteur de l'agriculture pour la gestion aussi et l'hygiène en matière de traitement de la nourriture. Alors, donc sans plus tarder, nous allons vous remercier chacun pour votre participation et céder la place aux prochaines étapes du programme. Merci beaucoup et à bientôt.
Ouais.
J'ai plein de papiers. Ouais, tu partir avec. Donc finalement, tu peux aller avec ça. Bonjour, mesdames et messieurs. Nous allons reprendre les travaux avec une nouvelle session plénière. J'espère que la pause café, pause thé ou pause santé a été très bien accueillie et que vous avez repris des forces pour qu'on puisse poursuivre les travaux. Prenez séance, s'il vous plaît. Pour ceux qui parlent anglais et portugais, je vous encourage à porter vos écouteurs. Le canal 1 pour le français, canal 2 pour l'anglais et le canal 3 pour le portugais. Notre session après la pause s'intitule « De la détection à la réponse. Comment repenser l'architecture de la surveillance des fièvres hémorragiques ?» Nous aurons, durant cette session, trois temps. Le premier temps sera une présentation inaugurale pour planter le décor. Ensuite, les panélistes prendront place sur l'estrade. Je leur poserai des questions. Et ensuite, après le troisième temps, sera un échange avec les congressistes que vous êtes. Donc, je vais appeler le premier intervenant qui va faire la conférence inaugurale, la présentation inaugurale. L'objectif de cette présentation, c'est vraiment d'examiner comment l'Afrique de l'Ouest peut réimaginer, réinventer et renforcer son architecture de surveillance des fièvres hémorragiques virales. Comme vous le savez, nous avons dans notre sous-région de nombreuses fièvres hémorragiques qui sont souvent sous forme quelquefois endémiques, mais très souvent épidémiques, qui apparaissent ça et là dans notre sous-région. Nous devons avoir une architecture qui va nous permettre à la fois d'intégrer tous les systèmes d'alerte précoce, y compris les systèmes d'alerte précoce communautaires, les réseaux de laboratoires pour un bon diagnostic, mais aussi de plus en plus une plateforme génomique. Donc, je vais appeler à cette tribune le docteur Ibrahim Socéfal, directeur de l'Institut Pasteur de Dakar. Mais avant d'être directeur de l'Institut Pasteur de Dakar, il a eu une longue carrière internationale. Pour ceux qui le connaissent, le reconnaissent toujours comme étant celui qui est à l'OMS, s'occupait des urgences, pour ceux qui le connaissent. Donc, mais je n'ai pas fini. Oui, oui. Attends. Oui, parce que son CV ne tient pas en une page. Il a un CV qui est long comme le bras. J'essaie de le raccourcir pour vous le donner. Et il est, bien sûr, un médecin épidémiologiste de renom. Il a fait de nouveaux travaux scientifiques sur les urgences, sur la surveillance, et il est reconnu dans la discipline comme quelqu'un de très compétent. Mais il a été aussi directeur au niveau global, c'est-à-dire de l'OMS, des maladies tropicales négligées. C'est quelqu'un qui a une grande expérience dans les fièvres hémorragiques, notamment dans la fièvre jaune, dans laquelle il s'est beaucoup investi et a fait le programme de vaccination de la fièvre jaune. Donc, je vous demande aujourd'hui d'accueillir le docteur Ibrahim Socéfal. Je vais vous laisser le pupitre pour votre présentation. Donc, on va écouter le docteur Ibrahim Socéfal et après, je prendrai la parole pour la suite. Vous avez le pupitre.
Merci, professeur. Bonjour, good morning. I have the option to speak in English, French, or Wolof. You have to choose. Hein? Bambara? No, Malinke. Okay. So I will switch between French and English. Merci beaucoup, professeur, pour cette introduction. C'est un énorme plaisir d'être avec vous aujourd'hui. Donc, en tant que CEO de l'Institut Pasteur, mais aussi, comme vous l'avez dit, j'ai dans cette salle beaucoup de mes anciens collègues qui étaient dans mes équipes à l'OMS en Afrique et dans le monde. Et c'est un sujet qui m'intéresse particulièrement, comme vous le savez. Et j'essayais de faire référence aussi bien du travail fait par l'OMS, mais aussi de ce que fait l'Institut Pasteur en ce moment. Next. Est-ce qu'on a... OK. Donc, cette slide, c'est vraiment pour illustrer l'émergence et la réémergence des maladies à potentiel épidémique, y compris les fièvres hémorragiques virales dont nous parlons aujourd'hui, mais aussi des arboviroses qui peuvent faire l'objet de la prochaine pandémie. Nous avons déjà vu la situation avec Zika. Nous avons vu que la dengue a été transmise localement dans plus de 100 pays l'année passée. Donc, devons être très vigilants et savoir que ces maladies seront de plus en plus fréquentes. Et nous avons des évidences claires aussi que la déforestation crée des conditions complexes de perte de la biodiversité qui font de plus en plus que ces maladies, donc les fièvres hémorragiques virales et ces arboviroses sont de plus en plus fréquentes. Next, si on regarde spécifiquement la région africaine, vous voyez sur cette slide, sur cette étude que nous avions menée dans la région africaine, nous avons vu qu'on avait plus de 120 épidémies par année. Au départ, on avait une baseline de 100 épidémies, mais en améliorant le système de surveillance, nous sommes rendus compte qu'on était entre 120 et 150 épidémies par année. Heureusement que la plupart de ces épidémies sont maîtrisées très tôt et on n'en entend pas parler. Je pense que c'est aussi une des performances de nos systèmes que nous avons transformés à la suite de l'épidémie d'Ebola en Afrique de l'Ouest. Next. Je voulais juste montrer quel travail que nous avions fait déjà il y a 10 ans. Parce que tout le monde parlait de préparation, de preparedness. Et nous avons introduit la notion de evidence-based preparedness parce qu'il faut savoir à quoi on se prépare. Et ça nous a poussé à faire une analyse du risque épidémique en Afrique avec une cartographie des niches des différentes épidémies. Sur cette carte, par exemple, vous voyez donc à gauche, on a le risque Ebola, le risque Marburg, et vous avez vu la fièvre jaune et Zika de l'autre côté. Et nous avons utilisé ces éléments et aussi l'introduction de ce qu'on appelait le GE, Joint External Evaluation of IHR, pour faire ce qu'on appelle Evidence-Based Preparedness et aller amener les pays à avoir des plans nationaux pour la sécurité sanitaire. Et c'était sur la base de ce travail que nous avons conduit avec Cambridge qui est au Kenya. Next. Là, vous voyez, on parle de Lassa aujourd'hui. Déjà, il y a 10 ans, nous avions fait cette cartographie du risque Lassa, mais aussi de Crimée-Congo, que vous voyez ici. Et je pense que c'est extrêmement important pour les pays de continuer à faire cette analyse de risque, donc d'affiner les analyses et de faire une stratification du risque au niveau national pour leur permettre aussi d'affiner leur stratégie de surveillance, mais aussi leur stratégie de préparation et de réponse. Next. Et quand nous parlons de ces maladies épidémiques, la plupart sont des zoonoses, comme vous le savez, avec un réservoir animal. Et ces relations complexes entre l'être humain et l'animal doivent aussi définir le design de nos systèmes de surveillance. Et c'est pour ça qu'il est extrêmement important d'insister sur la notion de surveillance collaborative surveillance. Next. Et c'est pour ça que quand j'étais à l'OMS avec mes collègues, nous avons travaillé sur ce qu'on a appelé l'architecture mondiale, la préparation et la réponse aux épidémies. So we have introduced the concept of 5 C's. And the first C you can see is about collaborative surveillance. And I was talking about collaborative surveillance in the previous slide when we talk about zoonotic diseases. And but we need to make sure that we are not only investing on surveillance, we invest also on the other C's. And I'm very happy to see that during this conference, we were able to talk about the other C's, like the community protection, the scalable care, prise en charge, but also medical countermeasure with the R&D. I think we have had session on R&D, including for vaccine, for treatment. And as we have seen, the ministerial roundtable was strongly focusing on R&D for new vaccine for Lassa. And above everything, we need strong national coordination mechanisms. Otherwise, it will be very difficult to be ready and to respond to outbreak when they happen. Next. So in this slide, I'm just highlighting the collaborative surveillance I just talked about. So what is integrated collaborative surveillance? It's an approach to surveillance that systematically strengthens capacity and collaboration among diverse stakeholders within and outside the health sector, within the One Health approach, as you all know. And the ultimate goal is to enhance the public health intelligence and improving evidence and
Isso é para
decision-making
melhorar as
foundation of
informações
viral hemorrhagic
da
syndrome
saúde
surveillance.
pública
And so
e
as such,
melhorar a
integrated
vigilância, que
surveillance
é
system and
a
other data sources
pedra
that make
basilar
up collaborative
de toda a
surveillance. And this is a
vigilância e
system
as fontes de
approach. We need
dados
this
para
as an
fazermos
approach,
essa
otherwise we will not be
colaboração.
able to build strong system for surveillance. Next. And talking about priorities, very important to understand that surveillance of epidemics are highly dependent on efficient institutional governance, on management at high level of human capacity, human technical capacity. Without the institutional governance, we will not have this, systemic approach to build a strong surveillance system. And building expensive surveillance systems without paying attention to fundamental institutional effectiveness will result in failure. So I'm not going to go into every single detail. I'm sure you will have the slide after the meeting, but these are priority number one. We need to build national capacity and focusing on national public health institutes. Without national public health institute coordination and innovation, using science to guide policy, it will be extremely difficult. Next. And number two is about strengthening One Health surveillance and laboratory capacity. On the graph I show about the 5C, already within the collaborative surveillance, we have highlighted the importance of laboratory, because without the right diagnostic, it's very difficult to build a strong surveillance system. But unfortunately, most of the time, when we have an outbreak like Ebola, we go and test. If it is not Ebola, we are all happy. It's not Ebola, but we don't push much to know what is happening. And we miss opportunities to understand why people are getting sick at the community level, why people are dying at the community level. We need to make sure that we use the integrated approach for that. And within the surveillance system, of course, we talk about the digitalization of data system, integrated surveillance, but also the governance and laboratory capacity. And the lab capacity is extremely important. Even if we are in very remote area, we should be able to, detect diseases, but also to perform, genomic surveillance. This is really available, and we need to continue building capacity everywhere, and continuous training on quality assurance system is extremely important. Logistics is everywhere in health emergency. You cannot perform surveillance, and respond to outbreak without strong logistics system and working very closely with communities. Next. And when we talk about also surveillance, very important to maximize the value of data. You can see here in our region, Africa, we are still very, weak in terms of research. Only less than 2% of global research is happening in Africa. And we need to maximize the use of data. And we cannot prepare and respond effectively if we cannot innovate. I talked about evidence-based preparedness. That's why research and data are extremely important for us to be able to build a strong surveillance system, but also overall good preparedness and response system. And we need to improve institutional analytical capacity in Africa because it's still very low. And without capacity to analyze data, we will be always behind. And now with the new technology, artificial intelligence, we should be speed in analyzing data in a routine operation, and to ensure that the workforce have continuous access to training, and we bring new talent and we are able to maintain them in the system. And next. So regional collaboration is extremely important. Here I'm showing a slide. I'm sure you have already seen another session, this presentation made by Boubacar and Abdurrahman. We are working with 12 countries right now around the 4S, the 4S. Donc, le système de surveillance 4S qui a été mis en place d'abord au Sénégal, mais aussi que nous utilisons dans 12 pays aujourd'hui, qui nous permettent donc de faire une surveillance syndromique, mais aussi de faire une confirmation des diagnostics avec donc le plus souvent des laboratoires mobiles que nous pouvons déployer dans beaucoup de pays, mais aussi avec une plateforme de surveillance génomique qui nous permet de comprendre exactement donc comment ces épidémies arrivent. Est-ce que c'est des nouvelles introductions? Est-ce que c'est un relapse donc d'une infection qui existait déjà? Et en continuant à travailler avec les pays de la sous-région et peut-être au-delà, dans ces plateformes, ça nous permet d'avoir des systèmes qui sont interopérables et une facilité d'échange d'informations, même en temps de paix quand il n'y a pas d'épidémie, pour nous permettre d'être beaucoup plus efficaces sur notre façon de contrôler ces maladies. Next.
Essas doenças.
There is something missing. Next. Yes. OK. Quand on parle aussi de local manufacturing, la production locale des tests de diagnostic ici, sont illustrés par cette initiative que nous avons au niveau de l'Institut Pasteur qu'on appelle DAY2. Donc, DAY2 nous permet de développer des nouveaux tests de diagnostic rapide. Aujourd'hui, nous sommes à la dernière phase du test de diagnostic rapide pour la rougeole, par exemple. C'est un test qui sera utilisé non, pas seulement en Afrique, mais dans toutes les zones du monde où nous avons des crises humanitaires, où la rougeole pose un grand problème. Donc, nous sommes déjà en discussion avec l'OMS dans ce cadre. Et Diatropix travaille aussi sur d'autres tests pour les maladies prioritaires telles que Ebola, Marburg, la dengue et Lassa, dont nous parlons aujourd'hui. Et la plateforme donc, que nous avons nous permet de travailler en même temps sur plusieurs tests de diagnostic. Nous avons aussi introduit la production de nouveaux tests pour des maladies tropicales négligées telles que l'onchocercose. Et nous sommes en discussion avec certains partenaires pour d'autres maladies telles que la loase qui sont co-endémiques dans certains pays comme le Cameroun. Donc, pour vous dire que le potentiel que nous avons aujourd'hui d'améliorer nos systèmes de surveillance en améliorant la production de tests diagnostiques est une opportunité que nous devons partager avec toutes les régions. Next, on ne peut pas parler de production locale sans parler de vaccins, mais ce n'est pas le topic d'aujourd'hui, c'est juste pour montrer que nous sommes aussi très engagés dans la production de vaccins et en soulignant qu'un système de surveillance solide nous permet aussi d'adapter nos stratégies de vaccination. Nous l'avons vu avec la vaccination en ceinture, ring vaccination, durant les épidémies d'Ebola, mais aussi bien avant, durant l'éradication de la variole. Et aujourd'hui, nous avons l'opportunité de produire des vaccins ici, y compris pour Lassa, sur lesquels nous travaillons. Donc, que ce soit les vaccins liés aux épidémies, comme celui de la fièvre jaune, Ebola, Lassa, mais aussi des vaccins pour les pertes de routine plus tard. Next. Donc, en conclusion, pour faire bref, étant donné qu'on a un panel assez long, je vais juste résumer ces points qui doivent définir notre organisation du système de surveillance en revenant sur la nécessité de renforcer les instituts nationaux de santé publique pour plus d'efficacité avec des ressources adéquates et tout le système de régulation. La surveillance digitalisée avec une analyse robuste des données, mais aussi tout ce qui est surveillance génomique, en les équipements qu'il faut et les capacités de ressources humaines qu'il faut avec un réseau de laboratoires solides qui nous permettent dans nos pays, en utilisant les systèmes sentinelles, mais aussi le système de routine, de détecter à temps tous les problèmes de santé qui peuvent survenir. Et la résilience donc, de nos institutions de santé publique en termes de capacité d'analyse et d'innovation est un élément extrêmement important aussi pour cette architecture de la surveillance. Et dont on a parlé tout à l'heure, la collaboration sous-régionale, mais aussi régionale, et aussi à travers la collaboration transfrontalière qui est un des piliers importants du règlement sanitaire international. Et finalement, la capacité de production, de manufacturing, et qui nous permet de travailler dans la sous-région pour avoir des pôles de production qui vont nous amener à couvrir les besoins les plus importants, les besoins prioritaires pour faire face aux maladies à risque épidémique. Je vous remercie. Merci.
Merci au docteur Socéphal. Je pense qu'on doit encore plus l'acclamer. Il a mis en évidence plusieurs choses. La première, c'est qu'il y a des priorités mondiales, mais également des priorités sous-régionales concernant les fièvres hémorragiques, les fièvres hémorragiques virales. Il a insisté sur le fait d'avoir une bonne surveillance et également un bon diagnostic dans notre sous-région, l'Afrique de l'Ouest. Et qu'il a souhaité également qu'il y ait des réformes urgentes au niveau des pays pour que les systèmes des pays soient forts et ensemble, on pourra aller plus loin. Il a également fait un point sur la surveillance de manière active, mais qu'on soit maintenant dans une surveillance de type prédictive. Merci au docteur Socéphal pour avoir planté les décors de notre panel. Maintenant, je vais appeler les autres panélistes. Tous sont des chercheurs et des épidémiologistes de renom. Je vais commencer par le docteur Muntari Hassan, qui est le chef de la division de surveillance. Oh, you can't keep. You can't keep because you speak in French. OK, calme. Il est le chef de la surveillance, la division de surveillance au Nigeria, au centre de contrôle des maladies. Mais il est également celui qui s'occupe de la collecte, de l'analyse et de l'interprétation des données relatives à la santé pour la planification, pour l'implémentation, également pour l'évaluation au niveau du système de santé du pays, soit au niveau communautaire, au niveau district et au niveau national. Merci de nous rejoindre. Le second qui va nous rejoindre, le troisième plutôt, c'est le docteur Pierre Formonti, qui est médecin vétérinaire, qui a un master en santé publique et qui a longtemps travaillé avec l'OMS jusqu'à très récemment. Il a été avec l'OMS responsable après Hassan. Il a été responsable des maladies, des fièvres hémorragiques virales dans ce département à l'OMS et il est un grand expert de toutes les fièvres hémorragiques, à commencer par Ebola, Marburg, la vallée du Rift, Crimée-Congo, Lassa et d'autres, tous les arboviroses qu'on connaît. La troisième, c'est une dame, docteur Mini Sankolo Rix. Elle est libérienne, c'est une voisine, elle n'est pas très loin. Elle est libérienne, c'est une voisine. Elle est responsable de Phoebe Hospital and School of Nursing en République de Libéria. Mais elle est également la première femme à diriger une telle institution dans son pays. Mais elle travaille également sur la prévention des maladies infectieuses et beaucoup de choses. Le quatrième intervenant est le professeur Alpha Kabinet Keïta. Il est médecin microbiologiste, mais il est également recteur de l'université Gamal Abdel Nasser de Conakry. Il est chercheur, oui, après la dame. Il est chercheur avec l'INSERM. Il a beaucoup travaillé sur les maladies infectieuses. Il a cofondé le centre de recherche et de formation en infectiologie en Guinée et il est spécialiste des épidémies. Il a joué un très grand rôle dans la lutte contre la COVID dans son pays. Et le dernier, mais non des moindres, Dr. Donald Samuel Gantz. What is it? Ah, okay. I'm looking for you. Good. After process. C'est également un chercheur d'un pays voisin, la Sierra Leone, et il a beaucoup travaillé sur le développement du secteur de la santé. Et il travaille avec l'université de Tulane aux États-Unis. Et il a essentiellement travaillé sur les fièvres hémorragiques. Comme vous le constatez, on a un panel de chercheurs qualifiés sur les fièvres hémorragiques et ils vont nous entretenir sur ce point. Bienvenue, chers collègues. Donc encore merci, docteur Soussé, pour votre intervention. Je vais m'adresser à présent au docteur Muntari Hassan. Le Nigeria a une approche particulière. Il va en quelques mots nous expliquer comment au Nigeria l'on fait. Le Nigeria a intégré la surveillance génomique, la surveillance communautaire et des outils de rapport numérique ainsi que le séquençage génomique dans la gestion des fièvres hémorragiques. Donc, docteur, quelles sont les leçons? Donc, premièrement, comment pouvez-vous assurer que les outils que vous utilisez sont bons et que cela permet de faire un système d'alerte précoce? Is good or I have to translate it? It's okay? It's gone. Okay. Don't worry. Yeah.
So thank you very much. First of all, I would like to say that surveillance system and even the laboratory component of the surveillance are all detect component of the under the 19 technical areas of the IHR. So for genomic sequencing, we know all the data that comes for that sequencing comes through the surveillance system that is already existing. But the sequencing, we are all aware that, especially in Nigeria, is not all confirmed cases that we sequence. Probably we prioritize, unusual cases or during outbreaks or research, or viral evolution or clusters. So having said that, let me just give a brief background on the surveillance system in Nigeria. We're all aware of the evolution of the surveillance from 2001, when we had the Integrated Disease Surveillance and Response Technical Guideline, the first edition, to 2019, when we have the third edition of IDRSR Technical Guideline. Now, in the IDRSR Technical Guideline third edition, we're aware of the 45 priority diseases. We know 25 are being reported as case-based, where Lassa fever is part of it. So that is where we report, using surveillance, outbreak response, management, and analysis system. So in the third edition of IDRSR Technical Guideline, apart from the 45 priority diseases that we're aware of, the most important components that are stressed in that third edition are transformed from paper-based to electronic-based, IDSR. So that's what we are working on. That is why we strengthen our surveillance, outbreak response, management, analysis system. The second component is to strengthen the event-based surveillance. Although it's existing, but it needs to be really further strengthened. And that is, of course, what we are doing to also make sure that using event-based surveillance, we can pick Lassa fever. And then the third component is also to complement these two, surveillance approaches to strengthen our community-based surveillance, because we know all these cases are from communities. So now, using the case-based diseases that I mentioned, which Lassa fever is among, we use SOMAS, that is Surveillance Outbreak Response Management and Analysis System that, we use as case-based. It has to be reported immediately. And we have a robust structure in Nigeria for that purpose. SOMAS has covered, over 774 local governments that we have. Our disease surveillance and notification officers and their assistants, and the state epidemiologists and the state disease surveillance and notification officers, they all have access to SOMAS across the 37 states and 774 local governments that we have. Recently, we have also deployed this tool, surveillance tool, to secondary and tertiary health facilities, over 5,000 of all the secondary and tertiary health facilities across the country. So that is for the electronic IDSR, that is the SOMAs, which is case-based. Now, when we come to event-based surveillance, which we have strengthened, at the national level, we're able to have a robust event-based surveillance system that we use using our toll-free number, which is 6232, that you can call. Even if you don't have credit in your phone, you can call from community, from local government, from health facility. We have the WhatsApp, platform. We have a live chat, also platform. We also have a local surveillance tool that we developed in Nigeria, which is called, Tata4, that you can, sieve this information through 3 major languages that we have, in the country, not necessarily English. So, Hausa, Igbo, and Yoruba, which are the major languages in Nigeria, just to mention that in summary. And then we have the international platform, which is epidemic intelligence from open sources. But for you to use that locally, you have to develop what we call bots. In Nigeria, we're able to develop 4 bots. One of them, very important, is the epidemic prone diseases bot, that we use it to search for, these cases. And then we have also cross-border bots that if something happens in Cameroon, we'll be able to pick it also using that bot, despite the fact that it's an international tool, which is epidemic intelligence from open sources. We will now be able to pick, all these cases using these tools. Then finally, as I mentioned, community-based surveillance. We're able to develop a strategy, just like we have developed a strategy for genomic surveillance. We have developed strategy for community-based surveillance in Nigeria. We have actually implemented in many of our states, but what we want to do is we have done a pilot, just like during polio, where you use autovisual alert detection and reporting, which is called AVADA. You can have community event-based surveillance, and you can also have community indicator-based surveillance. So just like what has been used in during polio. So I think I'll stop here. These are the briefly the tools that we use in surveillance. I think we can discuss further. Thank you.
Merci, Dr Muntari Hassan. Il a montré le système au Nigeria avec toutes ses composantes. Et cela montre que les pays avancent dans la surveillance et comment on approche les ripostes avec chaque pays à sa stratégie en fonction de son contexte. Je me tournais à présent vers le docteur Pierre Formonti, qui est ancien chef de l'équipe des fièvres hémorragiques virales à l'OMS. Et étant donné votre expérience au sein de cette équipe et de l'OMS, quelles sont les stratégies intersectorielles que vous pourrez avoir pour renforcer la prévention et la préparation face à la fièvre Ebola et à la fièvre de Lassa et bien sûr toutes les fièvres hémorragiques, parce qu'aujourd'hui on parle certes de la fièvre de Lassa, mais c'est toutes les fièvres hémorragiques virales qui nous intéressent.
Ah, je pense que j'y suis. Merci beaucoup et merci beaucoup aussi pour l'invitation à venir ici, dans la merveilleuse ville d'Abidjan. Votre question, je pense qu'une grande partie de la question a été répondue par professeur Saucé. La surveillance telle qu'on la voyait, je dirais, il y a 25-30 ans, a beaucoup évolué au travers de multiples crises. Une des choses importantes que je regardais dans la présentation du professeur Saucé, c'était le regard régional. Et c'est quelque chose qui nous a, à l'OMS, toujours guidés. C'est sûr qu'on a une approche santé globale, mais pour pouvoir mobiliser des systèmes de surveillance au niveau national, il faut aussi regarder quelles sont les priorités régionales. Et je pense que nous avons tous été frappés par l'importance et de la flambée d'Ebola en Afrique de l'Ouest de 2014 à 2016 et ses conséquences dramatiques sur les populations et aussi sur l'économie. Mais au cours de ces longs 24 mois, nous avons aussi réussi d'une part à mettre en place des systèmes qui fonctionnaient à travers notamment les 3 pays les plus touchés, des systèmes de réseaux de laboratoires, de réseaux de communication, de réseaux d'information aussi. Et on a réussi à faire des essais cliniques en temps réel et des essais vaccinaux et de mettre à disposition des populations une meilleure prise en charge pour les fièvres hémorragiques virales, mais aussi le début de mesures médicales comme des vaccins. Et ceci a ensuite été continué, par exemple, en République démocratique du Congo. Donc, pour beaucoup de personnes qui ont été impliquées en Afrique de l'Ouest au cours de cette épidémie, pour les fièvres hémorragiques virales, vraiment, l'objectif de la surveillance, ce n'est pas seulement de compter le nombre de cas et de décès, mais d'aider les gouvernements à mieux comprendre ce qui se passe et à développer des stratégies pour mieux combattre, prévenir ces épidémies, pas tout seul, avec des cliniciens, avec des spécialistes de la communication, avec des chercheurs qui vont travailler sur des nouveaux traitements, sur des nouveaux vaccins, sur des nouveaux comportements pour éviter les infections. Et donc, c'est un travail, je dirais, de multi-pluridisciplinaire. Professeur Saucé mentionnait les 5 C, et on est vraiment là-dedans aujourd'hui, que ce soit pour Lassa, pour la fièvre hémorragique de Crimée-Congo. Là, moi, j'ai beaucoup travaillé au Moyen-Orient sur Crimée-Congo d'ailleurs. Et on reprend l'inspiration du Nigeria et des autres pays d'Afrique de l'Ouest sur le management de Lassa. Ça a inspiré les pays du Moyen-Orient sur une approche très proche où non seulement on va faire plus de surveillance et d'analyse, mais aussi appuyer les cliniciens dans les hôpitaux pour qu'ils soient mieux formés, qu'ils puissent être protégés au cours de leurs interventions et amener aux patients une prise en charge médicale avancée, comme on a vu avec la prise en charge, par exemple, dans le Covid. Et donc, c'est quelque chose qui est vraiment de plus en plus avancé. Et pour Lassa, je sais que beaucoup de gens sont frustrés parce qu'on n'a pas encore un vaccin, mais je me dis que depuis 10 ans où on a vraiment intensifié le travail sur Lassa, ou depuis 15 ans où on a vraiment intensifié le travail sur Lassa, beaucoup de choses se sont améliorées. On a aujourd'hui, j'ai compté 18 laboratoires en Afrique de l'Ouest. Là, je reviens à notre région. En Afrique de l'Ouest, 18 laboratoires de Dakar à Yaoundé qui ont un diagnostic Lassa Fever. On a 8 centres de traitement Lassa, 7 qui sont au Nigeria et les autres qui sont au Togo, au Bénin, en Guinée, en Sierra Leone et au Libéria. Donc, ce qui manque peut-être en plus de ça, c'est plus de coordination entre ces équipes médicales, ces équipes de laboratoire. On l'a pour la surveillance parce qu'on a une meilleure coordination de la surveillance, mais ce qu'on voudrait pousser, et je pense que d'ailleurs il y a un rôle à jouer avec le centre collaborateur de l'OMS Dakar, c'est pousser pour une meilleure coordination des laboratoires pour que Abidjan demain aide Freetown, ou Cotonou, ou Lomé, que Iroua fasse des missions pour aider Bamako, etc. Et qu'on ait vraiment cet échange entre tous ces pays sur cette problématique. Je me souviens, par exemple, au Togo, un médecin qui devait prendre en charge un bébé infecté avec le virus de Lassa, et on l'avait mis en communication avec des cliniciens pédiatres d'Iroua pour qu'ils puissent échanger sur comment on prend en charge un bébé infecté avec Lassa pour augmenter ses chances de survie. Et c'est ce genre de network de réseau, pardon, qu'il faut, à mon avis, mettre en place pour stimuler une meilleure prise en charge des patients, parce qu'avec cette meilleure prise en charge viendra le trust, la confiance, et la confiance, c'est essentiel pour une meilleure survie. Si les gens voient dans la surveillance uniquement des chiffres dans des jours, vraiment, moi, comme je dis, ma grand-mère, ça ne l'intéressait pas. Et je pense que pour vous, c'est pareil. Il faut que les gens voient qu'on travaille pour eux Et pour cela, il faut faire des progrès sur la prise en charge, les thérapeutiques, les vaccins et un meilleur accès aux soins. Je vous remercie.
Merci, docteur. Vous avez confirmé, si j'ose dire, tout ce qu'avait dit le docteur Saucé. On voit que ce sont des anciens de l'OMS, donc la vision est identique, mais c'est la vision aussi des pays. Donc, merci. Je voudrais passer la parole à présent à la seule femme de notre panel, docteur Minirix. Vous êtes à l'hôpital. Donc, vous êtes en première ligne de là où commence, non, même pas en première ligne, en deuxième ligne, parce que la surveillance commence en communautaire avant d'arriver à l'hôpital. Mais vous êtes dans les premières lignes de la surveillance. Pour vous, quels sont les principaux obstacles et aussi les défis à une détection et un rapport efficace sur les fièvres hémorragiques au niveau communautaire et au niveau des structures sanitaires au niveau du Libéria?
So I want to say thank you very much for this opportunity. Thanks to the organizers, partners, and sponsors that made it possible for us to have this conference. So I want to deal with the enablers first before I get to the barriers. As a frontliner, there are primary enablers, barriers. I want to contextualize it to my facility and then maybe Liberia also. So for VHF detection, you will need a community-based surveillance and the national community health system. Okay, you need trained healthcare volunteers or healthcare workers, community healthcare workers. These are the first points of contact in the community for any disease surveillance, okay? And they should be equipped to identify and report suspected VHF and other priority diseases. And this program should be extend above the reach of just the urban areas or in remote communities. You need a community engagement and community trust. We learned lessons from the Ebola, okay? And there should be greater emphasis placed on community engagement and community involvement. With that, you build the trust of the community. Okay, healthcare workers will have trust in the health system. Evidence-based surveillance, as has been mentioned, this is important. It encourages the reporting of unusual events and a cluster of deaths, even if they don't fit into a standardized case definition, but they should be reported. And it allows a more sensitive and proactive approach to detecting potential outbreaks and threats. And in Liberia, we also have what's called a WhatsApp platform for evidence-based, okay, that is used for surveillance, the county health team, and also the facility-based team. We are also part of this WhatsApp evidence-based group. And it comes to the integrated disease surveillance and response framework, the IDSR. You should have the standardized guidelines and case definition, okay? Now, this guidelines, it should include case definition for all VHF and other priority diseases. The consistency helps ensure that cases are reported and investigated uniformly across different communities, okay? And it also integrates surveillance into the existing health system from the community level to the national level. And it creates a clear chain of command and communication to reporting and responding to public health events. Also have the use of technology, like the mobile-based surveillance tool. This has been scaled and piloted in Liberia, okay? And it helps improve the timeliness and accuracy of data and allowing for real-time reporting of suspected cases, from remote areas to district level and national level. Data management system, that cannot be overemphasized, okay? The integration of community level data into the national system, like the district health information system, it helps central authorities to monitor diseases, disease trends, identify outbreaks, and allocate resources more effectively, hopefully. So when it comes to the barriers, okay, logistical and resource constraints. That's number one. And you have poor infrastructure and communication in many rural, remote areas, like where I work. You have bad roads or poor road conditions, making it difficult for health workers to reach communities or sick individuals. You also have communication infrastructure, phone network, okay? Internet. Most of the time we have a shortage of internet and even the provision of phones, okay? Credit for telephones, they are all limited for people in healthcare, in rural healthcare areas, okay? And these pose hindrance to effective, reporting for far to reach areas. We talk about insufficient supplies and equipment. Most of the time, supplies are more concentrated to the urban areas and not the remote communities. And these are humans. You have healthcare workers, you have patients in these areas. And people expect us to make magic. I gave an example of the Ebola. Some days you have just a pack of gloves. How do you cater to your patients? And being a frontliner, you are not going to wait and say, oh, I don't have gloves, so I can't touch these patients. But in creating an environment to attend to your patients, you also pose yourself at high risk because of what? Insufficient supplies, okay? Inadequate funding and incentives. Most of the time, people in rural areas are overlooked, especially community health workers, community health volunteers. Okay? They should be trained, and not only be trained, they should also be fairly compensated. So all of these are what? Barriers. You have the community level challenges, the traditional and social factors, okay? The mistrust for outsiders, okay? Traditional beliefs, the use of traditional healing practices. We learned lessons from the Ebola. Most of the time, traditional people want to what? Bathe their dead. But in Ebola, we had to what? Talk to them and say, no, we have to do what? Safe barrier practices. And this brought a lot of mistrust. This is our tradition. We've been doing it so many years. Why this time? Why are you preventing us from practicing our tradition? Okay, so you also have the lack of public awareness. It's not only during outbreaks that we should go to the community. Okay, there should be a high level of understanding of symptoms and transmission of what PHFs in the community. And if we can just continuously engage the community, okay, build up the trust, not by just identifying outbreaks, but providing primary health care, okay, immunization, maternal and child health, basic primary care. You build the trust of the community. So when there's an outbreak, you are not seen as an outsider, okay? You are seen as a friend, okay? We should start to be what? Community champions, and not only just outbreaks. You also have the health system weaknesses. And one is data quality and reporting gaps, okay? Despite the level of technology, you still have poor data management, incomplete reporting, and under-reporting of cases remain a significant challenge. You also have limited laboratory capacity. Well, thanks to the research of Lassa fever in Liberia, now at my facility, we have a PCR lab. But before then, And then we also have the National Reference Lab. Before then, Liberia used to take their specimen to our neighboring country, Sierra Leone, and we may not even get the result on time.
Enviávamos as
But even with the national
amostras aos nossos vizinhos da Sierra
it's just now
Leoa
taking
e demorava muito para
a week or so. But thanks to this research for my facility, Phoebe Hospital, we have UNC, we partner with UNC, and we have a study on Lassa fever. We have a PCR lab. So the turnover time, while we are waiting for the national reference lab results, we already have a result within 4 to 6 hours. And that helps with our what? Decision making and our management of patients. Ineffective supervision is one thing. Not many healthcare workers go into the remote villages. Okay? So supervision is one of those barriers in effective supervision. I mean, surveillance. We can't just let the community health workers, community health volunteers be on their own. You need to supervise them and be able to know that, okay, that's at this level, they have the resources and then they are trained enough, they are being supervised and monitored. This creates trust from the community for these community health workers. I would just want to stop there and
next time. Merci au docteur Mini Rix du Libéria qui a exposé sur le cas de son établissement et a noté notamment les points d'engagement communautaire, des problèmes de logistique, des problèmes aussi pour protéger les praticiens. Ce sont des points importants et surtout à parler des laboratoires. Donc, je veux me tourner à présent vers le professeur Alpha Fabiné Keita, qui est directeur du laboratoire de recherche sur les hémorragiques en Guinée. Donc, monsieur le recteur, la surveillance génomique a permis de confirmer rapidement le marabout en Guinée. Mais également, je voudrais dire que le rôle de la surveillance génomique est important. Et le rôle des laboratoires devient de plus en plus important dans la fois dans la confirmation des cas pour qu'on puisse faire la riposte. Donc aujourd'hui, la Guinée a un leadership affirmé dans cette option-là, grâce à cause des flambées Ebola et Marabout. Donc actuellement, monsieur professeur Alpha, qui est à cabinet, la surveillance génomique a permis bien sûr de confirmer, mais selon vous, quels sont encore les obstacles techniques ou même politiques, hein, parce que là, comme vous êtes directeur aussi, dans le côté politique de l'affaire, qui reste à institutionnaliser ce type de séquençage. Bon, on dit général en temps réel, mais pas, parce que c'est très rarement en temps réel, mais c'est un temps légèrement différé, pour que le différé soit le plus court possible pour nous permettre de faire de la riposte dans notre sous-région de l'Afrique de l'Ouest. Vous avez la parole.
Alors, merci beaucoup, professeur Samba, et merci aux organisateurs de nous avoir permis de nous exprimer ici sur ces questions assez importantes pour la riposte aux épidémies de façon globale et aux fièvres hémorragiques particulièrement. Bon, je dois quand même apporter une petite précision. Je ne suis pas le directeur du laboratoire des fièvres hémorragiques en Guinée. Je suis, en plus de ma fonction de recteur, directeur adjoint du Centre de recherche et de formation en infectiologie de Guinée, qui est le CERFIG. Je pense que le directeur du laboratoire des fièvres hémorragiques doit être quelque part dans la salle ici. Voilà. Donc, je dois quand même préciser que sur la question des fièvres hémorragiques, de la surveillance génomique, de la détection de ces pathogènes-là, on vient de loin. Et je suis encore plus heureux parce que dans ce panel, j'observe que je suis dans ce panel avec des personnes qui se sont investies en Guinée, beaucoup, lors de la première épidémie Ebola entre 2013 et 2016. Donc, tout ce que je vais dire, je pense qu'ils ont vu ces choses-là évoluer. On vient de loin, pourquoi? Parce qu'aujourd'hui, on parle d'obstacles. Mais avant de parler d'obstacles, il faut déjà savoir d'où nous venons en termes de détection et de surveillance génomique. En 2013, j'aime toujours partir de ce point-là parce que lorsque l'épidémie d'Ebola a commencé à toucher les gens en Guinée, en 2013, il a fallu 3 mois pour faire le diagnostic. Entre, disons, les premiers cas et la déclaration officielle de la maladie, le virus a eu le temps de circuler et de faire beaucoup de victimes dans le pays. Ensuite est arrivée la résurgence en 2021. En 2021, quand nos collègues de Djekedou, donc du laboratoire des fièvres hémorragiques, ont lancé l'alerte, lorsqu'on retire le temps de transport des échantillons, il a fallu 24 heures pour faire la confirmation et 9 jours pour obtenir une séquence complète. Donc, faire le génome complet du virus. Ça montre un tout petit peu comment est-ce que les outils modernes de biologie moléculaire, les outils de surveillance génomique qui sont des outils formidables, le séquençage peut révolutionner et changer de zéro à tout la surveillance d'une maladie aussi dangereuse que Ebola. Disons que ceci étant dit, malgré ces avancées, parce que des avancées, il y en a eu, il y a bien sûr des obstacles. Et vous l'avez dit, vous avez commencé par le dire, il y a des obstacles techniques. Ces obstacles, il faut le dire, que la surveillance génomique, ce n'est pas seulement une question de machines sophistiquées. C'est aussi, il faut voir cette surveillance sur un plan plus large au niveau du transport des échantillons. Un transport rapide des échantillons, la disponibilité des réactifs, la formation des techniciens qui seront capables de faire fonctionner ces plateformes sont des aspects qu'il faut prendre en compte en quelque sorte en parlant de surveillance génomique et d'un processus de surveillance génomique abouti. Parce que lorsque les échantillons n'arrivent pas au laboratoire en bon état, lorsque les réactifs manquent ou sont de mauvaise qualité, lorsque le capital humain, donc les techniciens qui sont en mesure de faire fonctionner ces plateformes sont très mal formés, en ce moment, il ne faut pas parler de surveillance génomique parce qu'on n'obtiendra rien. Il y a bien sûr des obstacles politiques parce que simplement aujourd'hui, et jusqu'aujourd'hui, malheureusement, dans la plupart des pays, la surveillance génomique est encore considérée comme étant un luxe de chercheurs. Jusqu'à présent, on n'a pas pris conscience que la surveillance génomique et les outils qui vont avec sont disons, des outils stratégiques de santé publique pour permettre une surveillance efficace et permettre justement aux pays de mieux faire face à ces épidémies en les détectant et en les caractérisant assez tôt pour pouvoir guider la riposte. Et dans la plupart des pays, particulièrement en Guinée, je me focalise sur ce que je sais, avec l'aide de partenaires comme l'OMS, avec des réseaux comme le réseau AfroScreen, le pays a investi dans des laboratoires et a montré, si besoin en était, qu'elle était capable, avec des outils, du personnel bien formé, un approvisionnement efficace en réactifs, faire de la surveillance génomique, confirmer une épidémie, par exemple, telle que l'épidémie Marbourg, qui, en quelque sorte, je le disais tout à l'heure, a été confirmée par le laboratoire des fièvres hémorragiques. Je pense que le professeur Bombali doit être quelque part ici. Mais ce qu'il faut se dire aussi, c'est que l'institutionnalisation passera indubitablement par un engagement des États. Il faut, dans ce système, que les États apprennent à financer eux-mêmes leur riposte et que les États puissent mettre à la disposition de leurs professionnels de santé, des chercheurs, les moyens qu'il faut pour être efficaces dans la riposte. Mais au-delà de l'engagement des États, pour avoir un système durable, avec des capacités qui répondent aux besoins des populations, il faudrait mettre en place un système intégré. Ce système intégré partira, disons, de l'intégration des laboratoires pays dans des réseaux de labos pour éviter qu'il n'y ait de la génomique isolée. C'est quelque chose, à mon sens, qui est assez importante pour permettre justement, comme ça a déjà été dit ici, aux différents laboratoires de se partager les données et de pouvoir réagir en temps réel, hein, quel que soit le pays. Voilà, donc pour cette première, pour cette question, voilà ce que je pouvais dire. Je vous remercie.
Merci, professeur. Je reviendrai vers vous pour une autre question plus précise sur l'utilisation de votre laboratoire. Je vais à présent me tourner vers Dr Donald Grant de la Sierra Leone. La construction au niveau de la Sierra Leone, la construction d'un système intégré des fièvres hémorragiques après Ebola et tous les efforts que vous avez faits en matière de centralisation des services de laboratoire ont permis d'améliorer la coordination des réponses en santé publique. Vous avez beaucoup investi dans les infrastructures de surveillance. Mais cela dit, quelles sont les leçons que vous pouvez tirer de ce système que vous avez bâti pour rendre le système de santé plus capable à détecter rapidement des fièvres hémorragiques? C'est vrai que le professeur Keïta a parlé du temps entre les premiers cas et la confirmation de la maladie qui avait mis 3 mois. Il y a quelque temps que maintenant, on arrive à le faire en 1 semaine. Dites-nous, au niveau du Libéria, comment on peut voir, quelles sont les leçons qu'on peut tirer et aussi, quels sont toujours les défis qui existent pour qu'on puisse l'améliorer.
All right, thank you so much, and thank you to the organizers for giving me this opportunity. I think at the end you said Liberia, but Sierra Leone and Liberia were almost always doing similar things. Thank you. For us in Sierra Leone, the Ebola outbreak, we usually say exposed the health system, shows so many challenges, and wherein we lost health workers, we lost critical members in the communities, and up to date, we see those aftermath in Sierra Leone. But however, I must say proudly, there have been so much investment in terms of detecting these cases as early as possible. I would say before the Ebola, we were talking about paper-based IDSR that will literally report on a weekly basis. What does that mean? It means if even a suspected case is detected, it may not be reported that early. But now we have event-based surveillance system that covers, we now have a communication path, which is 117, wherein it has been popularized. Anyone can call through that number to say, oh, somebody is sick, or we are seeing a couple of households, being sick or having fever or being dead. So there's that kind of platform now. And we also have the case-based surveillance. I must say that is really critical. So it's not just waiting at the end of the week to aggregate the data, but on a case-based reporting are being done. And for Sierra Leone, our health workforce has been, we do have different levels. The first level is the community health worker. They form the bridge between the health facilities and the communities. So they also tap into this case-based surveillance system. Whatever they see in the community, they take it straight to the health facility, and the health facility will report it. And these reports through the case-based surveillance, it's well synchronized. Once those information go in on a case-based basis, it doesn't stay in the health facility. It's been seen at district level, it's been seen at national level, and it's also been seen at WHO level in country. So what does that mean? It means once you are in your facility and you plug in that information, you alert and trigger the system automatically. So there is that response that comes from district level to look at what is happening. And even at chiefdom level, all districts are divided. I'll speak specifically for the chiefdom that I am based. The district that I am based, we have 16 chiefdoms. So each and every chiefdom, no sooner a case is being triggered, that chiefdom, straight away, they have to put things in place, all the needed things. And also, we've invested a lot on human resource. We have the field epidemiology training programs. At chiefdom levels, we have these health workers being trained on basic epidemiology and surveillance strategies. So they're quickly able to report and in a timely manner. So these are some of the things we've done. And, it's not a happy thing, but the Ebola taught us those strong lessons that we need to be very resilient. We need to respond swiftly, right? Even though most of these ones are supported by partners, right? But you also see now the Ministry of Health taking that leadership so that this case-based surveillance system will be well placed across all facilities. There are challenges, there are gaps. One of which, if you're talking about electronic case-based surveillance, we also know internet connectivity is a big challenge. But one of the ways we've tried to circumvent this is, in as much as they will input it, we ask them to even take pictures and send as fast as possible. We also do what we call rumor collection, media scanning. So no information is left unattended. So if even that we have a team that monitors WhatsApp groups, the media, newspaper is being followed so that cases can be detected or any event can be detected as early as possible. Even now, we have moved away, not just focusing on human health, but also animal aspect, because we're talking about zoonotic diseases of such. So even in the farthest village, no sooner we realize that somebody sees goats, sheep, or these animals are dying, it is not kept at that level. It is being reported right at that level, triggered to the chiefdom level, to the district level, and to national level, and then it is being investigated. So these are some of the things, but one of the biggest challenge, as I mentioned, the internet connectivity for us to sustain it. We also have another big challenge is the dependency on donors and partners. I mean, that is critical. Even when it comes to the testing, my colleague from Liberia mentioned, thank God they're involved in a research. And if you talk about Lassa fever, I think that is one of the biggest challenge. Most of the testing sites are involved in the researches. So my question is, what happens to these testing platforms when these researches come to an end? So those are the critical challenges that if tomorrow these fundings are closed, are we going to continue testing? And where do we see these cases? These cases happen in remote centers, in remote communities. But where do we have our labs? We have our labs in the bigger cities. So I think also this also calls for us to look at it as a big challenge. One of my greatest push is looking forward to portable PCR platforms that, with all safety, that can be used even in the farthest community, right? I think with these ones, we'll also be able, once the cases are reported, they can be quickly screened, they can be quickly detected, isolated, and then all of which will be able to respond appropriately. Thank you.
Merci au docteur Donald Grant. Nous avons fait un tour de table avec tous les panélistes. Je vais demander au docteur Soucé son aperçu sur ce qui a été dit et nous allons passer à la troisième étape. Je vous avais dit qu'on avait 3 étapes dans notre session. Première étape qui était la présentation du docteur Soucé. Deuxième étape, échange avec les panélistes. Et troisième étape, échange avec l'audience. Donc, je vais passer la parole au docteur Soucé. Ensuite, je vous passerai la parole pour ceux qui voudraient bien intervenir. Docteur Soucé.
Merci, professeur Samba, et félicite aux collègues panélistes pour la qualité de leurs interventions. Et ça nous rappelle encore une fois, comme l'a souligné le professeur Keita, où est-ce qu'on est parti? Et on prend comme référence toujours l'épidémie d'Ebola de l'Afrique de l'Ouest, parce que ça a été un moment critique pour permettre de réformer nos systèmes de préparation et de réponse aux épidémies, aussi bien dans les pays qu'au niveau de l'OMS, parce que ça a déclenché une grosse réforme des urgences. C'est à partir de là que nous avons introduit la notion d'évidence-based preparedness, comme je le disais tout à l'heure, en partant de l'analyse des risques, mais aussi dans l'analyse des gaps en termes de capacité au niveau des pays. Et je suis heureux de voir que tous les pays continuent à utiliser de façon très efficace la stratégie de surveillance intégrée et de réponse aux maladies IDSA. Et je pense que aussi bien le Nigeria, Sierra Leone, le Libéria ont mentionné le IDSA, la 3e génération. Et j'insiste beaucoup sur ça parce que c'est un élément important. C'est en fait, à mon niveau, le dernier travail que j'ai fait en Afrique avant d'aller à Genève en 2019, c'était donc la mise à jour de la stratégie de IDSA qui a été approuvée par l'ensemble des ministres. Et aujourd'hui, avec les opportunités donc, que nous avons en termes de nouvelles technologies, de digitalisation, de passer dans pratiquement tous les pays du système basé sur les papiers à un système beaucoup plus électronique. Mais malheureusement, nous avons toujours des défis de connectivité dans nos pays. Cela veut dire que la surveillance n'est pas seulement le problème du secteur de la santé. Nous devons travailler avec donc les autres ministères pour nous faciliter l'accès à des plateformes digitales et cela nous permettra, même dans les villages les plus reculés, de pouvoir faire une surveillance efficace. Parce que comme tous les intervenants l'ont mentionné, c'est dans les zones les plus reculées, les plus difficiles d'accès que les premiers signaux doivent venir. C'est de ces zones que les signaux doivent venir, sinon le système de surveillance doit être efficace. Et qu'on puisse avoir en presque réel, donc les alertes, vérifications et la confirmation des épidémies. Ensuite, pouvoir faire presque en instantané tout ce qui est analyse génomique qui nous permet de comprendre exactement de quoi nous parlons. Mais les épidémies aussi surviennent dans un contexte de systèmes de santé qui font face à plusieurs défis. Notre capacité à détecter les épidémies, mais aussi à faire les diagnostics différentiels pour prendre en charge les autres causes de maladies et de décès, extrêmement important. D'où la nécessité du renforcement institutionnel dans nos pays, d'un engagement fort de nos États. Et en termes de sécurité sanitaire, nous ne pouvons pas attendre que tout vienne de l'extérieur. Les partenariats sont importants, mais l'engagement national, les financements domestiques sont extrêmement importants. Les ressources humaines de qualité pour pouvoir faire ces analyses dont nous avons besoin, ça demande un investissement. Ça veut dire qu'il faut un plan de développement des ressources humaines dans tous les niveaux du système de santé, qu'on investisse de façon donc substantielle sur des systèmes d'information robustes, des capacités d'analyse qui nous permettent d'identifier nos priorités. Parce que si on ne le fait pas, qu'est-ce qui se passe? Nos ministres vont dans les conférences internationales, l'Assemblée mondiale de la santé, etc. Ils vont écouter et les priorités seront définies à partir d'autres pays. C'est une approche mondiale. Mais l'approche régionale, encore une fois, comme l'a si bien dit Pierre Formant, est extrêmement important. C'est à partir de nos régions, nous ne pouvons pas identifier les priorités. Nous allons au niveau mondial, nous serons juste des consommateurs. Parce que les autres régions auront déjà défini, les autres régions du monde auront défini les priorités. Donc le repositionnement de l'Afrique dans l'architecture mondiale de la santé est extrêmement important. Et ça partira de nos pays et de nos sous-régions. Merci.
Merci, Dr Saucé, pour ce petit point. À présent, la parole à l'assistance. Si vous souhaitez prendre la parole, vous levez la main, je vous la donne, vous vous présentez et vous indiquez à qui vous voulez poser la question. Bien sûr, à tout le monde sauf à moi, parce que je n'ai rien présenté. Donc, il y a une main qui est là-bas. Donc, allez-y, donnez le micro. Et je vous demande aussi d'être bref, évitez de remercier les panélistes. Ça, c'est mon travail. Donc, allez à l'essentiel.
Merci beaucoup et merci pour les bonnes présentations. J'ai 2 questions. La première, c'est par rapport, juste pour rester dans le thème.
Vous ne m'avez pas écouté, vous devez vous présenter.
Moi,
Et puis maintenant, vous posez la question et vous indiquez à qui vous voulez la poser.
Voilà, moi c'est Antoine Ndiaye. Bon, j'étais avec MSH jusqu'à un passé récent. Et donc, je suis à Dakar, je viens de Dakar. Et la question, peut-être que c'est une question qui est plus transversale. Parce que tout à l'heure, je pense quand on écoute les panélistes, c'est sorti de façon très claire que nous avons beaucoup d'expertise au niveau des pays, dans chaque pays. Et peut-être que c'est au niveau régional qu'il y aura peut-être des choses à voir et à revoir. Alors, première question, est-ce que c'est possible d'avoir cette plateforme digitale régionale qui permettra au pays de pouvoir piocher des données qui ont été vraiment élaborées dans certains de nos pays? La deuxième chose, je pense, ça a été dit par un des panélistes, il faut que nos gouvernements puissent maintenant financer les recherches. Est-ce que c'est possible? Bon, comme on parlait de common basket avec les partenaires, est-ce qu'on peut avoir aussi un common basket entre nos gouvernants pour financer les recherches au niveau de l'Afrique? Merci.
Merci, monsieur Ndiaye. Est-ce qu'on a une seconde main? Juste dans le même carré, il y a madame qui lève la main.
Thank you very much for all the speakers. And my name is Fatima Sali from Nigeria Center for Disease Control and Prevention. I'm the Director of Surveillance and Epidemiology at the Nigeria CDC. My question goes to the Professor Fal, given your experience in the public health space, because it has re-echoed, everybody has mentioned issues of internet connectivity for the digital surveillance initiative that we feel will get data real time to inform decision making. Just wondering if maybe you could tell us more, if you have some models, maybe elsewhere that work, that we could, as a region, leverage and maybe utilize. For instance, some people say the evolving internet services, people were speculating, could we also explore the satellite services? A lot of propositions, but again, how do we balance this issue of data confidentiality, data governance, compliance issues when you give away such critical information out there for every satellite service, maybe provider, to have access to. So I'm just wondering if the professor can tell us more, if he has some experience where some models work, so that we all learn and run with it. It's actually a huge challenge, limiting the digitalization of surveillance initiative. Thank you very much.
Thank you. Est-ce qu'on a encore une autre? Je prends un dernier intervenant. Ah oui, du coup, il y a plus de mains qui se lèvent maintenant. La main là-bas s'est levée avant tout le monde. Oui. Et après cette main, nous allons donner la parole aux panélistes. Donc, les autres mains, vous pouvez les baisser. Oui, vous pouvez les baisser. Donne la parole aux panélistes qui vont répondre à vos questions. Et si on a le temps, on fera une seconde liste, ce qui n'est pas garanti. Allez-y, monsieur.
Une question directe au professeur ou Ibrahim Fall. Moi, je suis Salvatore Gomez, je suis venu de la Guinée-Bissau, directeur de l'agence de presse Bissau-Guinée. Monsieur Fall, quand est-ce que l'Afrique pourrait gagner la bataille de produire réponse à 150 épidémies par an? Merci.
D'accord, merci. Je vais passer la parole aux panélistes. Je pense que la plupart des questions sont adressées au docteur Fall. Cependant, comme je suis un homme équitable, je vais demander si un autre panéliste voudrait bien prendre la parole avant que je la passe au docteur Fall. You want? OK. Donc, le docteur Hassan Mougari va prendre la parole et c'est un autre panéliste avant le docteur Fall.
Yeah, so thank you very much. I just want to respond probably partly to the first question, from the participant about regional, either regional funding and the regional system or platform for surveillance. So I believe is that we already have Ecowas, we already have WAHO. It's just an issue of focusing, on these digital platforms in terms of support in funding, but nobody, just like Prof mentioned, we have to really look for ways to fund our systems because, partners are not always going to be, it's not a sustainable kind of. So I think, but we have a platform like WAHO and Ecowas that we can, but secondly, the issue of regional digital platform. I remember there was a move by actually WAHO funding the Regional Center for Surveillance and Disease Control to, come up with a harmonized version of, data system, that cut across here. Okay. Okay, so that's just it. I'm just trying to say that I'm just reminding the Regional Center for Surveillance and Disease Control to probably continue in that path because we had a meeting trying to harmonize that regional platform. Thank you.
Sorry.
Thank you, Mr. Chair. Je ne sais pas qui s'occupe des slides, mais je voulais juste qu'on projette la slide, ma présentation où je parlais de priority number 3, building institutional capacity, institutional analytic capacity. Est-ce qu'il y a
pour avoir la diapositive de la présentation du docteur Fall.
Numéro 3.
Priorité numéro 3.
Mais 11. Ça me permet de répondre de façon transversale.
Oui,
beaucoup de choses qui sont posées ici.
S'il vous plaît, la technique qui a cette présentation, si vous l'avez, pouvez nous la mettre.
Je vais commencer en attendant.
Oui, on va commencer en espérant que...
Et nos collègues donc, du Nigeria et du Sénégal ont beaucoup parlé de plateformes digitales au niveau régional. Je pense que on ne peut pas sauter les étapes. Nous avions l'habitude de dire à l'OMS qu'il n'y a pas de mondial, s'il n'y a pas de national. There is no global without local. Et si nous n'avons pas de plateforme digitale au niveau national, comment avoir une plateforme digitale au niveau international? Et la raison pour laquelle j'ai insisté sur cette slide montrait que 80% des pays africains n'ont pas de capacité institutionnelle adéquate pour l'analyse des données. Donc, si 80% de nos pays ne l'ont pas, il est inimaginable d'avoir une plateforme solide à temps réel au niveau régional, raison pour laquelle nous devons investir sur nos capacités institutionnelles nationales et pour pouvoir aller maintenant vers des systèmes interopérables entre les pays qui peuvent servir de plateformes digitales. Et ça rejoint le problème de financement à la recherche aussi. Nous avons vu que seul moins de 2% de la recherche en santé mondiale se passe en Afrique. Parce que nous avons des systèmes tellement fragmentés. Et la plupart du temps, la recherche se passe à l'université, ou elle est supposée se passer à l'université, parce qu'elle ne se passe pas tout le temps. Hein? Il y en a beaucoup d'enseignants-chercheurs, mais ceux qui font beaucoup réellement la recherche, il n'y en a pas beaucoup. Et parce que tout simplement, c'est des systèmes fragmentés et chacun fait sa petite recherche pour publier et avancer en grade, mais pas pour changer la santé de la population, malheureusement, tout le temps. Cela veut dire que nous devons avoir des plateformes de recherche qui sont beaucoup plus collaboratives entre différentes spécialités. C'est de cela qu'on a besoin. Et tant que les équipes vont rester enfermées dans leur domaine spécifique et vont faire de petites choses, mais qui n'auront aucun impact sur la santé de la population. Et avoir des pôles régionaux maintenant solides, nationaux et régionaux solides, donc de recherche, nous permettons d'améliorer aussi le financement de la recherche. Parce que le financement de la recherche n'est pas un financement en dehors du financement de la santé. Mais si les chercheurs ne sont pas capables de montrer les valeurs ajoutées, ne sont pas capables d'influencer ce qui se passe au niveau politique, parce qu'ils apportent des évidences à partir de la recherche, il peut être très difficile de convaincre quiconque donc d'investir dans la recherche. Et cela se passe aussi dans nos institutions de recherche, comme même l'Institut Pasteur, là où je suis, où je travaille avec les collègues pour qu'ils aient une approche beaucoup plus intégrée qui montre que de la recherche donc fondamentale jusqu'à la production des diagnostics et de vaccins, nous avons une chaîne de valeur que chacun a un rôle à jouer. Cela nous permet d'avoir donc des approches de développement de proposals beaucoup plus cohérentes et qui améliorent aussi le financement de la recherche. Merci.
Merci. Vu le temps qui nous reste, je suis obligé de garder la parole. Je voudrais, avant de parler, dire merci à tous les panélistes. Merci pour vos interventions. Le sujet que nous avons à traiter était très large. Nous aurons souhaité avoir plus de temps. J'avais toute une série de questions que je n'ai pas pu vous poser. Vous imaginez, et vu le temps que nous avons. Mais cependant, nous devons retenir plusieurs choses. La première des choses que nous devons retenir, c'est que nos systèmes sont en construction. Nos systèmes sont en construction et on parle de plus en plus de systèmes régionaux. Mais le mot-clé, le professeur Fall l'a dit, c'est système national. Il faut que chaque pays développe son système avec toutes les contraintes qui ont été citées ici, notamment la contrainte de la digitalisation, la contrainte des ressources humaines, la contrainte du diagnostic, la contrainte des délais entre la surveillance et la confirmation. Nous devons, dans chaque pays, avoir des systèmes robustes. Mais pour cela, il faut qu'on travaille sur renforcer nos capacités. Ça, on le dit toujours. Mais aujourd'hui, nous devons renforcer nos capacités dans des domaines bien précis. Nous avons une surveillance basée sur le système communautaire qui, dans tous les pays, marche plus ou moins. Ils sont capables de détecter les premiers problèmes de santé, les premiers événements indésirables de santé. Ensuite, on doit être capable de faire cette alerte précoce qui va nous permettre de gagner du temps. Mais cela se fait soit par Internet, soit par téléphone mobile, de plus en plus. Mais il faut que cela aussi marche dans nos pays. C'est-à-dire qu'on est dépendant d'autres systèmes sur lesquels nous n'avons pas la main. Mais nous devons travailler avec pour que ça marche. Mais après qu'on ait fait cette alerte précoce, il y a un point qui est souvent négligé, c'est le transport de l'échantillon. Moi, j'ai vu cela dans Mpox, dans ma qualité de directeur général de la santé. Lorsque on doit prélever pour le Mpox, il y a une manière de prélever. Sinon, l'échantillon arrivé dans le laboratoire n'est pas conforme. Donc, on ne peut pas décider. Donc, il faut qu'on travaille sur comment prélever et comment transporter. C'est le rôle de nos instituts, notamment l'Institut Pasteur de Dakar, l'Institut de Pasteur d'Abidjan et aussi l'Institut de directeur qui n'est pas le directeur de l'Institut. Je ne sais pas si c'est bien ça, non, monsieur le directeur? Il n'est pas le directeur, mais c'est son institut. Bon, vous m'avez compris. Donc, c'est pour dire que voici les éléments sur lesquels on doit travailler. Transport d'échantillon. Après qu'on a transporté l'échantillon, il faut qu'on puisse faire la confirmation des cas. Aujourd'hui, l'exemple de Guinée montre que les délais sont très réduits. Malgré ça, il y a encore des délais. Et pendant ce temps, on est dans une zone de non-décision, d'incertitude. Ce n'est pas bien. Qu'est-ce qu'on fait? Donc, on doit réduire encore ce temps-là pour qu'on puisse confirmer rapidement et faire la riposte qui est associée à la maladie que nous avons trouvée. Et c'est ça qui va faire qu'on va sauver des vies. Et ensuite, quand on a fait de confirmer, de faire la riposte, il faut qu'on communique. Et pour communiquer, il faut avoir les réseaux Internet. Pour communiquer, il faut qu'on ait des téléphones mobiles. Nous avons une expérience en Côte d'Ivoire où on a remis des téléphones mobiles à des personnes. Et finalement, les datas qui étaient à l'intérieur du téléphone, ils l'ont utilisé à regarder les films sur Netflix. Au lieu de transférer les données, ils ont utilisé Netflix. Cela veut dire qu'on doit aussi on doit être conscient du travail qu'on va faire. Donc, le renforcement des capacités n'est pas seulement avoir des compétences techniques, mais aussi on doit avoir des compétences au-delà de la technique qui montrent notre engagement communautaire en termes sur la santé. Et c'est ça, aujourd'hui, qu'on nous demande, nous, acteurs du système de santé. Un point a été soulevé, mais très pudiquement, sur le financement de la santé. On l'a dit, que si nous voulons avoir financer la recherche, c'est financer la santé. Mais dans nos pays, la recherche est toujours entre deux ministères. La santé fait un bout de recherche, l'enseignement supérieur fait un bout de recherche, à tel point qu'il faut que dans chaque pays, on tombe d'accord sur comment on finance la recherche, et ensuite on pourra voir comment on va le faire de manière globale. C'est important de financer la recherche. Le professeur Fan l'a dit, et là, il nous a accusés, nous les chercheurs, enseignants. C'est vrai, on publie pour aller au CAMES. Ça, il faut le reconnaître. Mais au-delà de ça, maintenant, on ne doit pas faire que ça. On doit publier et donner des éléments pour l'aide à la décision au niveau des politiques. C'est ça le rôle de l'enseignant-chercheur, surtout de manière opérationnelle. Nous devons faire en sorte que les résultats de nos recherches puissent servir à l'aide à la décision. Mais pour ça, il faut aussi qu'on puisse s'ouvrir aux autres disciplines. Parce que le problème qu'on a, c'est que le CAMES ne compte pas l'article qui est écrit. Bon, les universités comprendront. Donc, on doit s'ouvrir aux autres disciplines pour nous permettre de partager nos expériences. Donc, vraiment, et le financement de la santé est un problème global. La santé est sous-financée. Et malheureusement, nous confions notre santé et surtout notre riposte à certains bailleurs. Nos pays devront de plus en plus prendre la charge de nos ripostes. Sans ça, on ne pourra pas avancer. Parce que ce sont nos maladies, ce sont nos parents, ce sont nos populations que nous devons soigner. Donc, je voudrais ici terminer en remerciant tous les panélistes pour cette session qui a été d'un apport appréciable. Et la question qu'a posée mon ami du Sierra Leone, qu'est-ce qu'on fait après? Et là, la question, je n'ai pas de réponse. Je vous remercie. S'il vous plaît, pouvez-vous laisser les écouteurs sur les chaises? C'est la consigne qui m'a été laissée. Merci.
Yeah. Yeah, thank you. Hello. So we're about to start the next session now. Thank you so much. I can see the last one was very exciting. I'm looking forward to the next one. Please, can we have one house for the next session? Hello, hello. So we'll start with the introduction of the next set of speakers. Okay, we'll start in the next 5 minutes to give us time to clear the hall. Thank you. Good afternoon, everybody. Welcome to this session. I'll start by calling out the presenters. Firstly, I want to call Rodrigue Macasala. If you're in the hall, can you come up, please? Thank you. Also want to call on Ola Ebuta. Are you in the hall? Ola Ebuta. Are you in the hall? Also, we're calling on Sheila Mary Ojo Ileli. Are you in the hall? Next on the list is Aniete Apan. Are you in the hall? Adetumi Shubulade. Are you in the hall? Opachi Abba. Are you in the hall? Perfect. Abigail Abankwa. Is she in the hall? And the last but not the least, Yetunde Abioye. So good afternoon once again. My name is Chimezi Ayakora. I'm going to be chairing this session. The way we want to run it is that we're going to let everybody, half of the 3 people speak first. We'll take a few questions. The remaining 3 will speak, and then we'll have a more interactive session before we go. I know we've lost a lot of time, but we'll do our best to stick to time. Make sure we finish before, by 1:30, but I will be very strict with timing. Thank you so much again. We'll start with Rodrigue, if you're ready. Thank you so much.
Ok, merci beaucoup. C'est un plaisir pour moi de partager avec vous le résultat de notre recherche. Alors, je m'appelle Rodrigue Nakasala, je suis médecin-chercheur en santé publique et en laboratoire en République démocratique du Congo. So, yeah. Alors, notre étude... Notre recherche porte sur l'étude des facteurs associés à l'acceptabilité du vaccin contre le coronavirus en République démocratique du Congo dans la ville de Kinshasa chez les adultes en 2022. Sorry, please slide. Yeah. Please. D'accord.
071. Sorry for the technical error. We'll start then with next person. Ebuta, are you ready? Okay, good. Perfect. Thank you.
Good morning, everybody. My name is Ola Ebita, and I'm from Ira Specialist Teaching Hospital. I'll be presenting strengthening outbreak response in West Africa. This is from a Nigerian simulation study. Okay, please, can I have the next slide? So recurrent outbreaks of emerging and re-emerging diseases is something that we do that we should prepare against. And now, because of the globalization and interconnectedness of countries, diseases can spread from one country to the other. And so we have to be very prepared to fight these epidemics. Simulation exercises are one method to prepare for epidemics because it assesses the response mechanism of our institution, identified gaps. But in Nigeria and West Africa, field simulation exercises are very limited. Next slide, please. So, Ira Specialist Teaching Hospital, in collaboration with the Federal Ministry of Health, conducted a field simulation study, field simulation exercise between 10th to 12th February 2025 in order to assess the reproducibility of the World Health Organization simulation exercise cycle, to evaluate our outbreak response procedures, and to test coordination of ICH emergency response team, identifying areas for improvement. Next slide, please. So the method used was the WHO simulation exercise cycle, which is divided into the pre-exercise, the exercise conduct, and the post-exercise phase. For the pre-exercise phase, this lasted for about 7 months. And what we did was scoping of the exercise. We wrote down some concept notes to know what we're going to do. Then there was establishment of the exercise management team who brought out a plan. After bringing out this plan, they identified participants, the evaluators and the observers who are going to be involved in the team, in the exercise. Furthermore, we developed materials such as the master scenario. We also developed evaluation checklists. And during the phase, we also contacted stakeholders. We had a stakeholder engagement, which was very key in leading these community members and even politicians to accept this simulation exercise. Then we set up the venue. We deployed our mobile laboratory and we set up our emergency coordination systems. For the exercise phase, this lasted for 2 days. And we had an opening ceremony, media briefings, and then activated the response structures. This time around, we simulated multiple cases of Sudan virus disease. And when the activation was started, every person in the team, consisting of pillars such as the IPC, the coordination team, logistics, case management, all had an activity to replicate during that period. Then for the post-exercise, we had a post-exercise debriefing after an initial debrief had been done. And we also had to write report and also close down the project. Next slide, please. So the results, we confirmed that the WHO simulation cycle was actually reproducible in a rural setting in Nigeria. And due to the planning that we put in, therefore we put on in the planning and stakeholder engagement, we had acceptance from the community. There was a little bit of resistance, but that was brought down because they were made aware, and they were also told that this is not a real epidemic, but just a simulation in case something like this comes into their community. And then for the evaluators themselves, as I've told you before, looked at the performance of each pillar, and they scored us looking at the checklist that the WHO had provided. And each pillar in our team, the mobile lab, scored the highest. They were actually very prepared and always very prepared for epidemics. The coordination, the infection prevention, the case management, and risk communication all had an average of 80%. Next slide, please. But we had some gaps. These gaps included limited communication, and this was because of lack of internet activity in the rural area. So it actually reduced our performance communication-wise. And then there was also poor control access at the isolation ward. The media that we invited while trying to capture some of these, some of the activities that happened during the event, tended to enter into the isolation ward, and so the access was poor. That was a lesson we learned on how to control the gap, control the crowdiness. Then also, the evaluators noticed that even though we had waste bins in the isolation ward, in the lab, and in the triage center, triage stations, we didn't have any centralized waste management system, and that was the gap that was told to us. And of course, during the operation, we had vehicle breakdown. Next slide, please. In conclusion, the exercise demonstrated the reproducibility of the WHO simulation exercise. It tested the preparedness of our institution in managing a highly infectious disease outbreak, and it revealed our institution's strengths and gap. Recommendation. Next slide, please. So, we will recommend that there should be a replication of field simulation in all Nigerian states and the West African sub-region as a whole, so that we can strengthen our epidemic preparedness. Also, there should be a sustained national funding for future simulation, especially in Nigeria. This will help build capacity, enhance communication tools, and strengthen logistics. Next slide, please. Next slide, please. We'd like to appreciate the ISTH management. I'd also like to appreciate the Federal Ministry of Health for working with us, all the partners, all the participants, all the evaluators. We say thank you for being with us. And the community, the rural community, we cannot forget them. Thank you very much.
Thank you so much, Dr. Ebuta. So we'll go straight to Rodriguez. Thank you.
Ok, merci beaucoup. On s'excuse pour ce désagrément de la technique. Alors, moi, c'est Rodrigue Nakasala. Je suis chercheur en santé publique et en laboratoire en République démocratique du Congo. C'est un plaisir pour moi de partager avec vous le résultat de notre recherche sur l'étude des facteurs associés à l'acceptabilité du vaccin contre le coronavirus à Kinshasa, en République démocratique du Congo, du 1er au 31 décembre 2022. Slide, please. Next, please. Alors, en guise d'introduction, la maladie à coronavirus était une pandémie mondiale causée par le SARS de type 2. Et en Afrique subsaharienne et surtout principalement en République démocratique du Congo, le plus grand challenge reste l'acceptation de la vaccination auprès de nos populations. Et c'est dans ce contexte que notre étude a été menée, principalement à Kinshasa, dans la ville de Kinshasa, pour identifier les différents facteurs associés à l'acceptabilité de la vaccination contre le coronavirus. Slide, please. Alors, notre étude a pour objectif de déterminer, premièrement, la couverture ou le taux de la couverture de la vaccination dans la commune de Lemba à Kinshasa en 2022 et d'identifier les différents facteurs associés à l'acceptabilité de la vaccination contre le virus. Slide, please. Alors, en termes de méthodologie, nous avons mené une étude descriptive et analytique allant du 1er au 31 décembre 2022 à Kinshasa, spécifiquement dans la commune de Lemba. Et nous avons fait un échantillonnage à deux niveaux. Le premier niveau a constitué à la sélection de ménages à enquêter ou à étudier. Et puis, le deuxième niveau a constitué à la sélection des candidats ou des patients devaient intégrer l'étude. Alors, les résultats collectés ont été saisis sur EpiInfo et l'analyse a été réalisée grâce au logiciel R et grâce à la régression logistique. Slide, please. Alors, en ce qui concerne le résultat, notre étude révèle que l'âge de la population étudiée s'étendait de 17 ans à 70 ans, avec un âge moyen de 35 ans. La majorité des patients concernés à l'étude avaient un âge compris entre 25 et 59 ans, c'est-à-dire jeunes, soit une fréquence de 93%. Et la majorité des participants étaient des sexes féminins, soit 71,5%. Et le taux de vaccination ou le taux de la couverture vaccinale contre le vaccin à la COVID-19 était de 43,4%. Et la majeure partie de la population qui ont fait la cohorte de l'étude était du niveau supérieur ou universitaire. Slide, please. Alors, en ce qui concerne les différents facteurs identifiés, premièrement, nous avons identifié comme facteurs associés à l'acceptabilité du vaccin contre le coronavirus l'exposition aux désinformations ou aux mauvaises informations en provenance des réseaux sociaux et des médias classiques. Alors, le deuxième facteur identifié était la proximité du lieu ou du centre de vaccination qui a été significativement associée à l'acceptabilité du vaccin contre le coronavirus, avec un autre ratio ajusté à 0,93% et un intervalle de confiance compris entre 0,36 et 0,91. Alors, les autres facteurs identifiés n'étaient pas significativement associés à l'acceptabilité du vaccin contre le coronavirus. Slide, please. En guise de conclusion, nous retenons ceci. Plusieurs facteurs ont été identifiés par rapport à l'acceptabilité de la vaccination contre le coronavirus au sein de notre population. Il est important d'agir sur ces différents facteurs pour améliorer non seulement la couverture vaccinale, mais aussi l'acceptabilité vaccinale au sein de nos populations. Comme le disait l'un de nos maîtres, le professeur Mouyembe, je cite, c'est que la République démocratique du Congo n'a pas seulement des richesses minières ou de richesses en termes de minéraux, mais il a aussi une certaine richesse en termes de virus. Alors, il faudra mieux agir sur la vaccination pour essayer d'atténuer ces différents virus. Slide, please. En termes de recommandations, nous avons reformulé nos recommandations à 3 niveaux. Premièrement, à la population générale. Nous avons recommandé à la population générale de croire à la vaccination car c'est le moyen le plus efficace pour lutter contre certaines maladies évitables par la vaccination. Et deuxièmement, nous avons recommandé au personnel soignant de bien expliquer et d'informer aux patients sur l'importance de la vaccination, le bien fondé de la vaccination. Et troisièmement, au ministère de la Santé de la République démocratique du Congo, nous leur avons recommandé d'élaborer un plan de communication efficace qui décrit clairement l'importance des bienfaits de la vaccination pour améliorer la vaccination au sein de nos populations. Slide, please. Slide. Next. Je chuterai par remercier Ecowas qui nous a donné cette opportunité de présenter nos recherches. Et puis, je remercierai le ministère de la Santé de la RDC. Et une pensée en ce moment où nous sommes en train de présenter, il y a encore un autre cas d'Ebola qui est déclaré dans une autre province. Alors, toutes mes pensées vont aux personnes qui sont atteintes et nos remerciements aux agents de santé qui sont en pleine action pour lutter contre cette épidémie. Merci.
So much, Dr. Rodriguez. I think we are doing very well with time. So I call Dr. Sheila to present. Thank you.
Good afternoon, everyone. Good afternoon, everyone. Okay, so good afternoon, everyone. My name is Dr. Sheila. I'm a pediatrician, infectious disease from Ira Specialist Teaching Hospital. I'm presenting the indications and potential diagnostic utility of lumbar puncture in the management of non-neonatal pediatric Lassa virus disease. Next slide, please. So there have been reports of discrepancy and discordance between CSF and plasma PCR results for Lassa virus disease. And these reports so far have raised issues which range from diagnostic, because the diagnosis will be delayed, to therapeutic, because delayed diagnosis will result in delayed onset of treatment or even inappropriate treatment, to prognostic issues. Delayed treatment means delayed onset of treatment means severity of the disease increases, and then that gives room for poor prognosis, which usually is seen in severe disease. And then public health importance, which will need urgent answers. Public health importance is because the delayed diagnosis up to treatment prognosis will result in issues with data collection, surveillance, and then it can even evade or erode public trust. Among these, the need for lumbar puncture in management of Lassa virus disease has been poorly researched, especially in children. Next slide, please. The aim of this study, the broad aim, was to define the place of lumbar puncture in the diagnosis of pediatric Lassa virus disease. And then the specific aims to estimate the size of the phenomenon of plasma CSF discordance, as well as to define the clinical correlates of the discordance. Next slide. Next slide. It was an observational study, took place between 2017 and 2023. Children were aged 1 month to 18 years. Children recruited were Lassa virus positive for either plasma and or cerebrospinal fluid. The lumbar puncture was done according to extant indications for children normally. And then a diagnosis of Lassa meningitis in this case was made by the presence of CSF pleocytosis with positive Lassa virus PCR. We identified 3 groups of patients: those who had Lassa virus meningitis alone, those who had Lassa viremia alone, and then those who had the dual Lassa viremia and meningitis. Comparisons were done using chi-square and Fisher's exact test. P-values less than 0.05 were taken as significant. Next slide, please. So from here, we had 87 children who had lumbar punctures of the total of 409 cases, but we had complete data for only 76. And out of these 76, 78% had meningitis after lumbar puncture, while 22% did not have meningitis. Of note is that among the 78% who had meningitis, 65% were both plasma and CSF positive, while 13% were plasma negative but CSF positive. Also, among these who had meningitis, now trying to look at the clinical correlates, we found out that among the various symptoms used to diagnose meningitis, one of which is typical meningeal signs, we found out that 85% of children with typical meningeal signs had meningitis. The other 15% had meningeal signs, but there was no meningitis from our diagnostic criteria. While 67% of those without typical meningeal signs had meningitis. Now, going to those who had only typical meningeal signs, those who had typical meningeal signs, 61% of them had meningitis, while 35% with the typical meningeal signs did not have meningitis. So it goes to say that typical meningeal signs may not be the only presentation for meningitis. Next slide, please. Now, looking at this slide, it shows us the relationship between the diagnostic grouping and clinical presentation. Here we see that headache had the highest proportion here across all groups. We have 3 groups, those who were both plasma and CSF positive, those who were plasma positive and CSF negative, and then those who were plasma negative and CSF positive. Now, headache had the highest prevalence across all the symptoms, but it's also important to note that all these neurological symptoms were more prevalent among those who had both plasma positive and CSF positive viremia. Then photophobia, on the other hand, was highest among those who were plasma positive and CSF positive, followed by those who were plasma negative and CSF positive. But it wasn't seen in those who were CSF negative, showing that it's a very specific sign for CSF meningitis, Lassa meningitis. Now, going to the table, we assess the diagnostic values of these symptoms, and they all had high diagnostic value. But of note is that photophobia had the highest positive predictive value, telling us that it is very useful in the diagnosis of Lassa meningitis. Next slide. Go on. Just go on. So in conclusion, we are saying that Lassa virus meningitis is common in children with Lassa virus disease and should not be overlooked, especially in those who will not present with the typical meningeal signs. However, we are saying that testing only plasma without concomitantly testing the CSF could actually miss a number of patients, in this case 20%, and reliance on typical meningeal signs alone could also miss patients with Lassa meningitis in about 37% of cases. Next slide. Now, we're recommending a high index of suspicion in patients who have meningitis to not just think of bacterial, but also viral meningitis, and in endemic areas, Lassa meningitis. We also recommend wider studies, broader studies on the impact of Lassa virus meningitis to the entire treatment of every patient presenting with Lassa virus disease, so that this can guide further review of our standard of care in patients with Lassa virus disease. Thank you. So my acknowledgements go to, please next slide. My acknowledgements go to IRA Specialist Teaching Hospital as a whole. My CMD is here present, I acknowledge him. Professor Akpede is also here, I acknowledge him, and then all other persons in the team, as well as the Federal Ministry of Health, West Africa Health Organization, for this opportunity to be here and to make this presentation, BNITM, ARCWA, as well as the NCDC. Thank you very much.
So thank you so much. I think we have one more presentation before we have a break to discuss what we've done so far. So I call on Odetunji to present. Thank you. Odetumi.
Good afternoon, everyone. 103. Slide 103. No. Slide 103. Yes, sir. All right. That's okay. No problem.
So good afternoon, colleagues and senior colleagues in the House. Permit me to stand on the already established protocol. So this afternoon, we're going to look at the epidemiological analysis of Lassa fever in Ebonyi State, Nigeria, taking a look at data from 2020 to 2025. And we're going to have an in-depth on trends, demographic symptoms, patterns, and then the outcome. My name is Akpan Anyetie Emmanuel from the Nigerian Center for Disease Control and Prevention, doubling as a Deputy Incident Manager for Lassa fever. Next slide, please. All right, basically, we have all heard a lot about Lassa fever in the past few days. So Lassa fever still remains endemic and remains a major concern, a public health threat, especially in Nigeria and West Africa as a whole. But it's evidence for us to note that Lassa fever is common in Nigeria. We have in Ondo, Edo, Taraba, as well as Ebonyi and Bauchi State. So today we're going to dwell on what is happening in Ebonyi State. Basically, we're going to look for the need for us to have a target surveillance interventions, early detections, and localized interventions in this high-risk settlement. So next slide, please. So basically, the objective is this, it's clear. It's to conduct epidemiological analysis of laboratory confirmed cases of Lassa fever in Ebonyi State from 2020 to 2025, and then describe the temporal trend in the incidents and distributions of Lassa fever in Ebonyi State. And then we're going to look at the pattern associated with infection and then the outcome. And we're going to examine common clinical symptoms as well as their association with patient outcomes. And then we're going to look at seasonal trend and transmission patterns to support preparedness and control strategies. Next slide, please. So basically, we applied a method, and this is what the method looks like. We had a retrospective of national studies of Lassa fever in Ebonyi State for the confirmed Lassa fever cases from the year 2020 to 2025. And then we employed descriptive statistics using chi-squares, logistic regression analysis, and then the mapping. So we use a geospatial mapping to look at the areas that were highly infected. So if you look at the map on your right or left, depending on where you're coming from, so you see that we have about 5 or 6 local government in Ebonyi that over the past 5 years has shown to have significant increase in number of confirmed cases. So we also look at variable analysis to include the demographic factors such as the age and sex, distribution and clinical symptoms, and patient outcome. Next slide, please. So we had a finding, and these are our findings. So we had about 297 confirmed cases that were used for the studies. And then out of these 297 studies, the year 2020 present with a high burden, which represents 31.3%. And this could account for, we all know the reason, because there were heightening of surveillance in the year 2020 as a result of COVID-19 pandemic. But then what is to note is that there's no significant difference in terms of gender. So there's no difference between male and female, but then there was a significant difference in age group, which attributed that age between 20 to 40 were mostly affected. But then something to also note is the common symptoms, which fever tops the charts to show that 94.3% of the patients presented in the facility had fever, and 80% had fatigue, and then 64% had abdominal pain. Then for the severe symptoms like that leads to mortality, we have bleeding to top 24% and sepsis with 21.7%, with a significant p-value less than 0.005, giving us a case rate fatality at 3.4%. Next slide, please. So basically, like I said earlier on, the age between 20 to 40 account for the highest number. And then the outcome distributions of our confirmed cases, like I said earlier on, we have bleeding and sepsis, which account for most causes of death, and we have 43.4% mortality rate. Next slide, please. So this is just a trend analysis of what happened in the past 5 years. And if you look at this trend analysis, it peaks from January and starts declining sometimes in April, May, depending on the year of the outbreak. But it's very common from January to March. Next slide, please. So in conclusion, next slide. Lassa fever poses a significant public health concern in Ebonyi State with 297 confirmed cases with a case fatality rate of 43.4%. And then it peaks in 2020, and particularly in Abakaliki LGA. So the common symptoms we've talked about include the fever, fatigue, and abdominal pain, with bleeding and sepsis associated with increased mortality. the seasonal peaks between December to March and suggesting rodent transmission during this dry season. And then we know that there's no difference between the gender, but this points that we need to intense our surveillance. But then we have the high risk group, which is the age. There are difference, which age group has shown that 20 to 40 age has been of high risk. Next slide, please. Next slide. So these are recommendations. So basically, this data were driven from data that was generated for surveillance purposes. So basically, the data tools that were used to generate this data were IDSR, Integrated Disease Surveillance Response, as well as Surveillance Outbreak Response Management Analysis System, which is the SOMAS. So basically, these were the recommendations. We need to look closely at our data to improve on timeliness as well as completeness of the data. This data had a whole lot of variables that maybe were not supposed to be there. So people collecting this data could not collect all the variables. So we have to expand our community-based surveillance. There's an existing community-based surveillance, but basically we're not going to have equal distributions in high burden LGA as those LGA that are not well affected. So we have to establish regular data quality audits to reduce demographic and clinical informations, and then we'll support operational research into driving of high case fatality rate and seasonal transmission dynamics in Ebonyi State. Next slide, please. So basically, I want to acknowledge the Ebonyi State Ministry of Health, particularly the epidemiological unit, for their support throughout this work, and also to support the National Incident Manager, Dr. Yetunde, as well as my colleagues, Dr. Nanvel, Emmanuel, and Udwa, who has also continued to support this process. So thank you very much. God bless you.
Thank you so much. So I think we're going to take a 10 minutes a question and answer session before we continue. We have 3 more to go. So for 10 minutes, the floor is open. Any question for the 4 presenters so far? We'll take first 3 and then afterwards 1, 2, and 3.
Thank you very much for the beautiful presentation. My first question goes to the first speaker. I want to believe what was the simulation exercise was operational based. So I want to know, is it the full scale or functional exercise? And also I saw a place EOC. Does that facility run EOC or your reports based on the channel of data flow regarding surveillance system in the country? Then for the second speaker, part of the risk factor when you're talking about vaccine hesitancy, you made mention of exposure to misinformation using social media. I want to know, is all the respondents literate? So I may be concerned for them to have access to social media. So that's that. Then lastly, third speaker, you talk about the issue that has to do with use of plasma and CSF. My worry is that you said non-neonatal. So when I saw the area of symptoms like headache, I'm a bit worried. I was thinking we should have had maybe those that reported headache, because you don't expect 3-month-old child, 6 months, 12 months to report headache, or even 1 year. So we will have look at those symptoms in age group to know those that reported that. So I don't need clarification on that, because I don't expect a 6-month child, 12 months to talk, say I'm feeling again. Thank you very much.
Gentleman, no, somebody got 3 already. If second one is there and third one is in gentleman in suit, so I can give him since you're already there.
Thank you very much. I think first one must commend all the presenters, made very lucid presentations, and in particular the one on simulation, which I join in advocating that it indeed, not just countrywide, but around the sub-region and indeed all over. Specifically, the presenter from the presentation from the DRC. Female-male ratio was a 4-to-1. I think you should say something about that. How do you explain that? Would that still be representative of the population you have? And then the presentation from Boeing, Dr. Anieche, a curious one, particularly as you say you're from the federal ministry or you work in Abuja. So somebody starts to wonder, what was the special interest in concerning Ebonyi? Gets the background that virtually all the states in the country are having Lassa fever. And as you rightly said, yes, there are some other hotspot states that you did not include, but decided to focus on Ebonyi. Then secondly, you said severe symptoms. And then you mentioned sepsis as one of them. Again, one is curious, what do you mean by sepsis? Since Lassa virus disease it's a form of sepsis. If you meant bacterial sepsis, how was this identified? And finally, when you said high risk of, you said high risk age group, 20 to 30 or something. Was it high risk for prevalence or high risk for mortality? And final one, sir, to Dr. Lily. You need to make a bit of clarity required to the recommendations. You looked at the potential, is it use or utility of lumbar taps, but your recommendation was on the need to look further at treatment. You need some explaining. Thank you.
The last question. Go to the body. Okay.
Thank you very much, presenters. For the first presenter on the simulation exercise, I have a few questions. First of all, sorry, my name is Dr. Abaye, Bayelsa State epidemiologist. What was the, you said you worked with the Federal Ministry of Health to conduct the simulation exercise. Which department in the Federal Ministry of Health did you work with? And why did you not work with the Nigeria Center for Disease Control? Secondly, what was the role of WHO and the NCDC in this simulation exercise and the report writing finally? WHO, NCDC, and FMOH, yes. Then for the other presenter on Lassa meningitis, am I correct to take home that your study implies that 80% of Lassa meningitis in non-neonatal pediatric patients typically present with typical meningeal signs, while only about 20% do not? I need to be sure I'm taking home the right conclusion. Then, did you differentiate in this patient between meningitis and encephalitis? Because we need to be sure what is really responsible for this discordance in typical meningeal signs. Thank you.
Thank you so much. We're going to get the answers. Please, we need 2 minutes for each answer. Thank you. Start for.
OK, merci beaucoup pour vos questions. Je commencerai par la première question concernant les informations ou les désinformations provenant des réseaux sociaux. Ce qu'il faut savoir, c'est déjà une étude descriptive et analytique qui a fait au préalable un questionnaire d'enquête qui décrivait les informations liées aux sources d'informations par rapport à la vaccination. Et les enquêteurs qui ont été formés, qui sont descendus sur le terrain, ils ont posé des questions dans le ménage par rapport aux informations que les gens recevaient sur la vaccination. Alors, en analysant tous ces questionnaires, on se rend compte que la plupart de mauvaises informations ou de désinformations provenaient des réseaux sociaux. Ça, c'est la première chose par rapport aux informations en provenance des réseaux sociaux. Alors, la deuxième question, c'est par rapport à la population étude. Je pense que l'étude a été menée dans une commune de la ville de Kinshasa, qui est l'une de 24 communes de la ville de Kinshasa, qui a une forte densité. Et l'échantillonnage a été réalisé, comme on l'a expliqué, à deux niveaux. Le premier niveau a concerné la sélection de ménages à enquêter ou à questionner. Et puis, le deuxième niveau a plus concerné les personnes répondant aux critères. C'est vrai, la ménage peut être sélectionnée, mais on passe à la deuxième étape, on sélectionne les personnes répondant aux critères par rapport à ces différents par rapport aux critères exigés par rapport à l'étude. Alors, ce sont ces deux éléments-là qui nous ont orientés par rapport à la constitution de l'échantillonnage. Mais il faudra retenir que c'est un échantillonnage aléatoire réalisé. Merci.
Thank you.
Thank you very much for your questions and comments. So the first question talks about children under 2 years, how they presented, since they do not present with the symptoms, the neurological symptoms presented. Yes, so children under 2 years can present with lethargy. Also, there were other features like excessive inconsolable cry and then bulging, tense, anterior fontanelle. However, these were minimal and were taken care of in the initial phase of the analysis. They were not excluded. Also, the second comment talks about clarifying my recommendations. So the recommendation explains is one will argue in two directions. Should we now do LP for every patient suspected to have Lassa fever so as to detect Lassa meningitis, or shouldn't we? Now, what we are saying is that we need larger studies to be done so that we can assess if children who have Lassa meningitis recover the same way for the same duration of treatment as those without Lassa meningitis, and there's no other neurological complication, then there will be no need going to do LP for everybody. So we're talking about larger studies to actually detect what is the impact of Lassa meningitis on these children. Then also someone asked about 80% of typical meningeal signs. So yes, for children who typically above 2 years present with typical meningeal signs, we are saying that 80% of those, when looking at meningitis, 80% of those who had meningitis presented with typical meningeal signs. However, not all those who had typical meningeal signs had meningitis, but all these were factored into the age group of these children. And difference between if we screened for encephalitis. So there's a very thin line between these two. However, we had clinical features and complaints which improved our suspicion of meningitis. And then we went ahead and using our criteria, CSF pleocytosis and Lassa virus PCR positive, made the diagnosis of meningitis. However, children with complicated meningitis will also present similarly, just like encephalitis. So it's a very thin line between them. Thank you.
All right, thank you very much for the questions, and I'm happy to know that people were listening to me when I was speaking. So basically, the first question is what informed us decision to conduct this study in Ebonyi State? Looking at, we have like 5 states in Nigeria that are reporting high burden. So basically, one of the reasons was there's high mortality rate reported in the year 2020. And there's also a sharp decline in number of cases reported in 2025, the same period of years. So we try to look at what is really happening when we follow the trend of reporting. So let's look at their data. And the data pointed that this report had just been restricted between 3 local governments, Abakaliki, Izi, as well as Izal and not something like, sorry, I'm not too familiar with their names. So these 3 local governments, over the 5 years of review, had been the burden where these reports had been coming outflow. So we try to deep. Why do we have a decline? In this case, are we winning the fight against Lassa fever in this community? And then that's another study that we need to put up to talk about. So when I talk about at-risk population, 20 to 40, there are population that we noticed that when we were doing data analysis that 70% of the burden of Lassa fever were within this population. So the 20 to 40 are the at-risk population. And so our searchlights, our targeted communications, our targeted risk communication is between this age 20 to 40, because we noticed that from 50 to 60 is less than 15%, which we know that we can do much on them, and compared to 20 to 40 because they are younger and they are vibrant. So when you talk of sepsis is the complications that result in a severe Lassa fever, and then sometimes it leads to organs damage. So when we do our case analysis, we looked at 21.7% of the diseased patients had sepsis, and that called for concern. That means they were presented late. In most cases, they presented late, and maybe so other comorbid conditions were involved. Thank you very much.
Thank you very much for the questions and comments. So I'll take the first questions, which asked whether the simulation exercise was a functional exercise or a full scale. So the exercise was a field simulation exercise, and it is grouped together with the full scale. It is higher than the functional exercise. So that is what we did. The difference between it and the full scale is that for the full scale, it can take much more time for planning and sometimes for execution. But apart from that, the same kind of resources, money and human resources otherwise are needed. Then again, there was a question on EOC, whether EOCs, that he's not head of EOCs in institutions. They're not supposed to be in the national or states. Yes, it is EOCs, as we know, is supposed to be in the national and state, but an institution can have an emergency operations center where you can coordinate your response activities. When you have investigated, you need to have data, you need to talk about the things you've done, like have your action reviews. Emergency operations centers can also help us do that. Then for the question on the department we worked in the Federal Ministry of Health, well, the collaboration was with the Federal Ministry of Health as a whole. The coordinating minister of Health and Social Welfare expressly gave an approval to the institution to conduct the simulation exercise, and NCDC was also on it, yes. And if I didn't acknowledge, that was my own mistake. I'm sorry about that. Then I don't know whether if I got this question correctly, the role of WHO and FMOH in the report writing. Okay, yeah. So the federal ministry, first of all, the WHO, we used their tools to conduct this exercise. So we leaned on their know-how, and we also had the go ahead of the WHO in those states to conduct this study, to conduct this exercise. For the Federal Ministry of Health, yeah, they sent us evaluators, and they were there to observe too, as well as the report that was written is with them. Thank you very much.
So much. So we'll go straight to the next presenter, Dr. Adetunji. Thank you.
Good afternoon, everyone. One zero three. All right, thank you. So good afternoon, everyone. I'm Dr. Adetumi Shulade, an epidemiologist and biostatistician from Federal Medical Center, Owerri, State, Nigeria. And I'll be presenting on behalf of the other authors here on the title, A Specific Seroprevalence Trend of Anti-Lassa Virus Antibodies a prospective quad study in Ondo State, Nigeria. Next slide. All right, as a way of introduction, where this has been said several times, Lassa fever infection is endemic in Nigeria, as we all know, and with highest burden, Ondo State is in southwest of Nigeria, Bauchi in northeast, Edo in south-south, Taraba also in northeast of Nigeria, and Ebonyi in southeast. Seroprevalence studies on anti-Lassa virus, IgG antibodies, provide valuable insights into patterns of exposure, to Lassa virus infection and the cumulative risk of transmission over time. The intensity of transmission across different age groups is however essential for development of appropriate targeted intervention through the vaccine. Next slide. So the objectives of the study were to assess the baseline seropositivity prevalence of Lassa virus specific antibodies, and also to assess the age-specific prevalence of seropositives at baseline and over time. Next slide. The study design was a 24 months prospective core study conducted in 10 communities in 3 local government areas of Ondo State from November 2020 to November 2022. And 2-stage cluster sampling was used to enroll 1,008 participants above 2 years old. Blood samples were collected at 6-monthly interval at baseline, 6 months, 12, 18, and 24 months, following informed consent. And the samples were analyzed for anti-Lassa virus IgG using a Lassa technique. The data was analyzed using SPSS version 27. Next slide. Now, if you look at this is a horizontal bar chart, showing the seroprevalence of the antibody at baseline and follow-up periods. Some things are striking here. At the baseline, we have high seroprevalence of the antibodies at 5.1%. And with a seroconversion risk of 10.2%. And one thing that you also notice here is that the immunity over the periods was waving. We have an increase at 6 months to 45.3%. However, we have a decrease at 30.2 at 12 months, then a minor increase, then eventually just a little decrease at 24 months. And this is showing that the immunity is not a lifelong immunity across the 1,008 participants. And also there is an evidence of sustained immunity, most likely due to the current infection. Next slide. And if you look at this is also horizontal bar charts, showing the seroprevalence of the immunity IgG across different age groups, and which is very important. The first thing you notice here, you will see from 2 to 5 years to 18 to 50 years, there is this pattern of increasing immunity in that along the line. And for 2 to 5 years, they had a 13.3%, and which could be because of the naive immunity for this age group, and also due to reduced immunity, reduced activity, to exposure to activities that could enhance transmission, maybe rodent to man or man to man. And we expect that as we increase in age, of course, activities increase. And you can see that in the trend of the pattern. And which takes its peak at 80 to 50 years, where we have 91.3%. And this is an active working age group, of course. Majority of the people in this conference will be within this age group of 18 to 50 years. And this a group that are very active, they engage in activities that will actually expose them to transmission of the infection. And another thing you will notice is those above 50 years, there is this decrease in the pattern to 30.6%. Yes, because at this age, there are comorbidities, of course, that could lead to complications in Lassa fever diseases, and that will lead to increase in mortality. And again, we can also talk of Lassa virus immunity reversion at this age. And you also remember, from this age above, activities will also reduce. Next slide. Now, we can look at this trend as well. This is just multiple line charts showing the seroprevalence trend across different age groups over the study period. And one thing I want us to take note of is the trend, the blue trend. That is showing the trend for 2 to 5 years. I said earlier, because of their naive immunity, that makes it to be very low, that's 90.7 and reduced activity. But one thing that is striking is a sudden increase over 6 months to 74.6%. Yes, this is a high seroconversion rate among this age group. And one thing is important, is actually a pointer and an opportunity for vaccination at this age group. And that that will still take us later to one of the recommendations. When we have early vaccination at this age group, there is going to be a fast seroprevalence response in the vaccination. And you will also notice a decline over the 6 months. Yes, we also have, in this age group, we also have the immunity reversion as well. That's waning immunity. And one thing that we can also take home from here is it's also a pointer for an opportunity for booster vaccination. All right. You can notice for other trends, in older age groups, especially the adults, there is little to minimal changes in the trend. And that is very common in endemic setting because it's showing sustained immunity, over the period. I've said it earlier, sustained immunity is most likely sustained through recurrent infection. Next slide. All right. In conclusion, low prevalence among children and adolescents highlights a huge susceptible population that remains at risk of future infection, underscoring the need for preventive measures like vaccination early in life. And the progressive rise in seroprevalence with age reflects cumulative exposure and sustained transmission in an endemic setting with recurring outbreaks. And lastly, the high trend in older adults indicates that most individuals acquire infection at some point in their lifetime, reinforcing the concept of lifelong exposure risk in endemic communities. Next slide. These findings have significant policy relevance for the design of vaccination strategies when the vaccines are ready and broader epidemic preparedness in endemic setting. And these are our recommendations. Targeting vaccination to younger populations before significant exposure is important because it may provide a significant long-term benefit for the community. Secondly, vaccination coverage to adults could reduce overall transmission and protect high-risk groups, of course, we as care workers, caregivers, and may accelerate community-level protection, that's herd immunity. And lastly, understanding the age-specific seroprevalence trend provides critical evidence for designing effective vaccination strategies in endemic regions. Last slide. Yeah, the authors, on behalf of the authors, would like to acknowledge, sorry, I sent a slide earlier, or maybe it's not here. This is actually from the 1.0 study. So we'd like to acknowledge CEPI, P95, NCDC, Macro, Epicenter, and the management of Federal Medical Center. Thank you. Merci à tous. Thank you so much. So straight to Dr. Abba.
Good afternoon, the session chairman, the co-presenters, very senior colleagues, ladies and gentlemen. I'm Okwache Abba. Here, I'm happy to share outputs from the Nigeria Field Epidemiology Training Program at the Nigeria Center for Disease Control between 2022 and 2024, when I served as the National Deputy Incident Manager. I'm happy the incident manager is here and the new deputy too on the stage. So evaluating Lassa fever surveillance system in Kogi State. Sorry, the title? Well, you have seen that. So we are evaluating Lassa fever surveillance in Kogi State between 2022 and 2024. It is not overflogged. Lassa remains a major public health concern in Nigeria. And in 2024 alone, there were over 10,000 suspected cases, 1,309 confirmed cases, and unfortunately 214 deaths. You've seen it in numbers. Yes, it's numbers, but these are brothers, sisters, fathers, mothers, cousins, school children who didn't return to school. And it is something that all hands will have to remain on deck for. Why is it important for us to evaluate a surveillance system? Yes, public health data helps in monitoring interventions, helps in designing control measures, and of course, bringing it down to Kogi State. It is important to identify the strengths and weaknesses of the system. I wouldn't let the researcher here ask me the question, why Kogi State, like they have asked someone. So I'll be quick to go to the next slide and tell you why Kogi State. So next slide, please. So Kogi State is somewhere in the north central in Nigeria. Nigeria has 36 states and the Federal Capital Territory, making 37 regions also, so to call it states. It is the only state that shares boundaries with 10 other states. That's the highest number. And very importantly, it is a link between the north and the south. It is a transit state. Then it also ranked fourth in the number in confirmed cases. It came fourth nationally in the year 2021. We have seen Ebonyi, Taraba, and Ondo Edo, taking the spotlight, but it came up as the top top 5 for that state, and this is why, and has had recurrent outbreaks since then. So this is why the focus came to Kogi State. How is their surveillance system? So what did we set out to do? Next slide, please. We set out to assess, to evaluate their surveillance system, to describe it, and then to assess if it is effective, and to evaluate attributes of the surveillance system and make appropriate recommendations. Next slide takes us to how we did this. Next slide, please. How did we do this? It was a cross. Yeah, one step back for this. The slide there is a cross-sectional. Okay, thank you. It was a cross-sectional mixed methods evaluation that was conducted in March 2024 for Kogi State in north central Nigeria that has 21 local government areas. Surveillance data between 2023 and 2024 were analyzed using the state line list. Key informant interviews were also held with 18 local government area disease surveillance and notification officers, DSNOs, and 4 state-level stakeholders between government and partner involved in surveillance. System attributes like data quality, flexibility, acceptability, stability were assessed, guided by the US CDC guidelines, and reported by descriptive statistics with qualitative insights. What did we find? That takes us to the next slide. So for the period under review, up there is the number of cases in Kogi State, north central Nigeria between 2022 and 2023, actually. Suspected cases were 112, confirmed were 38 with 12 deaths. 33% of before I go to that, I should let you know that there were 18 out of 21 DSNOs that responded. And their average age was 47 years. They were between 40 and 56 years of age, and they had at least spent a mean average, the mean was 23 years in service. So these were experienced surveillance officers. 33% of them agreed to receiving supportive supervision. This is speaking to data quality. Supervision, that is from up, down. But 83% of them conducted supportive supervision. That is from their level to the lower level. They had staff for completeness and validity, and it took time to complete CIF. But an insight from a stakeholder has it in the blue box, the first blue box. We encourage them to always have the next of kin's phone number so that we can get further information from them. Moving on to flexibility. 66% agreed that the tools could add new data elements. 90% said tools can accommodate changes. 83% agreed that the surveillance system, Lassa fever surveillance system in Kogi State was scalable in the sense that it could expand or contract depending on the outbreak or the need. And that's speaking to flexibility. If what we have to incorporate into the IDSR or the surveillance system is something that is worth doing, said one of the stakeholders. Why not? It will benefit the surveillance system, give it an expansion, and give it more understanding to health workers. And coming to simplicity, all the respondents agreed that the case definition for Lassa fever was clear, the case investigation forms were easy to fill, the system was easy to operate, but a stakeholder had this to say that actually it is not easy because even most of the doctors in our institutions are not even getting it right there because they don't know that all the variables are important. Next to more results. Here we are seeing the results from stability. The tree map on this side shows the challenges encountered doing Lassa fever surveillance in Kogi State. Very wide, almost half of it is on mobility. Ladies and gentlemen, Kogi State has the largest LGA, largest local government area in West Africa. It is called Dekina Local Government. Incidentally, my mom is from there. And when she was pregnant for me, she went back home to have the baby with her parents. So we have always grown with that bragging rights that we have a very large LGA, they are large LGA. So imagine moving from one corner to another corner of that LGA. And then it happens like that in many other LGAs, many states. So mobility was highlighted as a very major challenge. Laptop funding and others delayed stipends. Yes, seeing that 16% of the respondents, only 16% said they agreed to receiving stipends from government. These challenges were for stability. We are willing to continue our work as surveillance officers. However, we face challenges. This is from a stakeholder. In conducting our surveillance activities, such as mobility issues, lack of funding, and unavailability of data tools. So we go on to conclude, next slide, that the Lassa fever surveillance system in Kogi State is effective and demonstrates simplicity, acceptability, and flexibility, but there are challenges in stability and resource availability. This can limit long-term performance. Of course, these were also attested to by key informants. We recommend, in the next slide, yes, provision of mobility, incentives, improved funding, awareness, sensitization at the community level, community engagement, community ownership, especially. And now thanking all I want to acknowledge the other co-authors. Next slide, and then to the next is, next slide, next two slides. Thank you.
Thank you so much. Need 1 hour for this. Thank you. And last but not the least, Yetunde. Thank you.
Okay, good afternoon, everyone. I'm really happy to be part of this panel. And I also like to just crave your indulgence, please, if you could move forward so we could have better eye-to contacts and also discussion and engagements, because I notice a lot of us are kind of a bit distracted on our phones, but it would be good for us to really listen in because it's a very important presentation. So I will also align with the already established protocol. Beautiful presentation so far. And my name is Dr. Yetunde Abiyoye. I'm the National Incident Manager for Lassa fever in Nigeria. My topic is enhancing preparedness, readiness, and response to Lassa fever outbreaks in Nigeria. And we're going to be reflecting, going back in time to the 2023 Lassa fever after action review that we had. So just a quick background to this. We have, since 2005, Nigeria is among the 196 countries and WHO member states who have been a signatory to the International Health Regulations, which is a legal binding agreement for us to be able to prevent, detect, and respond to threats, any public health events. Of course, it could be endemic outbreaks or anyone with international concern as well. So in 2005, we were part of that agreement. And like every other agreement, right, you have to ensure how do you monitor, evaluate those particular agreements for countries. And WHO came up with the IHR monitoring and evaluation frameworks, which are 4 particularly, to monitor this preparedness, readiness, and response to Lassa, to outbreaks generally. So we have 4 of these, 3 are voluntary and 1 is compulsory. So the state party annual reporting, which we do as a country in relation to other WHO member states and all the 196 countries who have signed this agreement since 2005, we report annually. And then we have the voluntary one as well, which is joint external evaluation. And once again, Nigeria as a country, we've been able to do 2 joint external evaluation, which has benchmarks and evaluates this preparedness that we have to prevent, detect, and also respond. So in 2017, our score was 39%. In 2023, August, we did another one and it was 54%. And after that, we then have several after action reviews, which we have done. This is one out of the many. I'll also elaborate on the others. Next slide, please. Yes, so just this a bit of background, which I'm sure we are very, very familiar with. Lassa fever is a very stable zoonotic disease. Next slide, and we have a spillover, with humans, between humans and animals, and of course, a well-sustained human-to-human transmission. Next slide, please. So we also know that the multi-mammoth rat has been well implicated in this, but then there are other rodents that have also been implicated, but then we also have domestic animals and some other wild animals, like even lizards, that have been found to have antibodies to Lassa virus. So going back in time to 2023, what we were looking at was to review the implementation of the 2023 outbreak response activities. Now, action reviews are functional exercises. We have early action reviews, we have after action review, we have mid action review, inter-action review, but then we'll be focusing on after action review and a particular type, which will go more in the methodology. So we looked at that for 2023. We wanted to know, what do we have in place? How did it function? Because it's a functional assessment, it's a qualitative review to see if what we did, how did it work? How should it have worked? How could we improve? And then we did all of this, review what we did, looked at our best practices, challenges, we conducted a situational assessment, and we also looked at the enabling factors, best practices, which we have established over the years, and we immediately identified actionable areas for improvement, which I'm proud to say today that some of them have been implemented. Next slide, please. So long-term, mid-term, and the ones we needed to do. So this is just giving you a scope of the after action review itself. So the after action review focused on what happened from January to July of 2023. And I'm also proud to say that we're able to do this within 6 weeks of the escalation of the Lassa fever emergency operations center. So this just gives you a trend looking at this. Every outbreak is an opportunity, and we need to make sure, in the words of Winston Churchill, to make sure that we take advantage of whatever that when we encounter an outbreak, we don't just let it go. We need to document these lessons. And that's why for an AR, we decided on this scope, looking across the 36 states and the FCT, we had confirmed cases in 28 states and over 100 local government areas. And we also know that we have high burden LGS. Please, next slide. So we then use the following method. Of course, the very first thing you have to do is to outline resources. So we looked at the human resources that we had. We also looked at the material resources, the funding that we need to implement this after action review. And of course, we use the WHO after action review toolkits and every resource that is available. And after that, we prepared to de-escalate, and then we did that. And following that, we did the after action review within the 6 weeks of de-escalation of the after action review itself. And then we also decided the focus and the type of the AR. So for our after action reviews, which are action review, we have four different types. So we have a debrief type, we have the working group type, we have key informant interviews, and then we also have a mixed method approach. But for us, we focused on using the working group AR, which was best suited to our situation. We had an online facilitation, which was led by WHO, and we're very happy to have the national focal person, the One Health consultant, Dr. Kiki, facilitate that, where Dr. Kola Junaidu taught us how to, as facilitators, because one thing we realized is that there are so many tools out there, and we needed to make sure that we are all in one spirit, one focus, and we understand what we want to do. And we don't want to be confused when we are in the room. We need to move quickly because it's a very intensive, hands-on participatory approach. So we did that, even though it was late evenings, but I thank every one of them, the note takers and facilitators, who were deeply committed to ensuring the success of the AR. So we also made sure that all our participants and facilitators, experienced or not experienced, took the online WHO AR course, which is still available. You can also look at that. And then we had the 3 days intensive workshop with 40 participants across the high burden areas, making sure that everyone is also there. We have people from treatment centers, the DSNOs from the high burden LGAs. We had, our experts and partners who have also been supporting at various levels of national, state level, and LGA level. Next slide, please. So some of the, this is just showing our workshop photos, where we were able to draw out the timeline. So what happened? How did we come to activating our EOC? What was the time? How timely? What were the resources, the plans that we had? We also had, of course, it's a working group AR, so we had different groups. We had people divided into thematic areas, and we had to merge some thematic areas together that are similar, like case management and IPC. We were there hands-on, putting the documentation in place and making sure that every night we had people reporting immediately. Next slide, please. We had people reporting, the note takers were sending their updates, and this was updated throughout already. So the results that we had, were able to identify 75 priority activities for immediate, mid-term, and long-term implementation. And then after this, in the process of the AAR, we're able to then itemize 50 activities. Trust me, there is a lot. And when you look at the international health regulations, the National Action Plan for Health Security, the After Action Review, which is a functional exercise, is situated in all of these. And we know that some things will not be able to be resolved immediately, but we believe that we can still do them. And we itemize them. We didn't want this to go to waste. So we prioritized 50 out of these 75. And then we sent our report to top management, and top management drew out some other key things that needed to be implemented for immediate implementation. And we're proud to say that we're able to advocate and bolster risk communication and community engagement all year round, because Lassa fever occurs from January to December, and that is why we don't go to sleep when it comes to Lassa fever. Even when we de-escalate our EOC, we still have bi-weekly emergency operations centers meeting. So we've been doing that. Now we also were able to increase the number of labs that we had from 9 to 13, and that was done from the period of 2023 to 2024. We also were able to start implementing like a One Health implementation research, which is the community-based One Health participatory and empowerment approach, which was done with the support of RKI and led by Department of Planning, Research and Statistics at that time. So we're able to do that in Ebonyi. We piloted that using Lassa fever, and these were some of the key things we're able to do, and this commenced in November 2023. Currently, we are planning for the second phase of COPE. We are also able to start the Lassa fever Clinical Management Fellowship, the very first of its kind anywhere in the world, which we're able to do with our foundational members, and we had the pilots of this from August to September 2023. I'm also proud to say that we have just concluded the second cohort of this, and from the first cohort, we had 12 fellows. The second one, we have 19 fellows, and of course, we did this in line with our partners. We're also not neglecting the military. We also have several other ways that we've been able to do and ensure that we keep improving the capacity for us to manage cases for Lassa fever. Next slide, please. So in conclusion, and I also have my recommendations here. Now you might say, oh, well, we have history of Lassa fever being discovered in Nigeria from 1969 till date. That is 56 years of data for us and experience. But trust me, every outbreak has presented unique challenges. I'm just over 2 years of being the National Incident Manager, and every outbreak looking very unique when you look at, of course, the line graph, the 5-year line graph. But trust me, from 2023 till date, every outbreak has presented its own unique challenges, funding, and so many other things. Nothing has, I don't look at the outbreak as the same thing. There's always something exciting that keeps us on our toes. So it's very, very important. And of course, I'm taking my quote from Winston Churchill for this. Every outbreak is unique. We shouldn't allow it to go to waste. Now, it's very, very important that we conduct after-action review as soon as an outbreak comes to an end. And trust me, you might say, well, we need funding and all of that. Sometimes I call myself the queen of low-hanging fruits. And the reason is because I don't simply take excuses. If you're not able to get funding, trust me, there's still a lot you can do without funding before people come to help you with funds to do the things that you cannot do or you need to spread out. So AAR is something that is easy. You can have a very simple AAR for 1 day, less than a day. There are various models. You have a debrief AAR, you have a working group, you can do key informant interview, you can use mixed method. So it's not something that it's scalable, basically. Use it according to your setting. So there is no excuse to not do an after-action review after an outbreak has occurred. In our case, as Nigeria, we've done 5 action reviews. So we've done an early action review this year. We did our first after-action review for Lassa fever in 2017. We had one again in 2018. Unfortunately, after that, 4 years passed and we never did an after-action review. The next one after that was 2023. We had another one in 2024. We are yet to do the one for this year, but we're going to definitely do it no matter the scale before the next outbreak begins again in October. So, prompt implementation of priority actions, as you've seen, with the support of key stakeholders and our partners, is very important to ensure that no after-action review resources go to waste. You might feel like it's cost you your time, it can cost you money, it can cost you buying lunch, transportation, all of that. Make sure that you are able to implement 1 or 2 things. There are many things that came out of this. We had a webinar series for Lassa fever, which we have maintained for 2 consecutive outbreaks. So there is always something you can do. It's also important that you use the outputs of the AR to strengthen and build resilient healthcare systems, which is something that we as a country, Nigeria, and I know some other countries, have signed as part of our international health regulation. It's legally binding, and we have so many resources to do that. Now, One Health should not just be said. We know the definition. It should be in practice. So collaboration is key, whether within the health sector, whether within human-animal environmental interface. It's also important for us to know that we cannot work alone. We need to come together. We don't have to neglect any sector. Together, we can come together to achieve the goal of we have as a country and even as a region to reduce the CFR for Lassa fever to a single digit that's less than 10%, and even set a new target where nobody dies from Lassa fever. So next slide, I would like to thank our partners, WHO especially, for this toolkit, which is very helpful, and we've been adapting it and using it at various scales. And the Federal Ministry of Environment, Agric, Federal Ministry of Livestock now, and all our partners that are here, thank you so much for listening. And in our local parlance, we say, Mungode, Dalu, Eshekupo, and Usoko for my Fulani people.
Wow, this one is powerful. Thank you, Yetunde. So we need like 2 more hours for your own session, but we have to go. So we just, between us and lunch is just a few questions. We're going to select 3 questions and then take it from there. 1, 2, and 3. Let's do the first 3 first.
Thank you very much for the first speaker. Sorry, you made mention of course study. I was thinking it's more of a prospective concessional study for the study on antibodies to Lassa fever. It's more of a prospective concessional study, not cohorts. That's my understanding of that study design. Also, for the second speaker, I was wondering the choice. I'll still say it again, choice of Kogi. When Kogi is not one of the hotspots. And before carrying out that surveillance system evaluation, was there issue with reporting data quality issue also to have justified why going to Kogi? Then finally, we talk about stipend. Are these people not collecting salary? Okay, let's say the committee former are not even collecting. We should be disemphasizing issue of monetary motivation to non-monetary. We can combine both. Then finally, to today, Please, Dr. Etude, please, after this after action review you carry out last time, I was thinking we should be seeing results based on how many activities that were like. The cases keep on increasing in the country, and it initially used to be seasonal. It's now a year-round thing. So I think we need to revisit our after action review very well to see whether there are things we are not doing well, so that we can, see how we can improve on the current situation on Lassa fever in the country. Thank you very much.
Next.
Yeah, so thank you very much. Thank you for the, very extensive presentation, Dr. Yetunde. I just want to ask whether, you said you have done early action, after action review many times. Were you able to do the interaction review at any point in time? And in terms of preparedness, were you able to do any readiness training, across the zones? Because, lots of people are being endemic, just like many other epidemic-prone diseases. Thank you. Then, Dr. Abba, I don't know whether you have assessed, the monitoring and evaluation during your assessment of the surveillance system. Thank you.
The last question.
Thank you so much. I'll direct my question to the National Incidents Manager. And we keep having outbreak, and we keep doing after action review. And it's looked like we are just politicizing what's actually happening. We are not really so concerned, I'm sorry to say this, about how many persons. I think the CFRO this time was up to about 27%, even with an intra-action and after-action review. I'm surprised that the after-action review is still delayed. We are in September, and outbreak may start almost immediately. So I'm wondering why the delay on after-action review, considering what we've had. And the outbreak actually started December unofficially, but I know we had cases. So it's quite sad that we are still on the edge concerning this Lassa fever. Then secondly, we keep talking about One Health. I don't know, it may sound funny. What is our plan for the rodents? What's the plan for mastomes? I know One Health, most times when they come to our facility, they want to eradicate. But I keep frowning at that. If we kill all the Lassa fever, what will happen to the ecological system? I think my last conference I had in Hamburg, 2023, the guy was so concerned that he started vaccinating the ticks that caused one very hemorrhagic fever. I can't really remember. So I think we should be centered about the One Health, where the rodents too should be protected, because God didn't just create them for a reason. Thank you.
Thank you so much. Because of time, I think we're going to have a scenario discussion with the panelists. What I'm going to do now, I'll give each person 1 minute to tell us his last takeaway. In the process, you can answer any question that is addressed to you, but it's quite, I don't want people to walk away from the meeting before we end it. So just 1 minute, I'll be strict with it. Answer the questions if you can, otherwise give us your last word. We interact during the break to get more from them. Thank you.
Thank you very much. So my take-home message is that Lassa fever is common in our environment, which we know, and Lassa meningitis is common and it exists. And so a high index of suspicion is needed so as to reduce mortality and then improve diagnostic, therapeutic, and even public health statistics. Thank you very much.
All right. Thank you so much for this opportunity. The presentation on the serology is actually very important by the time we have the vaccine, because that's where everything is tending towards now. So I think it should be taken into consideration, especially vaccination early in life, so that it can help in the protection. Thank you so much.
Okay, for me, we assessed what we didn't go to assess monitoring and evaluation system, but the component we assessed was the supervision. upward and downward, if they received supervision or if they conducted supervision. And why Kogi? I think I'll meet you up after that. But for those that watch football, if you have the top four and then a club that's usually on that 10 is beginning to climb up, and then in the year is top four, you should know that you should look into that. That in this case is in the negative. So surveillance, and in conclusion, surveillance system should for Lassa fever should be assessed for either whether it is a high burden state, an emerging high burden, or a low burden state. Thank you very much.
Thank you very much, everybody, for listening. My last word is that we know that infectious diseases have come to stay. Emerging diseases are still coming. So we need to be prepared all the time. And even though I know it's my presentation, I still advocate for simulation exercises. Let us start doing that. Thank you very much.
All right, thank you so much for all the wonderful questions. So I'll just answer quickly. We haven't had an interaction review, and the reason is because we as a TWG has established best practices. So we have periods where we have surge, and then we activate the EOC, and then we've never had our EOC being activated more than 6 months. It's usually on the average of 6 months or less. So we usually do an after action review. And you also asked about if there's been any readiness training. So like I said, resources have not been, even before now where we had the massive funding cuts, we have not had a lot of, or high, specifically I can speak for myself, has not had a lot of funding. So what we did instead was that we started a readiness webinar series in 2023 in preparation for the 2024 outbreak. That's national outbreak. So we did that. We also did that, and it's one of the best practices we also keep. So we also did that for 2024 in preparation for 2025. And someone asked about the delayed after action review for 2025. So we de-escalated our EOC June 11th, and we are still within the 3 months window. So we hope to do this month at whatever scale before the next outbreak, which we know dry season is commencing, starting again at the state level from October. Someone asked, what is the plan for the rodents? Well, I believe there was a session here by the World Organization for Animal Health, but I'm also an animal welfare person. And I also say it's very important that we do One Health implementation research like is shown by COPS. So it's very important that we have a balance in the ecosystem. Any other questions we can take outside this? One final thing I'm going to say is that after action reviews, we know are voluntary, but I also say in the words of Winston Churchill, let's not allow any outbreak lesson go to waste. Let's learn from them. They might look similar, but there is always something unique about each outbreak. Thank you.
Thank you so much. So let me thank the panelists. Can agree with me that this is a very solid panel. The time was so short, but at least we did our best. Thank you so much. And thank you, the audience, for staying till now. I know your lunch is at stake. So at this stage, I want to thank everybody, and then let's end the meeting. Thank you. Let's have a
Hello. Good afternoon. We are all welcome back from the lunch break. We are welcome to the 17th section. In the next few minutes, we'll be having a section on strengthening lab networks for timely diagnostics. My name is Chukuma Umeokonko, and I will be moderating this section. And I would like to call up on the speakers to come up to the high table and take their seats. Is Ronald Fange, is he around? Please, can you come up, Ronald? Hanesh Shi, please. Audu Onye Macho. Audu Onye Macho, if you are around, please come up. Gudati and about this, welcome. Dalton Angus, if you're around, please come up to the high table. Amel Zemas, please come up. Eket Tobin, if you're in the room, please come to the high table. Valentine Victor, and Professor Sonny Rezik. Thank you. In this section, we'll have 9 presentations, and for each presenter, we'll have 10 minutes to make a presentation. And because of the number of presenters we have in this section, we will like to take the questions at the end. So please can jot down your questions or comments. We'll have a section of Q&A at the end of the presentation. We want to start right away. We are a bit behind schedule. Is Ronald on the seat? Okay. You're standing for Ronald. Okay. So please, the IT, can you project slide 034? Slide 034, yeah.
Hi, everyone. So I'm Hanesh Chi. I will be doing this presentation on behalf of my colleague, Fritz Roland, who wasn't able to make it due to some challenges with logistics. So we're going to be looking at external quality assurance for Lassa diagnostics. This is a part of some of the work that we did in Nigeria under our Find Lassa fever response portfolio. So we have actually, we all understand that the landscape for Lassa diagnostics is quite limited. We have a range of, but it actually ranges from serology tests, we have an RDT and some PCR tests. But one of the key things that we really want to focus on as Find would be, given the limited tests that are available, we still want to ensure that the data that we are generating out of this test are reliable. So we did this work in collaboration with some sites in Nigeria, 5 sites which are part of the Lassa fever testing network. And it's just an EQA program which we believe is vital for maintaining reliable diagnostics. Okay, so essentially our objectives were to assess lab performance by an independent agency, that was us, Find, to detect errors in testing processes and provide corrective actions. The objective also was to enhance confidence in reported results and also support laboratory accreditation and compliance. So for our methods, it was pretty straightforward. We sorted some samples with known results, pulled the samples, did some heat inactivation of the samples, aliquoted these samples into cryovials, actually developed sample panels and blinded these samples. And then following the triple packaging procedure, we packaged the samples and dispatched them to the sites. The sites received the samples, stored them between 2 to 8 degrees, and then tested the samples. And then on our side, we did the analysis of the result. We actually released the results to the sites and then did some analysis. And based on the performance of the sites, we did some root cause analysis and implemented some corrective actions. So we started with a pilot, which was 5 sites in Nigeria. You would see on the map the sites and the different areas in Nigeria that these sites cover. But essentially, we worked with the National Reference Lab, the Lagos University Teaching Hospital, the Federal Teaching Hospital in Abakaliki, Federal Medical Center Owo, and the Rural Specialist Teaching Hospital. So we did 2 rounds of this EQA. The first round we did in 2019, where we sent out 16 blinded panels. We actually distributed 16 blinded panels to the labs. We received 13 results, and that gave an overall participation rate of 81%. And based on the results, we observed a concordance rate of 92% across all the participants. After that, we did now the root cause analysis and corrective actions, did some site visits, worked together with the site. And 2 years later, we sent a second round of panels, and this one was 15 blinded panels. And this time we had 100% participation and also concordance rates. So we actually saw progressive improvement between the two panels, and we believe that this activity was really needed to also really improve the reliability of data with the Lassa test. So this is just a summary of the results for the first round, where at site level, we had one site that actually scored 89%, but we had good performance for the other sites. For the first round, we did it with 4 sites. And then the second round, we did it with 5 sites, and all sites scored 100%, and the participation rate was 100% too. So just as looking forward, we believe that we really need this improved accuracy of. We need to ensure that the data that we are generating from our tests are really accurate, and we really need to find ways of expanding this activity to more sites and also even across the region. So we just want to take some time to thank the sites that helped us to do this, because beyond testing, they also participated in planning this activity together with Find, and they include ISTH in Nigeria, the Federal Teaching Hospital in Abakaliki, the Lagos University Teaching Hospital, Federal Medical Center, or and NCDC in Nigeria. And just to acknowledge that this work was funded by the German government. Thank you very much.
This presentation? Yeah, thank you.
Right, so I will still stay with you for the second presentation, which has to do with another activity that we still conducted under our Lassa fever response portfolio, which is establishing targeting product profiles for Lassa fever diagnostics. So again, just from when Lassa fever was recognized as a priority disease under the WHO R&D Blueprint Initiative, it's been more than 5 years now, but we are still experiencing, we're still observing a lot of gaps in the diagnostic landscape for Lassa fever. So just in order to be able to address this gap, we think one of the sustainable ways forward would be to really develop target product profiles which would serve as guides, which would serve as a guideline to be able to develop the appropriate diagnostics for Lassa fever, because based on with the Lassa fever, with the TPPs, we'll be able to understand the minimal and the optimal characteristics based on the different use cases that we'll be exploring for Lassa fever. So these are just some of the benefits of the TPPs that we had in mind while we wanted to engage in this activity. They include guiding product development, supporting laboratory standardization. We have prioritizing fit for purpose designs, amongst others, and leveraging on these benefits. Still under the Lassa fever response portfolio, we now engaged into developing the TPPs for Lassa fever. And to begin with, we actually identified 2 use cases just for this activity. And the first use case was for point of care diagnostics, point of care test for Lassa fever, and the second use case was confirmatory test for Lassa fever. So the second step was actually a whole structured process that we followed. The second step, we then moved now to constituting the TPP development groups. So we had 2 kinds of groups. We had the core development group, and then we had a larger development group, which was made of experts. But for the TPP development group, the core group, we had significant guidance from WHO and CEPI during this process, and it was also developed by some specialists in fine. And for the third process, we then did some modeling. We actually identified the indicators that were required for this process, and we did some mathematical modeling, which I'm going to show you in the next slide. And informed by that modeling, by the results from that modeling, we then were able to draft the TPPs. And with the draft, we then conducted a welfare survey, which enabled us to get anonymized feedback and expert opinions from the TPP development group, which we then analyzed at the end of the process. To be able, for us to be able to move forward, we set a consensus rate on each indicator of 75%. So for all the indicators we're not able to achieve 75% and above, we then worked again with the TPP development group through webinars to be able to align and achieve at least 75% consensus. And then we went forward to finalize the TPPs. So just as results, we now this is just to show you the kind of modeling that we did for during the TPP development process. We identified indicators such as proportion of cases that we identified, cost. We even did modeling of the algorithms also, and also positive and negative predictive values for the TPPs. And in terms of results, we have 2 TPPs that we've developed. The TPP1 is for point of care tests for presumptive diagnosis of Lassa fever, and TPP2 is for confirmatory tests for Lassa fever. So we have our exhibition stand, which you can stop by and obtain a copy of these TPPs if you want, or you can also visit the the FINE website where you can get electronic copies of these TPPs. So we just believe that the TPPs would really inform the development and implementation of these of Lassa diagnostics, because we now at least have been able to identify optimum and minimal and optimal characteristics of the indicators. And also, we just recommend that this kind of investment should really be done even beyond Lassa fever to other VHFs, and the kind of collaborative approach that we use, we thought also it could be copied for other initiatives. So we just want to acknowledge all the different stakeholders who were involved in this process. We really got support from WHO to guide us through this process. We got support from CEPI, and then we had a range of experts in Lassa fever who constituted the TPP development group who helped us to achieve this project. So thank you very much.
Thank you. Thank you so much, Hans. The next presentation will be taken by Audu, and that is on assessment of challenges healthcare providers face when communicating delayed laboratory results to patients managed for Lassa fever in Benue State. 036.
Good evening, everybody. My name is Audu Onyemocho from Benue State, Nigeria. I work with the Federal University of Health Sciences, Totuko. I'm presenting on behalf of the researchers that carried out this work. Assessment of the health, of the challenges of healthcare providers when communicating delayed laboratory results to patients that are managed for Lassa fever in Benue State. Lassa fever, as of today, is about 25 years old now. 56 years old, living with us. In Benue State, the first case was identified in 2017, which is about 8 years ago. And subsequently after that, we'll be having a series of cases, and the case keep going up in terms of the number. And the diagnosis of this patient, based on the cascade, that from suspected cases, you take them to hospital for diagnosis. After diagnosis, it's either been mild or moderate, as the case may be. Some may die in the course of the illness, and some may come out with good outcome, and they are going to be discharged. But along this line, there are some few individuals, either they died before they are discharged from, the result comes to them, or they don't even get the result at all. But I will work based on the national guideline that you may have to commence the treatment immediately. So the health workers now face a lot of challenges when this result comes out to be negative. But we all know that it is an ethical right of the patient or the relations to get the result of this test that is being carried out. Why do you have to do that? Because it builds confidence and it promotes adherence to management protocols. It also fosters community trust, and it also improves the health outcomes. And in terms of surveillance, once these results are being made known to the patient, it also gives you an access to surveillance and then also on contact tracing. And in fulfilling this, there are a lot of complex cases that comes up and challenges. So the aim of this study is to assess what the health workers face when these results are being delayed. And the specific objective, first of all, you look at the turnover time of the few patients that have been managed in the hospital. And then for those cases that are positive, but they come out late, or for the negative cases that the patient may have died before the result comes, and then are buried based on the state protocol of burying them in a Lassa way at the end. What are those things that these people now face? The methodology of this study, we did a cross-sectional study with a mixed qualitative and quantitative approach. And the study area is the Benue State University Teaching Hospital. It's 1,000 tertiary facility, but where this study was carried out is the isolation center that is situated in the hospital. And it comprises about 32 staffs that comprises of nurses, doctors, environmentalists, and also laboratory scientists. So the population for this study were those people who were directly involved in disclosing the results to the patients. How did you carry out this study? We use, for the qualitative aspect of the study, we use the patient's record to get the summary of what has been done for the patients. And then for the qualitative aspect, informant interview guides was used for this. From the summary, between that January to December 2024, a total of 102 cases were seen as suspected cases that were referred to the hospital. Of these, 46.1% of them were positive, which gives, that is the positive rate. And of the positive cases that were seen in the hospital, 6 of them died, corresponding to 12.8% as case fatality rate, which is above the national value. And between the time the samples were collected to the time that they got the result, we had an average of 6 days, which was very much. And length of stay for the patient, depending on the severity of the case, averagely we have about 25 days for all the patients that were seen. What were the results then? For those cases that they were negative, but they died in the course of the treatment, and now the result had to be made known to the relations after their demise. The health workers face a lot of challenges. For some individuals where the test is positive, but it didn't come on time, the health workers also face challenges. And when we sum these challenges together, we had a summary of lack of trust in the result by the patients. And some of them even denied the result, that the result doesn't belong to them. There was also failure of patients to provide detailed information about the contact because of the fact that this result had been delayed. At the end of the day, contact tracing was a challenge. Then we have also emotional blackmails and mistrust and ethical dilemmas. And some of them refuse referral for other places. Like the severe cases, we had to refer them to Irua because that facility never had a dialysis machine. But because of the delayed result, some of them refused to accept that referral. And there were also physical assaults and emotional abuses. Now, the qualitative aspects, unfortunately, this is just a summary of some of the conditions that we see there. One of them said, the result you are giving to me is not my own. You must provide the evidence that, yes, this is my result. So it was indeed a challenge. And a nurse was quoted again from the qualitative aspect of the study. Even the other hospital staff, that where I work, they now labeled me as a Lassa man or a Lassa woman. How can I now continue working in the isolation center because of this result? Another patient again quoted this. When they escorted when they went to conduct the burial in the community where this person come from, he narrowly escaped. And he had this to say, we narrowly escaped from the community. They wanted to kill us because they never believed in the test result and that our results were fake. Another result came like this. I have no contact with anybody. I don't even believe in your result. I will never call anybody's name for you to go and do any contact tracing. And this, we have another one as quoted like this. You people have killed my brother with your so-called Lassa fever, and you have made the whole community to label us as bad people. Now, you bring a negative result to us after we have buried our brother in the Lassa fever way. You must come with me to my village and announce publicly that my brother was innocent and that is safe. must come back to give him a befitting burial. So if you look at all this, they are enormous. Among the survivors, they have their own to say. Among the health workers, they also have their own to say. So in conclusion, what have we said? The prolonged time required to process the specimen from the time it's been taken and the time it's being processed and the time it's being released to the patient, it has a lot of negative impacts, not only on the patient, not only on the healthcare providers, it also have a negative impact on the community and in the surveillance system. And these delays create notable gaps in surveillance. So by and large, what now would you recommend for this? There should be an expansion in laboratory capacity in all endemic areas, and that you should try to introduce a rapid diagnosis test. Even though the gold standard, if it's a real-time PCR, if this can be made available, it will solve a lot of issues. And we also need to train and strengthen the healthcare workforce. And there's need to provide psychosocial support for healthcare providers to mitigate the kind of stress that they undergo through. And we also recommend that you should strengthen sustainable domestic funding mechanism to reduce the reliance on donor support. Because we look at this case, 8 years ago, up to now, if we cannot afford to have our own lab that can diagnose this patient, then it means we still have a long way to go. At this point, I want to thank everybody for listening and giving me this audience, and also my university, which supported me supported us to carry out this research. Merci beaucoup. Thank you.
Thank you, Audu. We've listened to 3 presentations from Nigeria. Now we go to the west, to Guinea, to listen to a presentation on Guinea's 5 years progress in Lassa fever, surveillance, strengthening diagnostics, and genomic surveillance. That's slide 037.
So good evening, everybody, and thanks a lot to the organizer to give me the opportunity today to share with you the achievement of this long-term collaborative project that has started in Guinea between the Berdanoc Institute for Tropical Medicine and the Laboratoire for Viral Hemorrhagic Fever in Guinea. A project that was focusing initially in strengthening diagnostic capacity, and then later expanded also to support the creation and the implementation of genomic surveillance in country. And that strongly contributed in the improvement of surveillance of Lassa in Guinea. This project started with the deployment of the European Mobile Lab, or EM Lab, from Germany, the Berdanoc Institute, to support the Ebola virus outbreak in West Africa. A deployment that lasted approximately 30 months, and then seeing many units and many laboratory experts deployed to support different countries overall. And at the end of this experience, it was clear that actually the real needs is to have a capacity already in the endemic area, and also this will have saved a lot of burden, economical burden and logistic. So the objective of the project was to invest in preparedness, to have a laboratory capacity already there, specifically in the area of the prefecture of Gekedu in the Forest Guinea, where the outbreak started of the Ebola virus in 2014 and 16. And so from the end of 2016, beginning of 2017, through training, provision of device, and all the reagent, the laboratory is now fully functional, managed from our colleague from Guinea, and has supported and provided the diagnostic for VHF, specifically Ebola, Marburg, and Lassa, since then for the community in the Forest Guinea. And as a consequence of this investment, actually, the laboratory of Gekedu was ready there in the moment in which the Ebola virus re-emerged in 2021, and they could timely give the results of diagnostic to the MOH and to also the other partner in WHO that were on site to trigger the response and the management of the cases. And I just want to point out here with the two maps that you have on the above, on the top one, a map that with the color codes show the number of cases of Ebola in the 2014 and 16, and on the bottom, the one from 2021. And you can clearly see, without counting the numbers, that there was a clear differences between the two outbreaks. And this was also because the diagnostic was timely in loco, in situ, and ready to trigger the response. In a collaboration with the reference lab in the capital city, also sequencing was performed, and this had additional information. And so that this was not actually a zoonotic new spillover event, but the team could prove that this was a resurgence of the Ebola virus very closely related to the one from the outbreak 2014-2016. And despite the dramatic moment in Guinea with the resurgence of Ebola, and let's not forget it was full pandemic COVID response, we took with our colleagues the opportunity to scale up this project to increase the network. And so another lab was reinforced and supported in Nzerekore, still in the forest region, and the unit for sequencing was created and implemented in the lab in Conakry in order to have all this capacity in the sites where epidemic could raise, and also to provide genomic surveillance directly in country without any expert that needs to fly and comes in country. And this not only has contributed to the Marburg virus disease response in 2021, but to several variant identification for COVID-19 in Guinea, several Lassa fever cases detected in the forest, and the laboratory in Conakry was in first row in the nosocomial outbreak response when few cases in a low-risk area of Conakry were spotted. And then latest, when actually we more and more scale up the capacity, these labs are now contributing to yellow fever, dengue, and mpox surveillance in country. Based on the robust, strong part of diagnostic, also the genomic surveillance grow, and the laboratory that you can see, it's a very small lab, but with a huge capacity. In the last 4 years has produced more than 100 runs using the MinION technology. 7 local staff were fully trained in SARS-CoV-2 sequencing, and now 4 of them are fully trained. When I say fully trained, I mean lab part and bioinformatic to perform metagenomic sequencing. And this has not just contributed to the pandemic response, but also to the identification of different sequences from Lassa belonging to lineage 4, and is currently contributing to the genomic surveillance for the mpox outbreak caused by clade 2B in Guinea. And if we focus on the Lassa, specific Lassa fever surveillance, the 3 labs in the last 5 years contributed to the confirmation of overall 35 cases of Lassa. And I just want to stress the point that if the median time between onset of symptoms and testing, this was only of 5 days, that it might still look long, but if you consider overall the condition and where the labs are seated, this is a very big achievement, and I'm quite sure we will shorten this also in the next years. As Dr. Bard already mentioned yesterday in his presentation, unfortunately, the case fatal rate is still very high, 60% in Guinea. And this information about the ribavirin treatment is overall, so only 32% of the cases confirmed were treated by ribavirin, but I can tell you that already in the last 2 years, this trend is changing, so ribavirin is more accessible in country, and the patient can have access to this more frequently. And if you focus on the map, you can see that the majority of the cases were detected in the forest region, so the implementation of this lab really where these cases are popping up, it's really crucial for the management of the cases and also to any other epidemic detection. So overall, this strengthening of diagnostic did not just contribute to the improvement of outbreak detection for the VHF, but specifically for the surveillance of Lassa fever in Guinea, and also to provide new information about the epidemiology of this disease in country. But this achievement, they came also with quite many challenges, so has been quite complicated to maintain this lab and a lot of the support has been put it on. So in stabilizing the infrastructure, because this lab operate in condition in which electricity is very limited, sometimes the infrastructure itself of the lab is not made to have a proper workflow for good diagnostic with good quality assurance system. So a lot of the effort with our colleague has been put to reach good standard, good diagnostic. And as has been many times already mentioned in this conference, the major point now is to make cheaper this kit, make available in country, and reduce the limitation that this has to come from donors or experts from abroad, but really empowering these labs to be independent and they make their work alone. And I need to stress also the point, equipment maintenance. So I'm quite sure that people who work in the hospital, they have the same problem. Maintaining this equipment, it's very crucial. You can have a Ferrari, you can put the gasoline, but if the engineer is kaput, it doesn't work anymore, the Ferrari doesn't work anymore. So a lot of also of this should be stressed for the future for any capacity building. And the last but not the least, the most important slide, the one of acknowledgement. So I'm presenting on behalf of many people. So unfortunately, I could not put all of them in the slide, but a lot of people have contributed to this very long-term project. First of all, the colleagues from Guinea. So the colleagues from the laboratory in Conakry, or Professor Sanaba Bumbali, previously Dr. Bagasuba, the one from the laboratory in Enzere Korea of CDB, and the one from Gokedu of Kundunu. Many other people from BNITM under the umbrella and the leadership of Stefan and Sophie. And of course, we also benefit a lot of the support of WHO, GORN, the collaboration with NSS, and the financial support of the Global Health Protection Program in Germany. And for the sequencing specifically, we also have a strong support from the Leuven University that help us a lot in this implementation. And with this, I want to thank you very much.
Thank you so much. The next presentation is from Guinea on the Lassa fever in Benin, the genomic characterization of isolates of positive cases responsible for 2023 epidemic. That's slide 38.
Bonsoir, Madame, Monsieur. Je suis ici pour vous présenter les résultats des travaux de séquençage des isolats positifs de la fièvre Lassa pour l'épidémie de 2023 au Bénin. Ce travail a été conduit au laboratoire des fièvres hémorragiques virales du Bénin, un laboratoire qui est sous le ministère de la Santé et qui reçoit le soutien de plusieurs partenaires dont nous en parlerons ici. Comme vous le savez tous, la fièvre Lassa est une fièvre virale très aiguë qui a été décrite pour la première fois en 1969 au Nigeria. Et d'après la littérature, cette fièvre est transmise beaucoup plus par les rongeurs, et plus précisément le rat Mastomys. Et ce rat constitue le réservoir de ce virus qu'on retrouve dans plusieurs pays de l'Afrique de l'Ouest, notamment le Nigeria, la Sierra Leone, Libéria, la Guinée et plus récemment au Bénin. D'après les estimations de l'Organisation mondiale de la santé, on estime entre 100 000 et 300 000 infections et 5 000 décès par an. Au Bénin, il faut noter que la première épidémie de la fièvre Lassa avec diagnostic a vu le jour en 2014 dans la commune de Tangueta, située au nord-ouest du Bénin, avec 8 décès et 20 cas positifs. De 2014 jusqu'en 2024, on a constaté que cette fièvre meurtrière a évolué dans plusieurs régions du Bénin, notamment au sud et au centre du pays, avec plusieurs décès, comme vous pouvez le voir mentionné sur le diapo là. Devant cette situation où chaque année, le Bénin paie plusieurs membres, plusieurs personnes de la communauté, il s'avère indispensable que des dispositions soient prises afin de savoir avec précision le génome qui est vraiment responsable de l'épidémie. C'est dans cette situation que, de commun accord avec le ministère de la Santé, les échantillons Lassa qui ont été suspectés ont été amenés au laboratoire et une fois ces échantillons amenés au laboratoire, ils ont été inactivés et après inactivation et amplification, les échantillons qui sont sortis positifs ont été séquencés. Et ici, nous avons utilisé le kit Tweets pour pouvoir faire le séquençage à partir de la plateforme Illumina. En ce qui concerne le protocole du kit tweet, dans un premier temps, il faut vérifier la qualité des échantillons, donc les ARN extraits et qui sont positifs à partir de l'amplification seront donc convertis en ADN pour pouvoir préparer les librairies. Après la préparation des librairies, il faut donc vérifier la qualité des librairies à partir de l'appareil Qubit et de TapeStation pour pouvoir voir la qualité afin d'avoir des séquences de qualité. Les résultats de nos travaux après analyse et utilisation de la plateforme CZID ont montré que plusieurs échantillons étaient positifs à la fièvre Lassa avec séquence L et on va beaucoup plus en profondeur avec 90% de couverture. Et nous avons également la séquence L qui est aussi présente et qui avait été décrite entre 2014 et 2016. Cette histoire nous amène à dire que le Bénin a son propre réservoir parce que pendant longtemps, le Bénin avait accusé le Nigeria d'être responsable des différentes épidémies de la fièvre Lassa qui se retrouvent dans le pays. Mais devant une telle situation où nous avons fait le séquençage, où nous avons eu notre propre réservoir, ça veut dire que le Bénin ne pourra plus accuser le Nigeria d'être responsable des épidémies de la fièvre Lassa dans son pays. Autre chose que nous suggérons, c'est qu'il faut réellement continuer la surveillance de la fièvre Lassa dans d'autres départements pour pouvoir connaître l'épidémie de cette fièvre qui revient chaque année. En ce qui concerne les recommandations, nous suggérons qu'il faut faire régulièrement la surveillance pour pouvoir connaître les autres réservoirs de fièvre Lassa qui se trouvent dans d'autres départements du pays. Ensuite, il faut penser à l'introduction du vaccin qui pourra limiter un tant soit peu la transmission de cette maladie dans les différents pays de l'Afrique de l'Ouest. Je ne saurais finir cette présentation sans remercier mon ministre de la Santé, le professeur Benjamin Runkwating, qui s'est vraiment impliqué afin que nous puissions conduire ces activités. Remercier aussi le DG de l'Agence des soins et de la santé et son directeur en charge de la surveillance. Ils m'ont vraiment aidé à pouvoir rentrer en contact avec les échantillons pour faire le travail. Je dois remercier également le gouvernement allemand à travers la GIZ qui a apporté un soutien très important pour pouvoir conduire ces travaux. Et le grand soutien revient à l'équipe de BNI. Je veux remercier ici le professeur Stéphane Gunta et Dr Michael et toute son équipe parce que le Bénin n'avait pas la capacité de faire le diagnostic des fièvres hémorragiques virales. Mais depuis 2014 jusqu'à l'heure où je vous parle, on a eu le soutien du département de BNI qui a formé les Béninois, nous envoie des consommables et des kits. C'est le lieu de les remercier publiquement. Je remercie également l'OMS à travers Dr Bédi et Dr Saizonou. Je remercie le DG de Ecowas, OAS et son staff pour avoir permis notre déplacement ici.
et enfin toute l'équipe du laboratoire qui a veillé jour et nuit pour conduire ce travail. Merci.
Thank you. Thank you for being a very good audience. The next presentation will be from Nigeria. AME will be presenting on their challenges of conducting longitudinal studies with blood draws in low resource setting. Lesson from Enable 1.0 Lassa fever epidemiological study in Edo State, Nigeria. That's 040. Thank you.
Good afternoon, everyone. My name is Ame Onome Ahabwe from ERA Specialist Teaching Hospital. I will be presenting our study on challenges of conducting longitudinal studies with blood draws in low resource settings, lessons from the Enable 1.0 epidemiological study. We already know that Lassa fever is endemic in West Africa and that Nigeria continues to remain a major hotspot. So the Enable 1.0 study was a study funded by CEPI, and it was a multi-country cohort study in which Nigeria was one of the countries that this study was engaged in. And the goal for this study was to generate epidemiological data in order to create a future Lassa fever vaccine development. However, there were several challenges that we experienced in the course of the Enable 1.0 study. The challenges included logistical and cultural hurdles. So the study that I will be presenting on, it's not just a study about numbers or blood samples. No, it's a study about communities. It's a story about communities, resilience, trust, and resource management in low resource context settings where there are logistical issues and where cultural beliefs sometimes matters more than medicine itself. The objectives of the Enable 1.0 study, like I earlier said, was to gather data in order to produce a Lassa fever vaccine. However, for our paper, the objectives were, one, to document the challenges that we experienced in the field and to describe the adaptive strategies that we had to adopt in order to mitigate these field challenges, as well as share lessons for future research in West Africa and beyond. So this study, one of the sites was in Edo State, Nigeria, and it was a selection of rural and semi-urban hotspots. So we conducted this study for the Enable 1.0 in 7 communities. Some of it were villages and some were like semi-towns. ISTH for the Enable 1.0 study was the only Nigerian site that had 2 cohorts, the disease cohort and the infection cohort. The disease cohort had over 5,000 participants, and the infection cohorts were over 1,000 participants. The infection cohort was nested within the disease cohort, so that means that all members of the infection cohort were members of the disease cohort, but not all members of the disease cohort were members of the infection cohort. For the disease cohorts, they were all sampled once at baseline, but for those who were in the infection cohorts, we sampled them every 6 months. For this study, we adopted an ethnographic approach, our observations as members of the study team, as well as debriefings that we received from our field workers. So the Enable 1.0 study flow went like this. Enrollments began in November 2020, and that was the first lesson for us. It was around the festive period, so it meant that sometimes a lot of members of households were not home. So our field workers had to work late into the night. They also had to go back multiple times to the same households in order to meet potential participants. And they also had to work long weekends. So the first lesson for us from this study was that flexibility is key when it comes to participant recruitment for longitudinal studies. Now, for the participants in both cohorts, they had bi-weekly follow-up visits, and it was quite intensive. So the real challenge beyond participant recruitment was keeping these participants, over 5,000 of them, engaged from the beginning of the study till the end of the study, which lasted for over 2 years. And then particularly for members of the infection cohort who we had to draw blood from every 6 months. Could we keep them engaged? Could we keep them motivated to stay in the study till the end and achieve a high retention rate by the end of the study? So for the members of the disease cohort, again, which was all members of the study, we followed them up every 2 weeks, either by home visits or through phone calls. And so it was quite intensive for them. For the members of the infection cohorts, we drew blood from them every 6 months. For all members of the disease cohorts, if they were febrile, they were tested at partner health facilities in the local communities and treated for malaria at these facilities up to a certain amount. And then when they were tested for Lassa, if they tested positive, they were treated completely free of charge at Era Specialist Teaching Hospital. And at the end of the study, we did not just walk away. We went back to those communities to provide feedback, to tell them the results that we had generated from the study itself. And so we provided closure for them, and this helps to build trust in those communities. So the number of I've already discussed this. So the key operational challenges that we experienced for the Enable 1.0 was transport. One of it was transport and storage. I'm going to discuss the challenges, and then I'll also discuss the strategies per challenge side by side. One of the key operational challenges we experienced was transport and storage. We had poor road networks. We still continue to have poor road networks in Edo State for some of the study areas. And we had unexpected increased fuel costs that came about because of a result of policy changes and things like that. So it was quite unexpected. It increased the cost for logistics, and the number of limited vehicles we had risked sample collection as well as samples storage and sample transportation. Because due to this poor road network, sometimes there will be road jams, and if we had to rely on traditional means of transportation, we would risk sample hemolysis for quite a number of samples. So what did we do to mitigate these challenges that we experienced? We adopted a hub and spoke transport. So that means the ISTH lab was the central lab where we stored all our samples. However, particularly for the more remote communities in Asako West, we would gather these samples, collect them, and store them in a facility pending when it could be transported to the central lab. So there were mini labs at the various communities, two of the communities in Asako West that were a bit far from the center. And so we would batch these samples, batch scheduling, we'll batch the samples from the two communities in Asako West and then transport them using non-traditional means such as bikes, in order to avoid hemolysis and spillage. We also could not always rely, due to the distance and poor road networks, on ice packs being deployed from ISTH daily to these remote communities. So we would procure ice packs from those communities and then also store the samples in the fridges in those health facilities. So these were measures that we adopted in order to cope with transport and storage issues. We also had participants-related challenges. Again, like I had earlier said, follow-up was quite intensive. We were calling participants every 2 weeks. We were visiting them every 2 weeks, and we did this for more than 2 years. So they had fatigue from frequent visits. Some of them even had fear of blood draws. We had migration, attrition issues, people who migrated. We know that Nigeria continues to have high migration rates. People who at some point in the study refused to continue to participate in the study, and sadly, even deaths from our participants. What did we do in order to improve retention of these participants? We adopted flexible follow-up strategies, allowing the participants to choose when and where we could follow them up within the scheduled window. We collected collateral contacts, phone numbers from participants' relatives, so that if we couldn't reach them directly, we could try to reach them indirectly through these persons. We provided modest incentives during blood draws, and we continue to be empathetic, trained and retrained our field workers on the need to be empathetic towards the concerns that our participants had, on the need to continue consenting, to continue dialogue with them over and over, no matter how often the participants expressed fatigue or concerns, to show empathy, to show concern, and to answer whatever questions they might have. We also had sociocultural and communication beliefs. There were rumors, several rumors in the communities. Some persons said that the blood samples we're collecting, we're using them for rituals in order to make money. Some persons said we're selling the blood samples to white people, or in our local term, Oyibo people, in order to make a lot of money. Some people said that the blood samples we're collecting were the reasons that their lives were the way they were negatively. We sometimes had language barrier issues. We sometimes had, in Enable 1.0, we experienced delays in distributing results to participants. So what did we do in order to combat this challenge? We had community liaison officers in all the communities who spoke the language, who were members, not just that they spoke the language, but they were trusted members of these communities. The communities knew them, the communities could rely on them, the communities, they were part of the communities. We also employed local data collectors who were from those communities who could speak the language, and we tailored communication to the cultural context. I had earlier said this study was conducted in 7 communities and they had different cultures. So one communication strategy could not fit all 7 communities. So we had to ensure that whatever we're communicating was tailored to that specific culture. What would work in one culture would fail in another. So we employed culturally tailored communication. We provided regular updates to our participants. We told them the truth over and over, even when the results were not available as at when we expected them to be. We went back, we didn't wait for them to always ask us the questions. We would go back to tell them this is what is happening, this is when we expect these results to be ready. As soon as it is ready, we will distribute them to you, and we would hold community feedback meetings. And in terms of rumor management, which was one of the biggest issues that we had, we were transparent. We told them the truth. We told them these blood samples are going to so place. We told them these are the persons who are sponsoring us. This is the organization that is sponsoring us. We even went as far as telling some of them, if you want to send a message directly to SEPI, you're free to do so. If you need to ask them questions directly, you're free to do so. We explained to them over and over. Like I said, consenting was an ongoing process from beginning till the end. We continued to tell them what the study was about. We continued to tell them who the study sponsor was. We continued to tell them how important their involvement in the study was, not just for us, but for themselves, for their communities, for their legacies, and for the roles that we're all playing in order to combat Lassa fever. So to conclude, it is possible to do longitudinal large-scale Lassa fever studies, but we must realize that those studies come with major hurdles. And so if we're going to be successful in such studies, first we must adapt. We must be willing to adapt to situations that we may not have accounted for or envisaged. For example, we did not think that fuel costs would at some point go from maybe 300 to over 1,000 naira, but it happened. Some of us did not expect the rumors that would come up in these communities, but it happened. And so at every point in time that there was a challenge, we had to adapt. And so we're able to thankfully have a high retention rate of over 94% at the end of the study. And part of this is also due to strong community and participant engagement. This cannot be overemphasized. It's important that the community feels like they're part of the research that is being conducted, that they take ownership alongside whomever the researchers may be. And we must be ready to create locally driven solutions, realizing that one size solution does not fit all. We have to do what fits the cultural context. So for future studies such as the Enable 1.0 study, what do we recommend? First, we recommend that activities or recruitment activities are done in a way that aligns with local calendars / events in those communities. It's important that we invest in community relationships. That's what will build trust, and that's what will help us retain majority of the participants in such studies till the end of the study. We have to strengthen logistics. And so that means even before starting such studies, we must invest in logistic planning. We must anticipate unexpected logistics events in terms of transport, poor power supply. And we have to support field teams. A lot of field teams, they are doing a lot of emotional work, so they must be supported, and we have to communicate results promptly. We'd like to acknowledge the pioneers of Lassa fever research, our mentors, the research assistants, study participants and communities, SEPI and WAHO, and lastly, ISH. And thank you for having me.
Thank you. And we want to listen to the next presenter, Victor. He will share with us the post-mortem pathological insights into Lassa fever via minimal invasive tissue sampling, a comparative study in West Africa endemic region. Victor, you have the floor.
Good afternoon, everybody. I would like to say I'm not Victor. My name is Osaoji Isaac Ediawe. I'm actually standing for Victor and Teres Isaac, who are actually the owner of the work that they did. But fortunately, I'm the one that took the consent for all the patients that minimal invasive tissue sampling were done for. Historically, we remember that Lassa fever started in Nigeria in 1969 in Borno, a town called Lassa fever, where a group of scientists and doctors and nurses were involved in a patient who had Lassa fever. And at that point in time, they didn't know that patient had fever. But they did an autopsy because the doctor was worried. They did an autopsy. The doctor, the nurses, and those that handled the samples were infected and they died from that disease. May their soul rest in perfect peace. Amen. So minimal invasive tissue sampling. Lassa fever is a severe hemorrhagic disease which is endemic in Nigeria or in West Africa, notably in Nigeria, Sierra Leone, Guinea, and Liberia, where you have an estimated of 100,000 to 300,000 infections annually with a high case fatality rate of about 70%. This occurs annually and where organs are actually involved. But unfortunately, we can't actually say which organs are involved. And that's what gave birth to minimal invasive tissue sampling and also sepsis study, where they believe that there's a whole lot of hyperinflammatory markers like the interleukin-6, the procalcitonin, and other, probably the CRP. But we can't really tell which organs were involved, and this gave birth to minimal invasive tissue sampling. MITS offers is quite safe and is acceptable post-mortem. Unfortunately, the first autopsy was actually done in 1969, which was not ethically accepted at that point in time. So because of that, people felt that MITS is safe and you're not actually doing a full open autopsy because of the disease, which is quite virulent and has a high infectious disease rate. So MITS offers a safe, acceptable postmortem, which is an alternate of matching conventional autopsy, which results in about 90% of cases. This study prides itself as the first MITS employed for use in Lassa cases of Lassa fever in Africa. So what are the objectives? One is actually to investigate the organ pathology of fatal Lassa fever cases using the MITS. The specific objectives is one, to quantify and localize Lassa virus in tissues and fluids, to also identify infected cell populations using immunofluorescence and expansion microscopy, and also to investigate tissue pathology and associated molecular and immune responses. What were the methods? It was actually designed using a single center study in Ira Specialty Teaching Hospital, Nigeria, and also with our collaboration, Bernard Institute of Tropical Medicine and University of UKE in Hamburg, in Germany. The procedure was done using ultrasound guided biopsies, and the tissue analysis were done both locally and abroad. So the site research assistant or the pathologist, they must be trained for a good PPE and also how to do an ultrasound guided biopsy so that you'll be able to localize the different tissue that you need to biopsy for the MITS. So ethics was actually taken and it was approved, and approval was actually gone. Biosafety Street PPE, like I said, MITS is used to minimize Lassa virus disease risk. So this is the result. There were 27 MITS that was done, and it was performed using 22 cases and 5 controls. You can see the control, the median age is 29, and we had about 60 cases for male and 40% in female using the control, while for the Lassa rates, which was done between 2022 to 2025, we had about 22 MITIs done, and the median age of 32, males were 55, and female it was 45. And we tried to tie the clinical symptoms with what was done for the patient alongside with the MITIs. So you can see that they had fever and they were bleeding, they had seizures, and also jaundice. So gross and residual findings were also done using the ultrasound scan, which reviewed efficient for 65 cases of individuals with Lassa fever, and jaundice was observed clinically in 65% of Lassa fever patients. No efficiencies were noted in the control cases. So result, Lassa virus is in all organs, but it was found to be highest in the liver, lowest in the kidney. Some were actually positive for the brain samples. In the liver, they found necrosis, inflammation, viral protein in the hepatocyte, and also the presence of copper 6. The kidneys showed minimal damage with acute tubular necrosis and also a low viral antigen despite acute injury that the patient presented with. The spleen and lungs, they had some spleen immune changes. The lungs were congested with hemorrhage and viral antigen. While the brain, there was viral protein in endothelial cells in selected cases, suggesting that they had no infection. Maybe that could actually account for the meningitis or probably the encephalitis that they present with. So these were the results, the scan that were done, and also some of the histological findings that were also done for these participants. Now they showed some hyperechogenic kidney parenchyma, bilateral pleural effusion, and also a collapsed IVC. So in conclusion, we found that the liver was a major target organ, but probably that's why we have elevated liver enzymes like the AST and the LAT. The kidney probably because of we felt that Lassa could affect the kidney directly or indirectly through a bacterial infection, and they show some level of inflammation. While the brain, possible neuroinfection in severe cases, and the impact was to guide understanding and targeted therapies. So let's know that minimal invasive tissue, it's safe, it is practical using high quality samples. So recommendation, minimal invasive tissue sampling and clinical impact, standardized minimal invasive tissue and use of the result to improve Lassa fever management. This could actually help for our treatments and also for drugs for these patients. So we also need expansion and collaboration between our sites and the Bernard North Institute for Tropical Medicine and also the UKE Hamburg, and the community engagement to promote ethical interactions to support post-MITS this. So I will just say some things on that because it's quite difficult. That's what we talked about, the community engagement. When you lost a patient to Lassa fever and you are telling the relative that, please, we need to consent you for this procedure, they keep asking different questions. How come this wasn't done? And now that if you want to do this, what already happens? So what we try to do as such research assistant is to actually make them to understand that this is needed for possible revelation of what needs to be done for Lassa fever in terms of treatment and also for possible diagnosis. So acknowledgement, we would like to thank Ira Specialty Teaching Hospital, the Bernard North Institute for Tropical Medicine, Institute of Legal Medicine, and Institute of Neuropathology, University Medical Center, Hamburg, and also the people that gave us the funding, German Research Foundation, and Lebis Association, and also the participants, the families, may their soul rest in peace, who actually accepted us to do this procedure for them. And lastly, please, I'd like to also tell my wife, thank you. Thank you, Mrs. Ediawe.
Thank you so much. Thank you for sharing the experiences from the dead. Lastly, we want to listen to Professor Sonia Rezek. She's going to be sharing her experiences of Pedro Curie Institute of Tropical Diseases in Combating Infectious Diseases in Cuba. Thank you.
Well, I want to start by the end. First of all, I want to acknowledge and say thank you to WAHO that invited me to be here, especially Dr. Virgil that pushed very much to get this opportunity to be together. Because WAHO wants to start a cooperation with the institute in where I work. Well, I am Sonia Resic, the head of virology department at Tropical Medicine Institute, Pedro Curie in Cuba. Well, I am from Cuba, an island that is very far from here, but also very close. Our genes, our culture, our religions, in a 50% are from Africa, and most specific from West and Central Africa. Because of this, it is a very big honor for me to be here and to have the opportunity to participate in this magnificent scientific meeting and learn more about Lassa fever from all of you. I have a request. I want you to see me as a sister and not as a guest. Thank you. The Institute of Tropical Medicine Pedro Curie is known as IPK, is a center dedicated to research and services. The main activity is directed to protect the Cuban population and develop autochthonous knowledge. The IPK, with more than 18 years of existence, has been involved in the management and control of multiple infections, epidemic and pandemic disease, as you can see in the slides. To exemplify the experience of the Institute of Tropical Medicine in combating emerging infection diseases in Cuba, I will briefly refer to the Oropoche epidemics, the last one that we had last year. I know you don't have Oropoche here. It's better if I explain a little bit about that to you. And for me, has been very useful this conference because we don't have Lassa in Cuba, and I am learning a lot from you. It doesn't work. On May 9 last year, the Pan American Health Organization reported more than 5,000 cases of Oropoche fever in Bolivia, Brazil, Colombia, and Peru, and sent an alert with regard to autochthonous cases of areas of Brazil and Bolivia where the disease had not been previously. Oropoche is a member of the family Peribungianviridae and is maintained in the nature throughout selvatic and urban cycles. The urban cycle is thought to involve the bite to the Colecoides paraens midge, another urban vector in tropical regions where it feeds on both human and animals is the Culex mosquito. Sequence studies suggest the existence of 4 different genotypes. On May 20, the National Reference Lab for Arbovirosis at IPK received samples from 89 patients with acute febrile illness of unknown etiology from 2 different provinces of our country, one in the middle of the country and other in the east part of the country. Where in these 2 provinces was an increase of cases of the number of cases with that illness, and all of them were IgM for dengue negative. Dengue is the most common arbovirosis in Cuba. As you can see in the slides, in only a week, IPK could conclude that the epidemic was caused by the Oropoche virus during RT-PCRs and sequence. After the national alert was issued between May 28 to June 3rd, We processed 31 more serums samples collected from other locations with increases cases of acute febrile in a specific illness. Oropouche infection was confirmed in 80.6% of samples, and symptoms by order of frequency were fever, headache, general malaise, myalgia, and arthralgia. On September 19, Cuba reported the first 3 cases of Guillain-Barré syndrome associated with Oropouche infection. Guillain-Barré was identified in Cuba for the first time as a complication of this disease. It was published. At the end of the epidemic, we had 76 cases of Guillain-Barré syndrome associated with Oropouche infection with a positive virus detection in spinal fluid. We sequenced the whole genome of the virus using NGS. Phylogenetic analysis demonstrate that all Oropouche virus sequenced from Cuba belong to a monophyletic cluster nested with the AMCRO2 clade of the novel reassortant virus detected in Brazil. The Cuban subclade originated from a single viral introduction from Brazil state of Acre, probably in early February 2024, and has circulated cryptically until its identification in May, expanding nationwide in 3 months. What are the immediate and future research challenges and prospects regarding Oropouche fever in Cuba? We are establishing a national plan for entomological, virological, clinical, epidemiological, and other researches. We have to also include the characterization about environmental, vector, epidemiological, and social condition, some serological studies to know the prevalence of the infection and the immune response duration, but never know about that. And all of that research has to be done in urban, semi-urban, and rural areas with transmission because it's not the same. The pattern is not the same. It is necessary to continue the surveillance and study of neurological disorder because Guillain-Barré was described for the first time in our outbreak, and vertical transmission also. But the big challenge just right now is that there are currently few cases in Cuba now. As a conclusion, we can say that the outbreak in Cuba alerts the America and the world of the need for integrated dynamic surveillance system to detect the introduction and early transmission of Oropouche and consequently implement effective measures for its control. Thank you, and gracias en español.
Thank you so much, everyone. We have come to the end of the presentations. I will now open the floor for questions, answers, and comments. Yeah, can we have people that have to ask questions raise their hands? We have 1, 2, 3. All right, 4. So we'll take the questions. Please introduce yourself and then direct the question to a particular presenter.
All right. Thank you very much. I'm Dr. Tuko Moses. I'm a fellow of the clinical management for Lassa and a nephrologist. So I'm quite interested in all, but I will save time to just maybe pick 1 or 2. The first one I'm interested in is Professor Audu's presentation, which is quite interesting, showing the experiences healthcare workers face in the management. But beautiful as it is, I just want to give an insight into 2 things that I thought would improve in it, in the value. Is looking at maybe there were limitations, or you could consider them in the next phase. The counseling component of the healthcare workers, which is a very major component if you look at in the case management of Lassa that is usually left out. It's managed as an outbreak, emergency, everybody comes, patients are put somewhere, and there's very little interaction. That's really what in the end manifests with those kind of presentations, questions, comments, suspicions, blames, and all the rest. Then just to add too, there's a second component of standard of care. The standard of care in the management of patients who are suspected and isolated, we would consider probably to assess what standard of care was given, because sometimes the standard of care is much lower than the standard of care of patients that we know they are not having Lassa. So the chances are that you end up having patients who are suspected, who turn out negative, but they may have died from simple things that were not availed them simply because they were suspected. The same experiences came during COVID, but by and large, it's a good one. Then for the MITS study, very excellent. Like he said, it's the first, at least that I've seen, looking at the tissue. So it's an excellent job. And I just want to say that if you look at the mechanisms proposed for kidney injury, which is the commonest complication, at least, or very closely followed by bleeding, you see that it may have corresponded with your preliminary findings to say that there's very little, despite the high rate of AKI, you saw very little changes at level of kidneys. You saw ATN, which was measured. But if you juxtapose with the clinical finding of pre-renal cause being very significant as a cause of AKI in those patients, then it will make sense, because if we attended to little things of fluid therapy, you know, blood transfusion, supportive management, then most of it would not have caused, you know, necrotic damages at the level of the kidney. And to our sister from way close Cuba, like you said, very quite interesting to learn from the experiences of so many pathogens that you have actually worked on, and outbreak responses that your lab has been able to do. And just to appreciate that WAHO has done the right thing by linking up with people like you with the experience. Probably if you put Lassa on the burner too, we will learn a lot also from what you have found in other viruses. Thank you.
Thank you, sir. The second question.
Yeah, thank you very much for the presentation. I am Adidosu Nelson, consultant clinical microbiologist. My question goes directly to the MITC. And in time of the autopsy, I believe there are risks that are involved. So what were the strategies that were in place to avoid or to prevent those risks that are involved? Thank you.
Thank you. The third one, this way.
Voilà, je disais bonsoir à tous. Je suis Kunduno Fararemo. Je suis le responsable du laboratoire des fièvres hémorragiques virales à Guéguédou, ça c'est en République de Guinée. Je voudrais poser la question à Dr Amen, hein, la dame qui a très bien présenté là. Au fait, c'est par rapport aux défis qu'elle a évoqués concernant les activités communautaires. Suite à ces défis, est-ce qu'au cours de l'étude, l'engagement communautaire a été une priorité pour vous? Si oui, est-ce que les leaders communautaires, particulièrement, je vais parler des chefs de district, des chefs de secteur. Sorry? Ah, si je peux recommencer. Voilà, OK. Donc, je disais que par rapport à votre étude, vous avez évoqué quelques défis. It's OK now? Bien. Donc, vous avez évoqué quelques défis par rapport, n'est-ce pas, au suivi longitudinal de vos participants. Alors, je disais que, est-ce que l'engagement communautaire a été une priorité pour vous? Si oui, est-ce que plus particulièrement les leaders communautaires, notamment les chefs de district, les chefs de secteur, les délégués de la jeunesse qui contribuent à la réussite de nos études dans les zones ont été, disons, concernés. Sinon, je pense que pour pouvoir maintenir la cohorte à long terme, je pense qu'il faudrait changer de stratégie, n'est-ce pas, par rapport à l'engagement communautaire. Merci.
Merci. The last question.
Okay, merci. François. My question goes to the colleague who presented on postmortem analysis. So yesterday, some colleague of yours who presented studies they did in Nigeria demonstrated that the main complication was kidney injuries, and that needed hemodialysis for most of the patients admitted in intensive care unit. But how come with postmortem diagnosis, you find that kidney injury are just superficial and not more the complication, the main complication or the main post-diagnosis for those patients who died of this? So acute kidney injury as the key of the main complication during admission or during the management of the patient, but in the post-mortem, there is no sign or kidney injury goes stand the second, even with less, as you put, less seen as the post-mortem sample. How can you explain those discrepancies? Because normally, if the kidney injury acute kidney injury is the main complication, we should see normally some effect of these in the analysis of the sampling in the postmortem.
Yeah.
So they should have either some problem at the clinical level or some problem at the postmortem analysis. Thank you.
Thank you. We'll take the last question here, and then we'll take the responses from all the presenters. We are running out of time for the next section.
All right, good evening. Jamil Bello is my name. I'm from Atbut, Bauchi, Nigeria. I have a question for the presenter on a presenter from Guinea who shed light into some of the surveillance in Guinea and also presented some data for the PCR results that were conducted. From the study, I noticed the median for the GPC gene is 31 and also for the L gene is 26. However, I think maybe it's not a question, perhaps a recommendation. Maybe the study can equally look into stratifying the data to know the variation from these PCR results from those that are alive and those that are dead. Because I noticed the CSR is somewhere around 60%, which is quite very high. I did similar study, although a poster that shows that L gene perhaps could be a good predictor of treatment outcome. We find something very closer to the median score that you have for the L gene. And the GPC, ours, we found that it's around 30 CT value for GPC, while we have 24 CT value for. So we found that there is a difference in the CT value for L gene for both the dead and their live patient. So stratifying the data will help you and get to understand the difference in these CT values and how they can best inform your intervention. Sometimes you might not be able to dictate, or your PC might not be able to pick up the GPC gene on time, and maybe just the L gene being the large gene. So that can inform intervention too. Thank you very much.
Thank you so much for those excellent questions. We will have opportunity to get responses from the speakers. So the way we'll take it, we'll start from the end, Heinrich. and I will take the responses down to the end. For each speaker, you respond to the questions within a minute, and then if you don't have a question, you can give us your parting words, what you want us to take home from your presentation. Let's start from the beginning.
Thanks a lot for the comment. Yeah, we are stratifying now the analysis. We're also considering the time between the onset of symptoms and the testing, because of course there are variables then. Also, if there are other comorbidities, any other things, and indeed we sometimes don't see both the target when the PCR is done, and we see this very variable difference between the two targets. So we are digging a bit more on this. And indeed, if this can be used as a proxy to inform, this will be for sure used. And we are ongoing on this. Thanks a lot.
Thank you. The next person. Yes.
Okay, thanks very much. Concerning my presentation, I think the key message is this, to say that after doing the sequencing analysis, we realized that Benin has its own reservoir. So from today, we not blame again Nigeria people that they are responsible of Lassa outbreak in Benin. So today, Benin will take care of his patient, not blaming again Nigeria people. Thank you.
Thank you. Okay, the next, please.
Okay, thank you so much for your question. So in terms of handling those, what we actually do is, one, have a good infection prevention control. And how do you do this, or how do you go about it? For the pathologist or the site research assistant who is involved, must be trained properly on donning and doffing. And when that procedure is, before the procedure is done, you need to understand how to do an ultrasound scan for the different tissues you want to use. We don't allow them to use a very sharp needle. You use a blunt needle so that you don't get yourself just with that. They, at the end of the day, the different tissues that are being collected are put in triple package, where you put them into the bucket and transfer to the BSL L3 lab. That's what is done for that. Then a very good question, that most of the complication is actually acute kidney injury. But what we found out in the MITS is that very few patients actually had, from the biopsy that was done, very few results actually came out from there. Instead, it was more of the kidney, it's more of the liver that were actually involved, where you had hepatocellular necrosis compared to what you have in the kidney. Like my other colleague has actually explained, it's also possible, because patients were not properly hydrated, they could also have acute tubular necrosis. But it's a research. And another thing again that could probably account for that is also depend on the techniques, which part of the kidney was actually biopsied when that procedure was done. But I think at the end of the day, we'll actually have a better result for that. This is more of like a preliminary analysis that was done for the patient. Thank you.
Thank you.
So probably my parting word, I actually studied that it was actually a full autopsy that was done in the past, but now we are doing minimal invasive tissue sampling. We believe that we should be encouraged to do this in terms of collaboration, where over time we could actually have a full autopsy that could be done for the patient, where the scientists or the pathologists will have a better view of the different tissues that they want to biopsy. Thank you.
Thank you.
To answer the question that I was asked, yes, community engagement was actively involved. As a matter of fact, before this data collection aspect of the study started, before participants were recruited, team leads met with, governors, met with local government chairmen, and then they also met with palace chiefs, ward in Nigeria, you have local villages or local quarters within these villages. So they met with the general palace chiefs in the 7 communities. They also met with the local quarter leaders, what is popularly called in Edo State, where we do it, the Edion Wilays, and so they met with these people. The study had community liaison officers employed as part of the study. So they were in the study throughout from beginning to end, and they were called upon when there were participants retention issues that went beyond the data collector's ability to handle. So community engagement was something that we took very seriously, and we attribute it to the reason why we probably had, in part, in addition to other strategies, over a 94% retention rate at the end of the study.
Dr. Tuku, yours was more of comments, and I want to thank you for that comment. What I want to say here is that in the national guideline, emphasis is on the patients. A little is said about, the healthcare providers. Probably maybe because we're still at the elementary phase of how this management is coming up. And then again, maybe because a lot of health workers have not actually come up with the challenges that we're just trying to see now. Stigmatization initially was targeted on the clients and also where they come from. But now that we begin to see cases where the health workers themselves are being stigmatized and they're having a lot of psychological issues, I think that your recommendation is handy and we need to look into that. When we talk about the standard of care, it's the same principle again too. And a lot of studies is also ongoing. By the time we look into it, they will now conceptualize and see what is best for us. Thank you.
Thank you very much, the panel of speakers. Thank you, the audience, for the excellent questions. At this point, we want to draw the session to a close. Can you give a round of applause for the speakers and for yourself? Thank you. We wish you the present remaining sessions in the conference. Thank you.
Your finger is blocking it. Your finger.
Hello, hello. Good evening, everybody. We'll be starting our next plenary session in 3 minutes. Hello, good evening, everybody. We will ask everybody to sit down so that we can start the plenary. So good evening, everybody. Welcome to this plenary session number 3. And welcome to an increasingly crucial topic in the field of public health: AI and big data in epidemic prediction, transformational or hype. Is it fake or is it true? So this is a very interesting topic. And I have the honor to moderate. My name is Adamandir. I am a physician, senior epidemiologist, data scientist. I've been trained at MIT. And I've been supporting CDC, US Centers for Disease Control, on the field epidemiology training program in Africa. And I also lead a team in the US, and then because I'm based in the US and in Senegal, on supporting African health professionals on data science and artificial intelligence on capacity building. I'm also supporting in public health and nutrition. So it's my pleasure to be in this plenary session to facilitate this session. So the objective of this session today, I think we don't have the projection. May I ask the projection to start? So the objective of this session is a presentation. Right. Right. Okay, next slide. I already introduced myself. Next slide, please. Yeah, the objective is today to critically examine the promise and limitation of AI and big data. So both are going together, big data and AI. We will dig into this during the discussion. And as a tool for epidemic prediction and response, particularly in West Africa. So we will also explore whether these technologies are truly transformative, innovation, or overblown distraction from the basic needs of health system in the context of African health system. So to prepare for our panel discussion, I will provide a balanced overview of perspective so that we have some kind of food for meat so that we can dig with that. And then, and perspective for those, are we against or are we for this kind of AI technologies and big data in the prediction of outbreaks or epidemic. But before that, I need this session to be very participative so that the question is, are we for or are we against artificial intelligence for the prediction of epidemic? So I will ask you to use the, we can show the QR code. I will ask you, don't know what's going on. I will ask you to, there will be a QR code. I will ask the audience who are for AI to use in surveillance, outbreak surveillance, and who are against. So those who are for, you just need to scan the QR code and answer for. And then we will see after the discussion if you are still for or against. Okay, are we okay with that? Everybody is with that. Okay, so I will ask the IT guy. The QR code is here. So just scan the QR code. I will ask everybody to participate so that it will be very fruitful. And then we'll see after the discussion if it is okay or not. Hmm? Yes. So you see, we will see as you are scanning, we will see the result as. Wow. Wow. You see, it's getting down. Becomes very interesting. Yes. Okay. Is everybody scanned? So we have more than 90%, which is everybody is for AI. So I'm very glad that everybody is for AI. It's increasing. I speak very early. Yes. Okay. It's coming. Now. 27, 21, 28, 21. Wow. What is going on? Okay, it's getting down to 13, 15, balancing between 13 and 15. It will be the median. Okay. Okay, let's wait for, let's say, 2-3 minutes, and then we will move on. We will do the same exercise at the end of this session to see where we are at, so that we can compare, because it's usually based on our knowledge and understanding of AI. So, wow. All right. Okay, we can already, everybody already scanned this, the QR code. Are there some people who didn't scan this QR code? Okay. All right. So we're still on the good mood, because 85 is a fairly high rate of, acceptance of AI within the surveillance system. So, which is a good news. So let's applaud ourselves. This is something I didn't expect 85 for this session at the beginning. So let me just do a brief presentation so that we will put out the foundation of this discussion, and then I will introduce the panel, the panelists. Let's go back, please, to the presentation. Let's go back to the presentation, please. Go back. Back. Ah, this is okay. Oh, so in introduction, epidemics pose considerable. We already know that it poses considerable global threat to health, and then not only globally but economically, the stability of the country. We already know that with Ebola, social system. And then what we need is rapid prediction and detection, which is usually something that is really lacking with our surveillance system. And traditionally, epidemiological surveillance and response are lacking, the rapidity of reaction as it relates to surveillance and response, which could be very, a gap that could be filled very easily with AI, artificial intelligence. So it is in this context that the integration of artificial intelligence and big data is proposing a very powerful solution And the next slide. So, okay. This one. Forward, back, okay. So let's go fishing. Because when usually we are talking about data science and artificial intelligence, we are talking about data. We're talking about information, we're talking about data for decision making. So let's go fishing for a transformative potential of big data. What is the potential of AI and big data? Let's consider it like a rod that we are fishing data. And the more quick we can fish data, the more, and then analyze data, the more rapid we can conduct surveillance and response. So you see that the model we will examine propose a comprehensive approach that integrates AI and big data to predict epidemics with increased accuracy and speed. So the first thing is you have an integration of heterogeneous data. Usually over the past, we have very few kind of type of data. You have text or spreadsheets or numbers, right? We were using, but now we have any kind of data. We have the sound, which is a kind of data, the image, which is a kind of data. So we use a whole range of data so that, and in a quick way, so that we can analyze and then take a decision. So AI can analyze vast and complex volumes of data in real time from diverse sources. So you see here from social media, which was not usually, we were not used as a surveillance officers, as surveillance people to extract data from social media. But now with AI, it's easily doable. From electronic health records, from environment sensors, the temperature, the humidity. When we talk about, pollution and outbreaks, it's very complex data. We can use AI to analyze data, air quality, mobility patterns and mobile phone, and electronic medical records also, genomic surveillance, the pathogens, evolution, search engines, queries, laboratory report. You see, we can fish all kinds of data with AI very easily without a big burden of collecting data and capacitating, healthcare workers on it and spending a whole lot of time on it. We can go up to waste water data, genomic sequencing, worldwide, and then lab notification and report. All these kind of sources allow us with AI to go very quickly and collect the data and analyze the data. So how are we doing that? We will use advanced techniques. Advanced techniques such as deep learning, as you can see here, which is a way of analyzing data, which is capable of processing sequential data, such as disease progression over the time of period and geographical space, which is very helpful now with outbreak prediction and outbreak response. We can also use what we call natural language processing for essentially for extracting insight from what we call unstructured data, which are, for example, from text. From text, you can extract data very easily. You don't need a spreadsheet to have your data. And then it will help a lot, which will allow us to go through social medias and all non-traditional sources of data to extract the data and then analyze the data. So not to mention sorry, not to mention not working. Anyway, not to mention other sources, spatio-temporal analytics, computer vision, and reinforcement learning. So as you can see, we have significant benefit of the integration of big data and artificial intelligence. It offers, it offers early and rapid detection. It offers improved forecasting, optimized resource allocation, and strengthening global health resilience and relevance to low resource settings. Nonetheless, we have some challenges and limitations, which are, which you can see here, the data issue, availability and quality, the data bias, which is also a lack of training, which involve also data bias when people are collecting, technical and infrastructure barrier, skills adoption. Can you hear me? Okay. Lack of digital skills and expertise, non-region specific model. You see, we have a lot to offer with AI, but there is a lot of work to be done because we need large amount of data to analyze our own data in Africa. As of now, we are using models from Europe and the US, which is not our own data. So we need to adapt to that. The ethical and regulatory consideration, you know, there is no consent form, for example, when you are using AI, which is also a big issue. The ownership of data, which is an issue. The oversight and accountability, all these kind of issues, we need to tackle them on a regulatory framework and then to move very slowly in this big environment of data. So these are some very few insights so that we can have a foundation for the discussion. And then some strategic recommendation are to invest in data quality, robust quality data, develop region specificity AI model, build AI local healthcare workforce. I'm really insisting on this, the workforce, on AI, on modeling, all those kind. We need those skills. Enhance interoperability. There was an interesting discussion yesterday. Establish ethical framework and promote collaborative. This will lead me to now introduce the panelists, these prestigious panels members for this discussion. So let me just introduce the first panelist member, who is Dr. Etienne L. Kwa. Can you join the panel? So Dr. Etienne L. Kwa currently serves as the Health Emergency Information Management and Risk Assessment Program Area Manager at WHO Afro. He has accumulated over 20 years of international experience in public health, international development, and humanitarian projects in several countries under UNDP, US CDC, USAID, EAR, and WHO in the area of global health security, health emergency, disaster prevention and preparedness, food security, family planning, malaria, and HIV. This is really another applause because it's a really huge breadth of experience. So the second member, which is also a prestigious member, Dr. Peter Adebayo Adewuyi. So applause for him. So he's a seasoned public health physician and senior field epidemiologist with over 2 decades of experience, which is huge spanning over outbreak response, epidemiological modeling, and digital health innovation across West Africa. He currently serves as a resident advisor, FETP, Field Epidemiology Training Program, and country team lead for Africa in Liberia. He is a strong advocate for integrating artificial intelligence, and we are very glad that he is here to share his experience in public health, and recently presented using AI for scientific writing, which is great. It's on the capacity building, of AI at the GF webinar series. His interests include applying AI and big data for real-time disease prediction, optimizing immunization system, and strengthening fragile health system. The third, which is the only woman, I don't know if she's there, Dr. Uzma Alam. So he's a science policy leader, a global health expert, currently the policy and data lead at the Science for Africa Foundation. Her work focuses on evidence-based STI strategy and crafting forward-thinking health policy at the intersection of technology and data for equitable impact. Dr. Alam pioneered science policy portfolio for Africa, integrating indigenous knowledge and African-led data, a model cited in the EU AU strategy. She contributed expert insight at the high-level policy. So this will be very fruitful in terms of discussion for the takeaway of this discussion as it relates to policy and AI policy, shaping policy development at the continental. She's currently the advisor on the advisory team for the development of Malawi's national science, technology, and innovation policy. Another round of applause for Dr. Uzma. And then last but not least, Mr. Usman Nikema, who is an information system and digital transformation expert. Welcome, Mr. Nikema. With over 15 years of experience at the intersection of IT infrastructure, digital health, and cloud technology. As an IT engineer at the West African Health Organization, WAHO, he led cloud migration for digital services and currently manages projects to optimize internal workflows. He also advises the PROA Lab project on laboratory information management system and helped draft the Ecowas 2026-2030 Regional Digital Health Strategic Plan. Usman holds multiple IT certification, Microsoft Linux, and cybersecurity, IT, and etc., and lectures at university and delivers AI focus. These are very prestigious panel. I'm very proud to be in this panel. Another round of applause for everybody. So I'm gonna join the panel and we will start right away the questions for the panel, and then we'll ask, let the audience to ask questions, if you allow me. Okay? Thank you. We will start with Dr. Peter Adewoyu. Sorry. So, Dr. Peter, given your extensive experience in outbreak response and advocacy for AI integration in public health in West Africa, could you share specific instances where AI-enabled surveillance has tangibly changed the course of an outbreak or enable a faster response?
Thank you very much, Doc, and
Thank you, Wow, for inviting me to this panel discussion. In 2013, I had the privilege of, that was shortly after I finished my FETP. During my FETP, I was posted to Oyo State in Nigeria, where after analyzing the measles data, we found out that the previous year, there were outbreaks, 44 outbreaks of measles that were missed. And in my inquisitive nature, I decided to work with computer science students in UI. And we developed some machine learning algorithm using the SVG, using the KNN, to be able to predict measles outbreak. And that was successful. About 98% prediction was accurate. Also, that was 2013. In 2014, healthmap.org used AI to identify Ebola outbreak 4 days before WHO was notified. And what HealthMap does is to use AI algorithms to scan and scrape the web for news, like what Doc has mentioned in his introduction, that we have social media and all of that. So they were able to detect 4 days before WHO could detect. And this is one of the problems, if the structured public health system had used that information, would have been able to save more deaths, because between these 4 days, we've had about 70 more deaths. Because by the time the AI was able to detect it in March 14, there were only 8 deaths. And 4 days after, there were already 23. So those are part of experiences that we've had in West Africa. Also, in Nigeria, they use AI in Lassa fever risk mapping. And one of the presentations that we have had in this conference at the health facility level, they use SG Boost, is a machine algorithm that was used to detect between malaria and Lassa fever, and with about 99 to 98% accuracy and precision. If we're able to, maybe at screening level, we're able to use that AI, and so all these suspected Lassa fever cases, move them to see an AI specialist quickly. We might be able to commence treatment on time and all of that. So I think AI is something that we should be thinking about. Although a lot of people are afraid of their data and all of that, but if we deploy, we'll get quicker response to outbreaks. We'll get ability to predict outbreaks. For the last one, a recent study done using AI, scraping information from the web and all of that, has helped to predict that in the next 10 years, so we are looking to see if it happens, that in the next 10 years, Lassa fever will move to Central and East Africa. So it's something that has been predicted by AI, and we can watch and see if that really happens. Thank you.
Thank you for this wonderful response and answer. I think you really emphasize the fact that even though people were thinking that in the African continent we were far behind as it relates to AI, but we were still using. And then the experience of Ebola is showing us that, we were using without being aware that we can use this kind of tool to advance in terms of preparedness response. And the other thing that you mentioned is also critically important as it relates to, predicting the Lassa fever in the next 20 10 to 20 years, which is also critically important, especially for this conference, and then for this, the topic of this conference is about Lassa fever. So AI will help us now better master data. So the second question I have for you is, for country, particularly in West Africa with limited infrastructure, how can AI tools be realistically adopted? And what crucial role can regional collaboration or cloud-based platform play in overcoming this resource gap?
Thank you very much for that question. I think one of the things that we have already is the little data that we're already collecting, which we use the DHIS2, SOMAS, and other platforms that we are using in West Africa. Those platforms or those digital tools can be plugged, can have AI plugged into them and help us to be able to identify, like I said earlier on, I mean, there were 44 outbreaks that were not identified. If AI has been plugged into this data that has been collected, it will be able to notify real time when the epidemic threshold has been crossed. That is one. And then we'll also need to increase our digital data collection up to the health facility level at all over the region in West Africa. I know Sierra Leone has started. Liberia is pushing for it, so that if we are able to collect digitalized data and plug in AI into that, that will help us to be able to discover a lot of things. We're talking about early detection. Also, the region can plug into Africa CDC have some cloud-based projects that they have developed. The region can also plug into that to help in improving our Lassa fever detection and prediction. Thank you.
Okay, so these also are great responses. And then I have to echo what you were saying about the current platform you are using for either collecting or storing data. But there is a very big limitation as it relates to using and analyzing data. You were talking about DHIS2, you're talking about now SORMAS is helping, but if we can add to those tools the AI, that will be an added value in terms of improving. And then just to mention one of my experience, because I was supporting the Central African region as it relates to surveillance with FETP during the Marlborough. So there was a community, community deaths, with event-based surveillance and community-based surveillance. There were around 20 deaths at the border with Cameroon and Equatorial Guinea. So at that time, I was already using AI tools. And then I used AI system for rapid alert system to put in place a system, an alert system. Because the traditional system we were using is you have to file the case investigation from the alert form, which is taking too long. So just to echo what you were saying, we need to improve our platform. And the other thing that capacity building for health facility for early detection. The health facility are equipped with some IT tools. So if we can do something to help them on early detection, it will be very helpful. Thank you so much for this very wonderful response. So the next series of questions is for Mr. Nikema. AI, from your perspective, Mr. Nikema, does investing in AI before sufficiently addressing basic reporting mechanism, laboratory capacity and workforce training risks, diverting limited resource away from these essential foundational health system needs?
Ok, merci beaucoup pour. Non? Euh, alors, il est important ici que les gens se rendent compte de ce dont on parle. Quand on a affiché tout à l'heure le sondage, la plupart de la salle, des participants, sont pour l'IA et très peu sont contre. Ici, il ne s'agit pas de l'IA que nous connaissons à travers Internet, que nous connaissons à travers les réseaux sociaux. Ce n'est pas ChatGPT, ce n'est pas DeepSeek. Ici, nous parlons d'IA qui sera appliquée à notre contexte pour détecter, pour prévenir les épidémies. Et là, je pense qu'il faut que les gens sachent en réalité à quoi ils ont affaire. Quand nous parlons d'IA, nous voyons trois éléments. D'abord, nous avons des algorithmes. Ensuite, nous avons de la puissance de calcul, c'est-à-dire que nous avons des serveurs, des machines sur lesquelles vont tourner ces algorithmes. Et enfin, nous avons des données. Et quand on parle d'IA fiable, c'est que cette IA s'est nourrie de données fiables. Alors que nous savons très bien que nous n'avons pas de données. Le sujet parle d'IA et de Big Data. Big Data, nous n'avons même pas encore de Petite Data. Parce que les statistiques disent que en Afrique, plus de 600 millions d'Africains n'ont pas accès à l'électricité. Le taux de pénétration Internet est de moins de 50%. Comment est-ce qu'avec ça, on peut baser notre système de surveillance sur l'intelligence artificielle? Et il y a une chose qu'il faut noter. Jusqu'à présent, 80% des épidémies ont été détectées par les réseaux communautaires. Donc moi, je pense que pour le moment, il faut aller à l'essentiel, équiper les laboratoires de réactifs, d'équipements qui permettent, au niveau basique possible, de pouvoir avoir, disons, ce qu'il faut pour pouvoir construire les prémices de données sur lesquelles l'IA peut probablement plus tard se nourrir. Ça, c'est la première des choses. L'autre chose aussi, c'est la formation de nos pairs professionnels de santé. Nous savons très bien que nous avons une résistance farouche à la technologie. Et là, nous parlons de très haute technologie. Et malheureusement, ce n'est pas ces technologies-là qui seront sur le terrain pour récolter les données. Ce seront les agents communautaires, ce seront les infirmiers. Et donc, il est important de miser aussi sur la formation de ces gens-là, de mettre en place des mécanismes de base pour pouvoir avoir des données fiables d'abord, quelque chose qui puisse permettre de construire des systèmes, disons, simples, qui tiennent compte de nos réalités, avant maintenant de pouvoir aller plus loin vers des systèmes plus sophistiqués. Merci.
Thank you so much. I think you really pinpoint a very critical issue, which is the data infrastructure in our continent. And then the other thing is also the capacity building. So I will add to what you were saying, which is critically important, that we need to adapt our training system to our local context. So we don't need big infrastructure to use AI and adapt it to our system. What you are mentioning is really critically important. What kind of mechanism can we use to adapt our workforce development in terms of AI and big data? This is critically important, especially in a resource-limited country. I really like this The other thing that you mentioned is that the event-based surveillance at the community level. How can we? But I think there are also some interesting perspective as it relates use of phone. You know, now you have people everywhere. As they can use their phone, now we can figure out how we can reinforce them to use their phone and using AI in terms of preparedness, detection, and response. This is really interesting. The other question I have for you, no, I think the other question I have for you, Mr. Nikema, is what specific kinds of AI-related investment would you advocate for that genuinely reinforce and strengthen rather than bypass the core surveillance infrastructure within the region?
Alors, comme je le disais, pour moi, en tenant compte de nos... Il faudra aller vers un modèle simple. Comme vous avez dit, si bien dit tout à l'heure, permettre aux agents de pouvoir utiliser ce qui existe déjà. Je prends un exemple tout simple. Permettre de pouvoir utiliser les réseaux sociaux, comme WhatsApp par exemple, pour envoyer un rapport. Déjà, un pas. Cela signifie qu'il y a au moins Internet, qu'il a accès à un téléphone mobile et qu'il sait s'y prendre. Ensuite, les former sur des logiciels simples qui peuvent fonctionner aussi en mode déconnecté parce que nous savons très bien que la réalité sur le terrain, nous n'avons pas souvent une très bonne connexion Internet. Donc, le système, comment, malgré ses fonctionnalités, malgré qu'il soit sophistiqué, s'il n'y a pas de moyen de transmission, cela ne va pas marcher. Et pour cela, il faudra mettre en place un système qui puisse fonctionner, même quand nous n'avons pas de bonne connexion Internet. On peut commencer par ça. Ensuite, on peut migrer vers une deuxième phase, qui est de mettre en place encore des mécanismes un peu plus intelligents, qui puissent offrir des tableaux de bord, qui puissent faire des analyses sommaires sur les données que l'on pourra récolter. Et quand nous allons bien éprouver ces systèmes, quand nous allons avoir suffisamment de données que nous pourrons juger entre guillemets fiables, à ce moment, nous pourrons aller vers ce qu'on appelle le deep learning et pouvoir avoir des IA réellement robustes qui permettront à ce moment de pouvoir prévenir très tôt les épidémies.
This is really great, and then I really like the question, the answer around using capacity building in data analysis, because usually our workforce in the health professional, they are usually trained to collect data, to process data, but they are very limited capacity in terms of analyzing and using data for decision making. I think if you, like you said, someone, even the user, the recipient, they can now start using AI to better understand their own data at the community level. And this is critically important for decision making. Usually we use this huge amount and then very budget consuming training where we train people to collect data instead of very quickly using the data for decision making. And then the solution you're proposing, very simply, start very simple at the lowest level and then move as it relates to learning all these very complex techniques like deep learning, and large language model, the modeling, all those kind of stuff, machine learning. This is interesting, and thank you for your answer. Now it's time for Dr. Usma to guide us on the policy level. Based on your research and work with Foundation promoting science in Africa, what are some of the most common missteps you have observed when AI tools are introduced into fragile health system without appropriate ecosystem readiness?
So thank you, moderator, for that question, and thank you for the organizers to have me on this, to the wonderful panelists. So I really like the way this discussion has been framed, right? So you've already said in the question, right, what are the missteps when AI tools are put into fragile systems, right? And the first thing is that any tool, right, not even AI, any tool will fail if the ecosystem is not ready. And when you were presenting your slides, you already gave us the gaps in ecosystem, right? And my colleague here already, highlighted cases around connectivity and trained staff, right? But another one, let's take a deeper dive, is that data piece, because that's very important, right? Because it's data in, decision out, right? And again, let me go to the slides that you brought up, right? So you said AI lets us integrate varied data sets. But again, from the conversations here, we know there's a lot of gaps in data, right? But the other thing is, even when there's published data, who's publishing it? Is it our African scientists? Is it our African experts? And, if it's not published, does that mean that data is not important for decision making, especially in the community we're going to go respond in? Right? So are we saying we're just making a decision based on what we have and the rest doesn't matter? Right? So, and then you talked about the ability of AI to pick signals from social media, right? Again, it's about context, right? How many of so I come from Kenya. So we in East Africa have a huge pastoralist communities, the Maasai people, right? And lots of elderly folks. How many of these people are on social media? What signal are we picking? Right? And then let's add to that thought, right? So the argument when it comes to data is that, we need big open data sets. We need to collaborate on data. Let's do cross-border coordination. But again, we have said that we don't have that capacity to use the data. So Africa will put out its data. Who's going to benefit? Who is going to use that data and drive value out of it? Right? So are we adding problems to ourselves? And we know this, right? There is capacity in the West. That's how even our scientific system is set up. There is this, unfortunately, this extractive relationship where our data is used that doesn't benefit us. And then one other piece around this whole question, again, on data and fit is biases. We've talked about biases with underrepresentation, whose data, gender, national, right? But another thing that really doesn't come up in conversations, especially in the African context, and my colleague alluded to it, is that need of big data centers, the electricity to run it, but there's also cooling systems involved, right? And those are linked to a climate impact. Are we going to put these big data centers, I don't know, in the middle of the Sahel and then find water sources to cool it? Or is a water-rich country going to take the hit for the footprint of this, right? So is this solution ready for us? So that's one, the over-reliance of technology, which is not eco-fit system, right? We've talked about poor contextual fit. COVID was a classical example. Everybody said, Africa was going to be hit big. Then it was in hindsight that we knew, there was some immunity. So climate science, climate sciences is showing that our disease patterns are emerging very rapidly. We're not understanding these patterns. So what is the model going to understand, right? And then the other thing is obviously and, you know, a tool is just as good as it's going to be used, right? So a big issue is when we have lack of involvement from local users. So here again, we are saying, oh yeah, there are big AI models that can be trained with, you know, good statistic methods to fit the African gap and stuff, but whose agenda is that? Was our policy makers involved in it? Were our researchers involved in it? Were our communities involved in it, right? And yet we are going to ask them to trust the system. And it's very closely linked to the vaccine story, right? There was no local uptake. It was not a locally owned agenda. It wasn't a, you know, a bottoms up approach, but then we're just asking people to trust the system. So I think those are the big ones. And, you know, I've got a bigger list than that, but I'll stop at that for now.
Well, thank you so much.
Sorry, I don't agree with the last two speakers,
Yes.
but I'll wait for my next time. to
Okay.
speak. Yeah.
So you go ahead. You want to add something? You want to add something? Okay. Okay. So thank you so much. We're in a discussion, so any thought is welcome. As yes, but thank you, Dr. Usma. I think you mentioned very critical points. I really like the fact that who is owning the data and who is, you know, using the data for who. And I really like this, the way you emphasize this point, because especially with AI, things are evolving very quickly. You see, we were talking about ChatGPT, and then after ChatGPT, we are now talking about AI agents, multi-agents, and then we are always consuming, without mastering what we are doing with our data. So we need to be very careful. And then I like the way, for example, maybe Chinese and other people are going to their space, to their rhythm, to better understand and then adapt the solution to their own context. I think Africa also, we need to do that. But what you said is critically important. The bias is also a very important point. I think the big data issue is also at the policy level is something we need also to address, as you said, and then we need to figure out how we can at least agree as a regional entity, how we can leverage our capacities to come to at least have some capacity in terms of big data. The second question I have for you is how should African countries effectively define and drive their own research and implementation agenda for AI, ensuring that the developed tools align with with genuine public health priority, rather than solely serving the interests of international tech firms or donors?
That's for me too. Okay. So I think that's a very important question, right? Because it links to what we have said. For AI to be effective, it has to be African-led. And what does that mean? We've spoken about it. Means it needs to have data, it needs to have capacity, it needs to be, you know, governed by a fit that fits us, and also regulated and coordinated. So what are some of the steps, right? So one, I've already alluded to it, is the importance of stakeholder-led priority setting. We need to stop working in this own model, whether it's our research agenda, whether it's our policy agenda, whether it's our healthcare agenda, that, you know, we are the experts, X and Y, Z, there's a knowledge gap. It's not that. We really need to bring everybody to the table right from the start. And, you know, that's one of the models that the Science for Africa Foundation, where I come from, really promotes within our research settings and agenda setting, that it is about the people, it is about the community engagement, and it's about the people. It's about a holistic approach. So that's one, right? We've already talked about the need to promote local capacity and leadership. You've spoken very well about it, so I won't you know, touch much on it. We've talked about transparent data use. So, we can't say, we need to fix this problem, right? And the fix to this is, how do we govern it? And let me give you an example, right? So by the show of hands, how many people in the room think AI is a relatively new phenomena in Africa, like 7 years, 10 years? Anybody? AI in general, the start of AI as a tool. Yeah? Okay, so let me tell you, the first published use case of AI, in Africa was in 2000, right? So we are still, 25 years later, we are still having the same conversation. Is it a hype? Is it a use? So what has gone miss there, right? And that again is about governance that Africa needs to set its own policy frameworks, which then contextualize our needs, right? So that would be a policy framework that says, this is what ethics means in Africa. This is what community means in Africa. This is what capacity or knowledge means in Africa, right? This is what partnerships mean. So it's really about contextualizing. And then obviously, that allows regional coordination. So that allows cross-border sharing, capacity development, and resource mobilization. But then the other quick one is what we've talked about is long-term funding, right? We really need, as Africa, as national countries, as partners, we really need to look into how do we provide long-term funding. But it's not just, again, about just the modeler or the innovator or the engineer, but it's also, about the policymakers, about the scientists. So we are training, building that capacity along. Otherwise, it'll be just a fractured approach. And that's, again, something that the SFA Foundation is very focused on. It's about building long-term capacity. And it's not only about building capacity in the hotspots or the easy to reach areas, right? It's not about saying, let's train in Kenya, let's train in South Africa, let's train University of Nairobi. It's about our other countries that also need to be brought to, developed and capacitated, right? So it's about building capacity in our weaker areas, in our harder to reach areas, in our different populations. So it's about, building this long-term vision across the board, linking it to governance. And then the last piece to that that's really important, and I think we'll really fail if we don't do this, is that we ask for accountability, right? It's a tool. It needs to be adjusted. It needs to model. So let's demand, robust evaluations of the systems we are putting out, right? Demand the evidence, right? So we need to pilot these tools really vigorously and be open to the adjustments that they need. So I think that's how you set a local agenda, because if we don't adjust to the changing realities on the ground, or do not show if it's working or not, or the cost or the negative or positive impacts, right? If we don't document these, then it'll just be, Professor X versus Professor Y, Professor, Z saying this or that, so saying I agree or I don't agree. It's really about the evidence of the evidence and really building that case study.
Can I say something?
Thank you so much. I think you raised really critical points. And then I love the M&E system, the evaluation. So we need to put a framework in assessing what is working and what is not working as it relates to, now we are adapting to AI, and then we are adopting AI in our routine system. We need from the get-go to start with a system we are assessing what is working, what is not working, and then the framework. I also like really the framework, and then think on a long-term vision, and then the resource mobilization also you mentioned is also critically important in terms of capacity for doing everything. And the whole approach is also important. You see, we were talking about One Health with different platforms and different levels of capacity as it relates to data, data use and data processing and data analysis, which is AI could be a very good way to connect all these different sectors as it relates to data infrastructure and data systems. So, and then thank you so much for these very good insights. And then last but not least, we will end with our colleague from regional. I take you from the last because I want you to give us a regional perspective as it relates to given WHO Afro's role in the health emergency information management and this, and the acknowledged challenge of data quality fragmentation, and infrastructure deficit across African health information systems. Who are WHO Afro's key strategy to build robust, interoperable regional data ecosystem that can effectively feed AI-driven early warning system for epidemic outbreaks?
Thank you very much, moderator. I think you've made actually my life easy because from your
yeah, I did it purposely to
and
so
also
that you can conclude.
Exactly, and also from the intervention of the colleagues, it makes it very easy for me. So basically, traditional surveillance systems are the backbone of our response, of our surveillance in general. That's something to keep in mind. So AI is not coming to replace that. AI comes in to actually amplify that, to actually multiply those potentials. And that is something to really have in mind. We're not going to rebuild anything from scratch. Number two, you mentioned the potential that we know. So in many ways, AI is going to revolutionize the surveillance on our continent. You mentioned the heterogeneous data sets, having different pipelines that AI can actually quickly cross and come up with intelligence. We mentioned the real-time part of it with the mobile technology that can be used. We mentioned the volumes of the data. For example, since you mentioned the surveillance systems, the IDSR data alone, and when you look at the regional level, we're talking about almost 6,000 districts data. Every week, data comes in. Can you imagine if you have 5 years of data and you're trying to understand what is in there? There is almost no way you cannot do that if you don't have tools like AI. So basically, using machine learning to learn from the data sets and come up with intelligence, basically spotting where the issues are, the hotspots, and where you can actually target your surveillance is where we're going. We don't have enough resources to continue to do routine surveillance everywhere. Of course, routine can go on, but we might think of targeting areas where we know there are more challenges. So that's really the power of AI. And obviously, you mentioned the data issues, challenges. It is true. But that is actually a motivation for us to improve our data collection and also infrastructure. This is also another possibility for us to know that these are needed to improve our surveillance system overall. So really, this is what we're trying to do at regional level. We have started with platforms that collect data from all of the IDSR. They are centralized. We've started integrating data sets. We integrate systems already. We use AI. You mentioned the threshold analysis, which in the past, our member states were actually looking every week to calculate if they have crossed an alert threshold. It's not possible. So we have now tools like AI that can actually pop up and say, well, in your country, in this district, these are the conditions or diseases for which you have crossed the threshold. And it's easy, using such a tool. So really, that is the perspective for that we're trying to put in place.
So thank you so much for this. And I love this, raising the issue of the burden of the data, gathering data. You mentioned 6,000 districts. It's a huge burden.
And then usually people are completely stuck with just, processing the data. And then this time consuming, this limitation, and then AI could really help. And then that comes the issue of now, or the challenge, like you said, how now are we going to foster the capacity building very quickly so that people can start using the data very quickly. And then I will echo that because during for example, the COVID outbreak, I was supporting the Central African region. But when we started using AI, it was way much easier to use the data for decision making and analyzing the data. We just have to train the FETP people on that. And then was very important. The challenge is use the challenge as a motivation. I think this should be now our slogan to push forward AI, taking it as positively a good challenge we can face and then we can address very quickly. I think that's really important to address. And then thank you for all these insights. The second question would be, from WHO Afro's perspective, how can international and regional bodies best support resource-limited countries in West Africa and Central Africa to adopt AI and big data tools for outbreak prediction and response in a way that in both sustainable and strengthen rather than bypasses foundational public health?
Thank you very much. And I think luckily our colleagues, particularly Nikema, mentioned some of his, it started with challenges and then later you actually have solutions. So we need to build things that are really technology appropriate in our context, really. And of course, we have to work with partners to support us. You have to understand our landscape. We have to, for example, you mentioned the offline tools. If you are thinking of a smart algorithm that you're looking for your surveillance in our situation here, perhaps you are wrong. We're looking at very simple tools that can run easily, simple, that can actually do the job for us. That's what we're looking for. So for example, you mentioned the offline. This is of course, if you cannot run your AI on the mobile smartphone, that can be offline. And when you have your internet available, it actually picks it up and synchronize. You have not really done the job. So we're looking at that infrastructure side. We don't need really those big infrastructure you're talking about. We don't have the funds for that, but we'll start with very simple things. And then on the data issue, the ethical parts, we have to care. We have to care about the data, who's producing the data. We have to care about our people, our communities, because this is really what we're trying to solve. The ultimate goal is really to prevent those preventable outbreaks to happen. If you have enough data, we can look, ahead of time and see what's going on so that we can actually predict early. So on your question, really the partnerships is really what we're looking at. Whoever can actually work with us. We are having partners are, for example, looking at weather models to be improved to actually have data beforehand on flooding. If you have a cholera outbreak and flooding is going to happen in the same area, you can already take measures. So 6 weeks ahead of time, you can have this kind of technology to really help you with. And perhaps the last piece that I would mention is the local production. So basically, all we are talking about here, we can develop locally. And I think your example is really a good one. We can develop our own algorithms here. We can adapt. One thing I always mention in terms of using technology, if somebody told you that when they invented the mobile, it was for mobile money, you wouldn't believe. But today, this is really what we are doing with it because of our situation, because of what we really have to face. We are using mobile money more than everybody else. Actually, we are teaching some of the countries about using mobile technology. So, and capacity building is important. The nurses that you mentioned, AI can help improve their capacity really to learn more and even faster. So there is so much that this can actually offer us that when you started, I was afraid you were going to really say, well, this is not going to happen. But then luckily you actually found all the solutions yourself. So I'm really happy for that. Thank you.
Thank you so much, Dee, for these very wonderful insights. I think you will really emphasize that we need local adaptation of this AI, you know, system that is invading our African community. And then we need to put our in place, not to fear AI, but to adapt to its evolution and evolving. And I think that's critically important. So we will allow the audience to ask some questions so that you will be more participative for that. So we'll take a list of 5, and please introduce yourself very quickly, and then if you can be very brief with your question. And we allow 1 question per person so that we will be allowing more people participation. Okay, this one. Okay.
Hello, my name is Caleb Badego-K. I'm representing Intuity Technologies. We're an AI company, so very exciting to be here. One of the things that I keep hearing this entire week in this conference is the need for cross-border communication, data aggregation, and collection, including dissemination of information, whether it's big data, small data, cures, vaccine, surveillance of prevalence of medicine. How do you see AI being a tool for helping organizations like WHO, WAHU, and Ecowas accomplish these tasks?
So who are you addressing your question to?
Everyone.
Wow. So we'll take another question. Let me go this way.
My name is Yahya Sokwa from NCBT. So my question is, thank you for the presentation. It was a very nice presentation. The fact that you've been mentioning how to leverage AI into reducing resource burden that's been channeled into surveillance, which soon become the good old surveillance. So my question is prevention more cost effective or response? And then how can we leverage AI into prevention? And then the third is basically all in one question. So we have a lot of resources and programs channeling into acquiring data on epidemiology, all these diseases, outbreaks. But most of the presentations, I've not seen presentations that actually speak that where we have accumulated data on knowledge, attitude, and understanding of the populace for these pathogens. And then if we can, how can we leverage AI into prevention? Because I believe the prevention is more where we should key in our channel resources rather than response. Because I've been hearing detection, prediction, and response, but prevention, not there in most of the keywords. Thank you.
Thank you so much. Another question at the back over there.
Merci. Je suis le docteur Boli Diop, le responsable de la surveillance épidémiologique du Sénégal. Donc ma question s'adresse à Niki Ema. Je pense qu'il a posé des principes importants par rapport à l'utilisation de l'IA et par rapport au contexte africain. Je pense que la question que je lui pose par rapport à l'IA à notre contexte, est-ce qu'il ne faut pas adapter l'IA à notre contexte pour un peu aussi respecter les principes éthiques? Vous l'avez dit, il n'y a pas de pénétration importante par rapport à l'Internet, mais est-ce qu'au niveau africain, on ne peut pas développer des outils IA qui viennent s'adapter à notre contexte et non le contraire? Donc, cette question que je vais lui poser. Merci.
Merci. Vous passez.
Hello, I'm Simon Frost. I work for Microsoft, and my team is building AI platforms for science. I know there's a mistrust of big tech, but our mission is to empower everybody to do more. And so I wanted to get the views of the panel about how, what should we do in order to help West Africa? Thank you.
What is your question? We missed.
So my team has input into building platforms for AI. So what can we do in order to better help West Africa?
Oh, okay. Thank you. A last question. Guy.
Merci. Merci pour ces opportunités. Je crois que, avec votre permission, monsieur, ma question serait un peu plus de commentaires que de la question. Parce que les questions qui ont été posées par rapport à l'intervention de mon collègue, et particulièrement la question de dernier intervenant, avant-dernier, m'a incité quand même à parler un peu de ça. Je crois qu'on a deux ou trois exemples que je voulais juste donner pour que nous rappelons, nous tous, que ce n'est pas une question de vouloir dire d'adapter un modèle, on n'est pas l'autre. Un exemple concret, quand Covid avait commencé, après les événements d'Europe, nous tous ici en Afrique, on avait entendu le directeur général de l'OMS se préoccuper par le décès, le nombre de personnes qui pourront perdre la vie en Afrique avec Covid. Et tout le monde est préoccupé. Mais cela, ça n'a pas été réalisé. Ça n'a pas été réalisé parce qu'il n'était pas intelligent, parce que les gens qui travaillent avec lui n'étaient pas intelligents. Mais le problème, c'est qu'à mon avis, j'avais eu l'opportunité de faire cette interview une fois où j'ai parlé de ça. À mon avis, les paramètres pris pour faire les prédictions, pour analyser le contexte de Covid à l'époque en Europe, qui n'était pas aussi une maladie grande en Afrique à l'époque, ce n'est pas applicable en Afrique. La population africaine n'était pas la population européenne. Les conditions climatiques en Afrique, ce n'était pas la même condition climatique en Europe. Donc, c'est ça la raison qui a fait que ce modèle n'est pas réalisé en Afrique. Et les gens, certains Africains ont commencé à dire que, bon, parce que c'est les médecines traditionnelles, parce que c'est deux autres choses. Je ne crois pas à ça, mais je crois justement à une réalité qui n'était pas là où la prédiction a été faite. Un autre exemple, quand la Chine a lancé le modèle de reconnaissance, l'utilisation des intelligences artificielles, les Européens eux-mêmes ont commencé à montrer une petite faille de modèle super intelligent d'IT chinois parce que les données chinois qui sont protégées, qui ne sont pas partagées avec les autres, et que c'est ces données qui ont été utilisées pendant des années pour créer le modèle d'IT, de IA, parce que le modèle IA, ça veut dire qu'il doit baser sur quelque chose pour créer le modèle avant d'y arriver. Ne sont pas exactement les mêmes conditions que des autres pays au coin d'Europe. Et c'est là, c'est pour créer un risque énorme pour que le modèle IA chinois ne fonctionne pas d'autre côté, juste à cause de cette différence de contexte là où il est appliqué.
Okay.
Voilà, on a l'IA aujourd'hui qui peut être appliqué, que ce soit le profil épidémiologique pour tout, mais comme Nikema a dit, autant que nous les Africains, on ne prend pas le petit temps d'utiliser la technologie, oui, ce qui est découvert, oui, on n'a pas inventé d'autres choses, mais essayer de l'appliquer selon les hypothèses d'information que nous avons, le contexte dans lequel nous vivons, la circonstance que nous vivons, nous ne pourrons pas avoir une IA qui pourra nous aider à faire les prédictions que nous souhaitons avoir dans les situations d'épidémie.
Merci beaucoup.
Merci.
On va prendre juste, merci beaucoup. On prend juste une dernière intervention avant que le panel ne réponde.
Thank you very much. My name is Théophile Wessou. I am a machine learning engineer, a PhD candidate at the University of Geneva. So I have a question for the panel, actually. I heard about data ownership many times this afternoon. My question is very simple. Who has ownership over the data, and how do we build the system to guarantee that ownership? Thank you.
Okay, very interesting question. So we can start. Maybe I can start with our colleague from WHO answering the question.
Okay, thank you very much. I will try to answer some of the questions that were directed to us. The first question, actually, from an AI company, I would say. AI, no, right here.
Okay.
So this is, you were asking more or less about data integration and how, you can actually help organizations like WHO, others to do that. There is a serious need for integration of data pipelines. We're actually moving away from both silos, parallel systems, surveillance system to more integration, which we now call collaborative surveillance, which involves many, many sectors beyond One Health. So basically, looking at a situation like cholera now, we know that if we have actually had the best or the right model, we would have known that this was going to happen. And by the way, we published a paper 2 years ago warning about that, because we used satellite imagery, everything we could, to say that perhaps some of the floodings that are going to happen around some of the water bodies might impact some countries. And so we are at a crossroad where that integration is critical, because we have to have input from everybody into the surveillance to make sure we actually don't miss anything that might happen. The question on prevention, absolutely. So anything we are talking about here is really to focus more on prevention, actually. We don't want things to happen and run after it, after those things. We want to cease being firefighters, like I mentioned, and become more, forecasters. So you can use the word prevention, we can use the word forecasting, we can use any other thing, but the whole point is to know what is coming so you can take action. And that is basically the definition of prevention. And of course, with all the measures that can go, public health measures that can go with it from the governments. There was a question on Microsoft. This is a great, we are really at the point where because contributions are all welcome. And so we'll have to see, how some of those models can be used. And I think we're already discussing, partnerships with Microsoft actually to see how we can improve that partnership. On the COVID, and I will stop there and give the floor to others. There is no model that can be, any perfect model will not work with our local context, that's for sure. And that your example, votre exemple est tout à fait ça. Il n'y a aucun modèle qui peut dire, même s'il est le plus sophistiqué, et qui va échouer parce qu'il connaît pas, s'il n'a pas pris en compte le contexte local, l'infrastructure, et surtout la résistance de la communauté, par exemple, ou les façons de vivre. Il y a plein d'autres choses. Donc, en fait, nous faisons tous ces modèles, mais il faut les bonnes données pour pouvoir être sûr que ça va donner quelque chose. And then the ownership, the data ownership piece, absolutely. We have to care about data, navigate through those challenges, but at the same time, we want to make sure we can prevent some of those outbreaks from happening. Some data are accessible, the member states actually share. Some are more challenging to use or to share. And these are discussions to happen and have data sharing agreements with the member states, countries, to make sure we don't also go too far away from ethical considerations. Thank you.
Thank you.
Thank you very much for all the questions. I would like to start with maybe just one, because it's addressed most of it, with the Microsoft person and the other company. Earlier this year, we competed for Meta grants to be able to develop a public health AI for Africa. So it's something that we'll be interested in collaborating with you. We didn't get the grant anyway, but we already have the concepts. An AI, public health AI, that will help epidemiologists to work faster and to be able to predict. And we're not thinking of at granular level, we're thinking of at national levels. We're thinking of involving about 12 to 15 countries in Africa to be able to have access to easy or quick detection, quick prediction based on their community data and all of that. So I think it's something that we can explore. Then the issue of data ownership, we all know there is a problem with AI as per data ownership right now. People are complaining, especially somebody like a poet. If you ask ChatGPT to write a poem like Chimaka, he writes exactly like her. Exactly. So that issue is an ongoing conversation, and it is what they say is that they got the data from the public. So there's so much that you can keep right now when it comes to data. And if you want to help our communities, help our countries, we need to make data available. And they have talked about data sharing and having agreements between the countries to be able to share data. I think I'll stop there. Thank you.
Okay, thank you so much. Uzma, Dr. Uzma.
Thank you for those questions. So I'll take the first question combined with the question around trust and data, right? So the answer to all that is like I've been saying, right? It's regional and local AI frameworks led by Africa, right? And the importance of what this does it, if we have these regional frameworks, multiple things. One, it allows us to develop harmonized standards for AI. So it's not Nigeria doing something different from Kenya, right? It's about coordination, but it's also about setting the standards, and it's also about respecting our realities, what the speaker said, right, of our context. If we build a framework that, is African-led, it will reflect our realities. It will talk about, infrastructure needs, building capacity, we need it, right? It'll talk about protecting the vulnerable populations we have talked about. It will talk about building trust, which is very important. It will, ensure, to the data question, ethical and equitable use of data. So again, it's really about governance structures. And I just want to highlight that this is not something that me as Uzma Alam is saying here. It's a study that the Science for Africa Foundation led last year with 34 of the Africa Union member states. We're engaging, stakeholders everywhere from policymakers to civil society with more than, 1,000 plus stakeholders and 300 different organizations. And, this was one of the conclusions that actually was highlighted, and that report is available in French, English, and Arabic on our website. So please feel free to go look at it. Again, it's not something that I'm saying, it's a national perspective. And then to the question from the gentleman from Microsoft. So I will choose to answer that slightly different. I know my two colleagues have here already, offered on collaboration, but I'll ask you a question, right? And my question is, why do you want to help West Africa to do this? Why do you want to help Ecowas to do this? And this is a very important question because it goes back to what we said about agenda setting, right? So if your mission, vision, values are very aligned to what, any one of these organizations do, then it's a very simple formula. It's equitable partnerships. It's not a top-bottom approach. It's not extractive. It's co-creation. It's grounded in reality. It's aligned, and it's resource shared, and it builds ownership and trust. So I think that would be my answer. Why do you want to do it? I think I will stop with that.
Thank you so much. And Nikki Emma for the question.
Ok, merci beaucoup. Et il y a une question qui m'a été adressée et qui concerne l'adaptation de l'IA à nos contextes. Je pense que mes professeurs ont largement répondu, mais je vais quand même dire deux mots. Et effectivement, il ne s'agit pas de consommer ce qui est déjà disponible, que tout le monde a l'habitude d'utiliser. Il faut effectivement créer nos propres modèles. Vous savez, les grandes firmes qui ont développé des solutions d'IA utilisent énormément de ressources pour nourrir ces IA. Et ces données proviennent des plateformes que nous utilisons au quotidien. C'est les réseaux sociaux, c'est Facebook, c'est WhatsApp, c'est TikTok. Toutes ces plateformes qui sont les leurs, qui ne sont pas les nôtres. C'est ces plateformes-là qui leur fournissent les données dont ils ont besoin. Les sites que nous visitons chaque jour, où nous enregistrons nos comptes email, où nous uploadons nos documents, ce sont ces plateformes-là qui contribuent à nourrir leur système. Nous ne pouvons pas utiliser ces systèmes-là comme les nôtres. Il faut donc créer ce qui va pouvoir se nourrir de nos propres données, ce qui va utiliser moins de ressources. Vous savez, rien que cette année, OpenAI, qui est la société qui a développé ChatGPT, compte utiliser environ 8 milliards de dollars, rien qu'en 2025. Vous imaginez ce que 8 milliards de dollars, ça peut nous apporter, nous, dans notre réalité. Donc, du coup, il faut des algorithmes beaucoup plus adaptés à nos contextes qui pourront nous éviter les biais. Parce que si vous utilisez, par exemple, ChatGPT, qui est américain, et que vous lui posez certaines questions, vous n'aurez pas les mêmes réponses que si vous utilisez DeepSeek, qui est chinois. Parce qu'il y a des biais qui sont liés à certaines réalités, et même certains blocages, voilà, qu'ils ont introduits pour ne pas avoir certaines réponses. Donc ça, c'est pour montrer pourquoi et comment il faut adapter donc, et utiliser nos solutions. Mais pour Microsoft, effectivement, c'est important de savoir, de comprendre le calendrier, mais sur le volet technique, si vous voulez nous aider, il faut savoir que nous avons un gros problème de souveraineté de données. Nous sommes réticents parce que nous avons peur que nos données nous échappent, que nos données ne soient plus sous notre contrôle. J'ai vu que récemment, par exemple, l'Union européenne a réussi à avoir Microsoft 365 hébergé en local. C'est-à-dire qu'une entreprise peut s'abonner et avoir ses données dans son entreprise. Ce sont des choses sur lesquelles nous pouvons capitaliser et qui peut énormément nous intéresser. Et ensuite, un autre volet, Microsoft, c'est probablement l'un des outils les plus utilisés par tout le monde dans cette salle et en Afrique de l'Ouest. Parce que nos PC tournent sur Windows, nos outils bureautiques tournent, c'est Office que la plupart des gens utilisent. Et pour vous dire la vérité, ce n'est pas donné. Ce sont des outils qui coûtent cher. Et donc, je pense qu'il y a beaucoup à faire dans ce sens aussi. Mais je pense qu'en capitalisant sur cela, il y a matière à pouvoir arriver à une collaboration régionale, une collaboration sous-régionale. Merci beaucoup.
Thank you so much. I think I will, before we are almost time, maybe we can take maybe one or two questions, but if you allow, yes, no, yeah, I will add to what you already mentioned that for one of the critical issues that was raised is data governance, the governance of data. And then I think we need also to, on both sides, to learn from our mistake. Because if we are not, we are fearing AI and all those kind of stuff, but if you're not failing, you're not practicing, you will not learn from your mistakes. I think we need some assistance in the way that we need to use the data to familiarize with AI so that we will build our own governance system in Africa that is adapted to our local context. This is number one. Number two is, this myth around AI need to be break. because it's very important for people to know that it's just a tool, right, you were mentioning, and then people need to familiarize with this tool. Nikema was talking about algorithm, but how many people know about algorithm as it relates to AI and big data? So we need to, strengthen our healthcare professionals and all people in all those terms, and then how we are using AI in a very simple and practical way, not taking expert only and then training them. I think this will be my addition to what you already said, rightfully. And then for Microsoft, exactly, I agree with the fact that it's on both sides. We need you to help us better use the tool you are addressing, but we need to master our own data. And then the question related to ownership is related also to data governance. Because if we master everything as it relates to our governance of data, we will know what our weakness is, we will know how to strengthen it, and we will know how to own our data. This is my word. I think we are at the end of the session. I would have loved to hear more people because it's a very interesting topic. But I don't know if you can take maybe one or two questions, and then I will just conclude very shortly with what we already. Okay, so I will conclude. Okay, so we've seen that, and then I have to answer the question around the KAP, knowledge, attitude. He was talking about using data, but he didn't see in our presentation data around knowledge, attitude. So I just want to reassure you that AI can be used in any field, social sciences, everything. And then we use AI also not only to analyze the data, but also to train people on the field of social sciences. For example, how to conduct a survey, a KAP survey. If you're using AI, is way easier. So just I want to reassure this, the guy from that. So I will say that in conclusion from this session, the integration of yes, I have my book. Yeah, the integration of AI and big data in epidemic prediction. We didn't talk about much about prediction, but a tool like machine learning has democratized, the modeling. We did it during the COVID outbreak response when we were using modeling and machine learning. So these are very practical tools now that can be used democratically. So AI and big data in epidemic prediction present a significant step forward. But its successful implementation in Africa required a balanced approach, concerted efforts, and careful consideration of the region's specific challenges. So we already all mentioned the different challenges. So now, like the representative from WHO rightfully said, we don't have to fear those challenges, but we need to take it as an exciting challenges we need to address to overcome this issue and burden we are having with this outbreak. And then, like you were saying, the prevention is key. We cannot always run after outbreaks and outbreaks. We need to prevent. And AI is very good in that. And big data, when we use our local context to use our algorithm that will be adapted to our context and going gradually, we can get there to have our own infrastructure in place. But its successful implementation in Africa requires approach, as I was saying, and careful consideration to the region's challenge. This is a complex conversation, And I look forward to hearing the perspective of the panelists as we explore these issues. So now, my last word would be, you vote. Can we have the result from the QR code, and then we have to vote at the end to see where we are. Are you confident that AI is a good thing for predicting outbreaks and then for surveillance system? So I will ask if they can project. So these are the QR code. So you can scan it and then give your opinion. And then we will use this as data. We're talking about, you don't need to conduct a protocol, to draft a protocol, a research protocol, but this is very interesting data we can use to guide us the way forward. All right, wow. So I need to better, we are all on the same page. Who are those who think that AI is really bad for predicting models, outbreak, and then for the surveillance system? Those are against, on who are thinking that this is a good thing, it's a benefiting the system. That's the question. Mm. It's the same. Wow. we confuse you more. No, it's not finished. I'm confident that we will get there. So keep going. Keep supporting. We convince more. Okay. So is everybody okay? Is everybody okay? Yeah. It's likely the same, I think. Yeah, it's likely the same if we but but I'm really happy and confident with the fact that we have shared a lot of knowledge as it relates to AI and predicting models, and then the usefulness or non-usefulness of AI as it relates to surveillance. But this is an opportunity we should take to move forward as it really as African people addressing outbreak in our continent. That will be my last words. And I encourage everybody to move forward, better understanding AI, and then we support each other in this journey for being the next continent that is moving after maybe China forward with AI in adapting AI in their local context, because it will be very helpful. So I will thank all the panelists with this incredible insight they were giving as it relates to this critical topic. And I will really encourage everybody to emphasize and increase networking so that we can address this issue and then this opportunity. Thank you so much.